adapters because I think the MacBook changed over the years.
It did, yeah.
So here's the old one, and then there's the USB-C.
Yeah, that's the one.
Okay, cool. They just sit down here.
Okay.
Yeah, and I can pop up and help you too.
Okay, great.
No
I'm
problem.
not the most technologically literate.
Yeah, hopefully it should be no big deal.
Thanks.
it's a big honor. You're the most sought after topic.
What was that for?
Are you guys the most sought after topic? Yeah, for like the journalists. That's why you guys said. Yeah.
All right, good morning. Welcome, everyone. So I'm Stephen Wong, and on behalf of my co-chair, Dr. Eugene Chang, who's sitting over there, we want to issue you a very warm welcome this morning for our 11th annual ENT In the Desert conference. We're excited you're all here. We have a very exciting program ahead of us, and hopefully the weather will even cooperate a bit. So I know some of you are probably looking forward to doing something outdoors, and while there is forecast for rain today, my understanding is tomorrow will be clear, so tomorrow afternoon will be a great day for you to get outside a bit. As I said, we're real excited about the program we have planned. Just to go a bit over the schedule, I'm real excited to welcome an exciting slate of distinguished faculty, some of the leaders in our field from across the country. We have Dr. Sean Desai, who is a facial plastic reconstructive surgeon from Johns Hopkins. We have Dr. Chris Holsinger, who's a head and neck oncologic surgeon from Stanford. We have David Jung, who's a neurotologist from Mass Eye and Ear. We have Dr. Sunil Verma, who is a laryngologist from University of California, Irvine. And we have Dr. Troy Woodard, who's a rhinologist and skull-base surgeon from the Cleveland Clinic, and he also is the president-elect of our American Academy of Otolaryngology. So really exciting group of distinguished faculty that will be speaking to us. And in addition, we have very proud of all of my colleagues, faculty here at the University of Arizona Department of Otolaryngology. So a great program. We want to give lots of opportunity to interact with all of you, not just during the sessions, but in the breaks and at lunch. The schedule goes all day today, so the morning and the afternoon. Then I want to make sure that you all know about and can come to our reception, which it'll be held next door because we are expecting probably some rain, and so it'll be in the next door room. That'll start shortly after the session ends this afternoon around 6 o'clock and go till 8 o'clock. We have some great food and drink, interact with others, as well as our sponsors, and that'll be a really nice event. So I hope you can all make it tonight. Tomorrow, the session will again start at 7:30, but it will go just for the morning. We will have lunch. It'll be bag lunches so that you can either stick around a bit and socialize, or you can take it with you and do something outdoors. We have a hike that's going to be led by Sonia Romo, and please stop by the registration desk if you're interested in signing up for that. Or you can do something on your own, and we can certainly give you suggestions on certain things that you might want to do if you have other interests for tomorrow afternoon. And then our final day is on Saturday, and again, it'll be starting at in the morning, and it'll end around 12:30, and then that'll close the program. In closing, I want to issue a special thanks to all of our fabulous corporate sponsors. I encourage you to interact with them in the breaks and at lunch and at the reception. I want to just acknowledge all of them, in particular our diamond sponsors, Sanofi and Regeneron, our silver sponsors, Depuy Synthes and Acclarent, KLS Martin, Medtronic, and Olympus. Our bronze sponsors, Castle Biosciences, Fusion Specialty Pharmacy, GSK, Hill Dermaceuticals, InHealth Technologies, MA Medical, NeoMed Pharmaceuticals, and Stryker. Literally, this meeting would not have been possible without our fabulous sponsors, so I really want to extend my personal thanks to them and hope that you can also thank them as well. And then last but not least, I just want to acknowledge my administrative team that just have done a fabulous job putting this together. Sonia Romo, Ann Lilly, Tracy Blades, really please thank them as well for doing as usual. Again, this is our 11th conference, and each year seems to be better than ever. So I really want to give my personal heartfelt thanks to all those who organized. Chris Adams on AV is going to once again, I'm sure, do a flawless job. Appreciate all the work of them as well as everyone else in our department who's worked so hard to put this on for all of you guys. And so without further ado, I'm going to step down, and then we'll have our first session of the morning, which is going to be led by my colleague, Dr. David Chen, who will introduce our first speaker.
Morning, everyone. Thanks so much for joining us. Super excited to be kicking off our conference this year with our session on facial plastics. We have some great talks lined up for you today. So joining us again this year are Drs. Ostrom and Olson, two of my colleagues here in the community. We also have a visiting distinguished speaker, Dr. Sean Desai, who's coming all the way from Johns Hopkins. I'll be giving Dr. Desai a formal introduction before his talk. But without further ado, I'll turn it over to our first speaker, Dr. Ostrom.
Good morning. Thank you all for being here so early. And thank you, Dr. Chen, for inviting me. My name's Janae Ostrom. If you were here last year, I spoke at this conference. I'm a local ENT facial plastic surgeon here in Tucson and former graduate from the University of Arizona residency program. So thanks for having me. Today we're going to be talking about otolaryngology and Ozempic. I took a quick poll from a couple colleagues for a few different topics this year, and this overwhelmingly was the requested topic for today. So disclosures, I have no relevant disclosures pertaining to this talk. I would like to disclose that I am by no means an endocrinologist or a pharmacologist, and I'm not an expert on these medications. I simply wanted to present information that you might find useful in interactions with your patients as these drugs become more mainstream, and frequently I get questions in my clinic about them. So the main players we're going to be talking about today are the semaglutide medications, which include Ozempic, Wegovy, Rybelsus, the SGLT2 inhibitors, which are not as frequently prescribed but also important. Some of them are listed here, and then the other GLP-1 receptor agonists, some of them are listed here. Important to note, there are hundreds of these drugs kind of in the works in different formulations. The ones that are FDA approved here in the US are all injectable versions of semaglutide. A little bit of background on why this might be important to you. The two classes of medications, SGLT2 inhibitors and GLP-1 receptor agonists, are frequently prescribed for diabetes medications. This is important because in 2021, there was estimated to be around 536 million people in the world suffering from diabetes, and this is only expected to increase, affecting about 783 million people by the year 2045. Diabetes alone is a major risk factor for associated cardiovascular disease, stroke, cardiomyopathy, AFib, heart failure, and chronic kidney disease. In 2022 alone, there were over 5 million prescriptions prescribed for GLP-1 receptor agonists for treatment of this disease. There have been many randomized controlled trials regarding these medications' use and diabetes. And throughout all these randomized controlled trials, they have found that other diabetes-related conditions have improved, including weight and obesity, cardiovascular disease, renal disease, and non-alcoholic fatty liver disease. This is important because there are many other diabetes medications out there, but a lot of the other diabetes medications that have been traditionally used actually increase cardiovascular risk, whereas these two classes decrease that risk. These drugs first gained FDA approval in December of 2017. Ozempic is currently FDA approved for treating type 2 diabetes. Wegovy is FDA approved for weight loss if you're over age 12 and obese. It can also be prescribed if you're overweight and have an obesity-related illness. And then Rybelsus is similar to Ozempic, and it's only approved for type 2 diabetes. These drugs have already gained widespread acceptance across the world. Europe and the American Diabetes Association strongly endorse both of these classes of medications to be used in patients with type 2 diabetes if there are additional cardiovascular risk factors. SGLT2 inhibitors specifically have shown a significant reduction in heart failure patients, and GLP-1 receptor agonists have been proven to reduce stroke risk. The European Society of Cardiology, the American College of Cardiology, and the American Heart Association all have stressed the importance of these medications, or specifically the SGLT2 inhibitors in patients with heart failure, regardless of their hemoglobin A1C and if they do not have diabetes. So why are we talking about these diabetes drugs at an ENT conference? Is it because they promote ketogenesis? No, even though they do. Is it because their pro-inflammatory agents are reduced? No. It's really because of their effect on body mass. So how do they work? The SGLT2 inhibitors, or the sodium glucose cotransporter 2 inhibitors, are very simple drugs. These specifically block an SGL2 receptor located in the epithelium of the proximal tubule within the kidneys. These transporters are responsible for about 90% of the glucose reuptake in the kidneys, and by blocking these transporters, the patient effectively has a significant glycosuria. This promotes osmotic diuresis, natriuresis, and this results in weight loss, reduction in blood pressure, and lower hemoglobin A1Cs. As you can imagine, however, they have a little bit of a terrible side effect in that patients with polyuria and high glucose in their urine can develop fungal infections of the GI tract. And this is a common occurrence in patients on this medication. But the risks sometimes outweigh the benefits, especially if you have cardiovascular risk factors in addition to your diabetes. Specifically, their cardioeffective effect is fourfold. It inhibits the sodium proton exchange, which is upregulated in patients with heart failure. They reduce myocardial fibrosis, promote utilization of ketone bodies as an energy source, and stabilize the cell membrane integrity. They're also renal protective because they increase sodium delivery back to the macula densa, and they slow the decline in GFR by constricting the afferent arteriole within the glomerulus. They also decrease fibrosis and inflammation within the kidneys by reducing reactive oxygen species. The main class of drugs that we hear about, though, today are the glucagon-like peptide hormones, or the semaglutide-based medications. These have effects on many organs in the body. This is an incretin hormone that's produced by the L cells in the GI tract in response to nutrient intake, specifically fat and glucose. These incretin hormones enhance glucose-stimulated insulin release from the pancreas, which helps in blood glucose control. And they also stimulate pancreatic islet cells neogenesis and prevent their apoptosis. Additionally, it acts in the hypothalamic receptors to increase satiety and decrease food intake by the user. And lastly, they slow down gastric emptying, increasing glucose utilization in the muscle and adipose tissue. These drugs also have a cardioprotective mechanism in that they reduce macrophage adhesion to the endothelium, which leads to reduced atherosclerotic plaque formation, and they inhibit platelet activity ex vivo. They've also been shown to be neuroprotective and reduce stroke risk in patients who take these medications by about 16%, and this is regardless of the patient's glycemic level. There have been many studies on these drugs in the diabetes population. The STEP study is a larger population that followed patients over 68 weeks, and it was more based on patients who had obesity. And this was a randomized controlled trial that split patients into two groups, either semaglutide use or placebo. And overwhelmingly in the semaglutide group, the cohort had better outcomes in terms of weight circumference, systolic blood pressure, and physical function scores. Specifically, the semaglutide group lost about 14.9% of their weight compared to the 2.4% in the placebo group, and both groups had other lifestyle interventions and coaching available to them. In step 4 of this group, they randomized patients to switch from the placebo to a treatment arm or from the treatment arm to placebo, and they noticed that the patients that switched to placebo slowly did gain the weight that they lost back. So this is important to mention to your patients who are on these drugs for weight loss, that if they do discontinue the medication, there's a strong likelihood that they will slowly regain the weight they've lost back. So all that sounds great, but what's the catch? Overwhelmingly, patients get GI side effects. Mostly this encompasses diarrhea and constipation, sometimes alternating on a daily basis, which can be unpredictable and quite uncomfortable for patients. Nausea, vomiting, abdominal pain are also common complaints. Less likely, patients get headaches, dizziness, and vision complications. Symptoms are very dependent on patient susceptibility, the kind of drug that's used, the titration, and the rate that the dose is escalated. And these are usually mild to moderate, and they may even lessen or disappear over time. Helpful advice for your patients who complain of these side effects are to make sure they're staying hydrated, eat enough fiber, stop drinking alcohol, and then to eat smaller and lighter meals. So you may be wondering, why do I care about this drug? It sounds like it's kind of a double-edged sword. Well, there are some pretty strong implications in surgery and ENT specifically, and I just wanted to make you aware. I'm sure you've all gotten messages from your local surgery centers about the changes for patients taking these medications, specifically regarding the delayed gastric emptying that patients experience when they are on these medications. So the ASA has come out with some recommendations for patients on these medications regarding elective surgeries. For patients on them taken as a daily tablet, they have to stop the medication the day before surgery. If they're on the injectable form, they have to stop the medication the week prior. If a patient has failed to hold their GLP-1 receptor agonist, you have to assume that their stomach is empty and either cancel or reschedule the case or consider an ultrasound of the stomach to evaluate stomach contents. There have been reports of stomach contents being identified in these patients up to 2 weeks after discontinuing a medication. You should also consider endocrine consult if you're worried about their diabetes when holding these medications. And then if a patient shows up the day of surgery with GI symptoms, consider delaying the surgery. So anything else you should know? There has been a lot of talk about the risk of increased thyroid cancers in patients on these medications. And I reviewed most of the studies this talk surrounds, and the answer is maybe there is some real risk. This all stemmed from a study that was originally done in rodents, which have a higher C cell count in their thyroids, and these rodents had a higher incidence of hyperplasia in their C cell, parafollicular C cells. This was dose dependent, and there were some observational studies in humans that did not confirm this risk. However, if you look at the mechanism of how this drug acts within the thyroid, it does make you wonder. There have been no events of medullary thyroid cancer described in this study, but they did a dose-dependent evaluation, and they did have carcinogenic factors observed when the dose was given 8 times higher than the greatest dose approved for humans. Tissue that has GLP receptor expression, like I mentioned, is less in humans than rodents, and the association was with chronic exposure for over 3 years of use of the medication. So you do have to take this slightly with a grain of salt, although it could be a real risk. Interestingly, both obesity and diabetes alone have been associated with an increased risk of several cancers, including thyroid. So that could be one confounding factor in these studies. And all diabetes drugs, when they're first released on the market, are linked to cancers, and then they get slowly disproven over time. So time will tell. More studies are needed if this risk is actually real. There's also a little bit of a bias because these patients are overly surveilled with ultrasounds and biopsies because insulin resistance alone leads them to have nodular goiters and increased nodular disease. So what is driving the increased demand from our patients to prescribe these medications? Really, this stems from a lot of attention these drugs are getting in pop culture and with the media. This is Mindy Kaling. She starred in The Office, a series that was on TV a few years ago, and the Mindy Project, and she's been very outspoken about her use of semaglutide to achieve her now more svelte body. Many other celebrities have come forward recently, Elon Musk, Jessica Simpson, Chelsea Handler, and the Kardashians, which drive a lot of our patients to ask, what you think about these medications. And I don't know if you all have encountered this, but I get questions all the time about Ozempic in my office visits. And I think most of us would agree that her transformation was quite dramatic. And this is kind of what's driving people to be interested. However, there is a downside to this, something called the Ozempic face, which was coined by celebrity dermatologist Dr. Paul Jared Frank. And this is where the rapid weight loss seen with these medications leads to volume depletion in certain areas of the face that really do contribute to a youthful appearance. This can be in the temples, the cheeks, the tear trough, the jawline. As a result, especially older patients can have sagging skin and heavy jowls. Loss of fatty acids can lead to dullness and dryness, and patients are often described as looking gaunt. These are two examples of Ozempic face. These are not taken a long duration apart from each other, but you can see, especially in the older patient in the background, her massive weight loss has really led to advanced facial aging. The younger patient in the foreground, you may think she looks great in both pictures, but I think nobody would argue that she does have significant under eye hollowing and hollowing in the cheeks that she didn't have in her prior picture before her weight loss. They actually did a study, and raters viewed patients after their weight loss as 5 years older pretty consistently across all age groups. So what can we offer these patients as facial plastic surgeons? We have our dermal fillers, fat grafting. There are energy-based devices that can help tighten the skin, including RF microneedling and CO2 laser, and of course, the mainstay is facelift. Also important for surgeons is to consider that these patients may be deficient in essential nutrients, including iron, vitamin B12, fat-soluble vitamins, and protein, which all could play a factor in their ability to heal their surgical wounds. And lastly, I just wanted to make a couple quick remarks on future impacts that you might see with these drugs coming into the foreground. The food industry is likely to be substantially impacted. Morgan Stanley research estimated that around 7% of the U.S. population will be using these GLP-1 receptor agonists by 2035. To put that in context, that's 24 million people eating substantially less food. 60% of patients on these drugs already drink substantially less as far as sugary drinks and alcohol are concerned, with 1 in 4 people giving up alcohol completely. The medical device industry is likely to be impacted. Bariatric surgery has already been on the decline, and related devices such as pacemakers, CPAP, gastric bands, glucose monitors are anticipated to follow. And this also will have effects on the stock market. The Denmark manufacturer of the leading GLP-1 drug is now Europe's largest company. One of the major competitors has a market value of $568 billion, making it the 9th largest company in the S&P 500. Both companies' stock rose over 85% in 2023 alone. So I think that these drugs are kind of here to stay, and you're going to hear a lot more about them moving forward. Some takeaway points. SGLT2 inhibitors and GLP-1 receptor agonists are cardiorenal protective, especially in those patients with diabetes. Their use is going to increase, and they are becoming the first-line therapy for treatments of patients with diabetes on a regular basis. Surgeons should be familiar with their effects, both on the wound healing capabilities of these patients and also for surgical planning. There are many more agents waiting in the wings with increased and broader indications. In terms of their effect on carcinogenesis within the thyroid, for now they're contraindicated in patients with a personal or family history of medullary thyroid cancer or patients with MEN2. And then Ozempic face, you can always treat that by referring them to your friendly neighborhood plastic surgeon. Thank you.
Any questions for Dr. Rosker?
So I looked into prescribing these. but I think that I don't have the right setup for this. One of my good friends is a plastic surgeon here in Tucson, and she has a semaglutide practice where she does, thyroid screening on patients. She does full panels of labs, and she has a nurse injector who manages all her medications. I personally don't, but I've talked to her about her experiences. Definitely, yeah. And in regards to the GI side effects, it really is dose dependent. So a lot of the patients who are on them for weight loss, they start at a much lower dose than you would be started on for diabetes control. And by escalating the weight loss patients much more slowly and gradually, you can really diminish the discomfort from the GI side effects. Say that again? Yes, and for adolescents. Mm-hmm. Okay.
Actually, sorry,
Yeah.
quick question. First of all, thanks so much for that talk.
Sure.
I hear about Ozempic all the time on the news and knew nothing about it, so I know a little bit now.
There you
The reason for holding Ozempic before surgery is it's purely because of the delayed gastric emptying and the risk of aspiration. Is that right?
Yes, that's correct.
Got it. Okay.
Yep. Okay, thank you very much.
So, thanks. All right, so next up we have Dr. Jerry Olson. So Dr. Olson has his own practice, works out of Foothills Dermatology and Facial Plastic Surgery. He's been in Tucson for quite some time now and has been super welcoming to me ever since I started as a new guy here. I've really appreciated sharing patients with you and working with you. So thanks for being here.
Good morning. Welcome. Sorry for the rain. You're a Tucsonan when you look up at the mountains and you're excited to see snow. My practice is a mix of cosmetic procedures and reconstructive. And what I thought I'd talk about this morning is sort of my approach to the patient who comes to me with nasal obstruction after he's been operated or she's been operated on elsewhere. I find this group of patients to be kind of challenging. They're a mix of people. Some of whom have had purely functional procedures, and a small percentage of those people after septoplasty are going to continue to have obstruction. And then there's the rhinoplasty group that may have had obstruction before their cosmetic rhinoplasty that wasn't addressed or developed obstruction secondary to whatever was done at the time of the procedure. So the first thing that I think about with these patients is, frankly, do I want to take them on? There's going to be a section of these patients that are going to be difficult to please. The rhinoplasty patients, even if you're treating just their septum or their functional problems, you kind of have bought their cosmetic concerns as well. Here's a patient on one end of the spectrum. He's 50 years old. He's active duty military. He had an open septal rhinoplasty 2 or 3 years ago. He's an officer. I suspect that I'm guessing, younger ENT surgeon that took care of him suggested that while we were there, let's take care of that bump and let's do a couple of other things. And, he's got a subtle inverted V deformity here. He has residual deviation of his septum. Turbinates are enlarged. He has kind of the spectrum of things we see. I am happy to take care of him. He wants to breathe better. His cosmetic concerns are fine. I'm happy to send that through his insurance company, no questions asked. This patient has had 2 cosmetic rhinoplasties in town. The surgeon who operated on her thought that a cosmetic maneuver for her that would be helpful would be to resect the last 5 millimeters of the caudal septum without additional reconstruction. So she comes in with mom, and you know, she can't breathe, and you know, one of their questions, she's got cosmetic concerns, but one of her questions is, well, how much will the insurance cover this procedure? And for me, the answer is, no, I'm sorry, this is a revision cosmetic rhinoplasty. We're going to address all the things, but I have an issue with sending that through the insurance company. As much as we hate them, I still think this is a cosmetic patient. So those are the ends of the spectrum, and you have to kind of decide, you know, who you're comfortable taking care of and who you're not. So we all know that septoplasty alone is a very effective procedure. The quality of life scores in multiple studies are great. Nose scores, a vast majority of people have improved dramatically. But in this study in otolaryngology head and neck surgery from 2016, this was a multi-center study, so there were 14 or 15 different surgeons involved, and they found 6% of those patients said they were no better at all. So, you know, there's a chunk of people who are going to come back, and you know, you look to see what you can find and what can be fixed. You know, there's some patient-related factors, you know, allergy, certainly, age, indeed. You know, and then there's things you can see on exam, residual deviation, turbinate hypertrophy, et cetera. Occasionally a scar between the turbinate and the septum, nasal valve issues. But what's always in my mind when I see these people is that some of those patients are not going to be happy. And the guy I think about, it's a guy, and he's measuring every breath through his nose. I mean, it's what he thinks about all day long. And you know, that patient, I just run away. I say, Dr. Chen at the U? No, I'm just kidding. So I don't, you know, I don't have a lot to say about this. You know, if there's a scar between turbinate and the septum, it's easy enough to fix that. In the past, what I've done to prevent them from scarring back together was to use absorbable packing, thinking that that would give enough time to let mucosa heal and then not recur. But I saw some scar back, and so now what I do is use this thin silastic sheeting. It comes in a 0.51 or 0.25 millimeter thickness. I also use this for septal perforation repairs. People tolerate this very well. For septal perforations repairs, I've left it in up to 5 weeks. Unlike a Doyle splint, you're not leaving that in that long. But people don't mind this so much. And I don't use stents after septoplasty, rhinoplasty routinely, but if I need to put something in, this is what I use. For residual deviation, I mean, there's nothing I'm going to tell you about going back into a septum, but often it's the caudal septum that doesn't get addressed. It's this patient who looks like this. There are several techniques for treating that initially or revising it. My go-to is to do a limited open rhinoplasty approach, expose that caudal septum, and just remove the deviated segment. Now, if you do that at the primary rhinoplasty, you've got cartilage to work with, but if the septum's been operated on and there's nothing there that you can remove safely, then I go to the ear. Now, the problem with the ear, of course, is that you've got conchal cartilage with a curvature to it. What I do with that is I take the cavum or cymba and remove it and then bivalve it and sew it on itself. Now you've got a slightly thickened strut, but it's straight. And then I just do an open approach. This is a different kind of patient, but this is my photograph of how I put that in there. And that's worked well for me over the years. Again, if you've got straight septal cartilage, then it's easy. I just think the other procedures, the swinging door or the cocking suture, which is a horizontal mattress suture to sort of bend it back in a position, those have just failed routinely for me. So my other thinking about after septoplasty is that if there is a generous resection of the septum, this can change the relationship between the upper lateral cartilages and the septum. When I was a fellow many years ago with Calvin Johnson, it was his observation that after he had done his septal resection for grafting that the mid-dorsum would drop. And so we looked at 19 patients, and we used this device on the left called the projectimeter. This is still around. Anthony Products carries them, and you know, it's a crude tool for measurement. But what we did is we measured Rinion, anterior septal angle, and then a midpoint in between before and after a septal resection. And in 83% of those patients, which was like 17, we found a significant drop of the septum. So you could certainly argue that the measuring device was crude, but nobody gained height. And you could also wonder, well, does it really matter much? And I think occasionally it does. I also did 2 cadaver heads during that same study, and there was a little reduction in the height of the mid-dorsum in those patients as well. This is a device Rick Davis in Florida has developed. I've never seen it in use, but I think it's a step above in terms of accuracy. You know, the use of these devices is to measure your points during rhinoplasty to see how much you've lowered, you know, this bit or that bit. So this was the sort of typical cartilage resection that was done when I was a fellow because he wanted grafting material. You know, I don't typically remove as much here, and that might have influenced our results in this study. And probably most of us for doing routine septoplasties are not taking out that much cartilage. But, you know, this is a patient that I saw from a very good surgeon here in town who underwent just a routine septoplasty, and this is the saddle nose that she was left with afterwards. Her septum was intact, there wasn't a perforation. She's obviously going to have issues with obstruction. So it does happen. Here she is after reconstruction. That's contral cartilage they used to reconstruct her there in her frontal view. And then, you know, I threw this slide in there not because it has anything to do with nasal obstruction, but it does have something to do with nasal reconstruction. You can see the patient in the background, or her nose in the background. She's got a severe saddle nose deformity. You know, we know about rib, we know about taking, you know, cartilage from the ear. This is a bone graft from the mastoid area. You know, for somebody who doesn't want to take bone where there's dura, and doesn't want to go to the rib. For me, this has been a go-to move for a long time, and there she is reconstructed. So it's just, I just point out that it's one more donor area for a saddle nose repair. So if I've determined the patient needs an open approach, I'm probably going to do everything because I find it difficult to decide, you know, is it the lateral crura, is it the angle between upper lateral cartilage and the septum? So if we're going to do an open approach, they're going to get all these things. Spreader grafts, a flaring suture, which has been very dependable for me to improve nasal airway, strut graft, batten grafts, and a domal equalization suture. I'll talk about that one a little more at length. All these patients I try to examine with a modified caudal maneuver ahead of time. And this might be the major determinant for me if I'm going to operate on them. If I lift up on that lateral wall of the nose and they say they're not better, then I don't think surgery, at least in my hands, is going to fix them. You know, I want that patient to say, oh yeah, that's great. So just some diagrams. We all know about spreader grafts and batten grafts. My experience over the years with batten grafts, especially in older people, is that they don't really make that lateral cruce really stand up. And I suspect that part of that has to do with the age of the cartilage. You know, you take contral cartilage out of a 20-year-old, you can bend it straight, it snaps back, it's incredibly elastic. Sadly, someone my age, you take it, you bend it, it cracks. It's depressing. This is a flaring suture. I hope this shows up well. So after I've done spreader grafts, I dissect along the lateral edge of the upper lateral cartilages and expose them, and I take a fluoroproline and in a horizontal mattress suture, go from one side to the other and tie them in the midline. That takes that lateral, the upper lateral cartilages and flares it out nicely, and you can look right in the table and see how much better the airway looks. For me, everybody gets this if we're doing an open approach. And then the final thing is this domal equalization suture. It's probably been described by others. I know about it from Roland Daniel, who is a retired plastic surgeon in Southern California. Dean Toriumi talks a lot about this suture as well. Mostly we talk about this for cosmetic reasons. It brings the lateral cruce into a cosmetically better position because you're cephalically rotating the caudal edge of the lateral crura. But that that edge is in the airway too, and in some people you can look in the nose and see it impinging on the airway. So the suture starts here, the undersurface of one dome, comes out, comes to the other dome, and then gets tied here. And you can see, I think, as it's tightened, how that the inferior part of the crus is rotated cephalically and out of the airway. It's also, you know, cosmetically better too, but that gets added to every patient that I operate on through an open approach. So here's that patient I showed you before, and she's had all these things done. We're able to get her projection back out where it should be. You can note how we project her lips as well. I did not do that. And then from the basal view, airway's better, cosmetically she's better. So that's the hard fix, is the open approach. There's two easier fixes: Latera implant and then nasal valve suspension. I haven't done a Latera implant in a long time, mostly because everybody else is doing them. Everybody in this room has probably had experience with Latera. When we first started doing them, I was very enthusiastic about it, and then, like everything, it kind of shakes out to who it works for and who it doesn't. I think if it's a dynamic collapse of the lateral crura, and the position of it is anatomically correct to start with, and it's just a matter of stiffness, I think Latera works. I think if you're hoping that Latera implant is going to lift that cartilage into a better position anatomically, I don't think it does that. I've also seen, especially in women, where the implant is placed along the nasal sidewall, it's visible and palpable. When I was doing these more frequently in female patients, I would extend it more to the piriform area. It seemed to work as well or not work as well, but it certainly didn't have that palpable ridge under the nasal bone. And then the last thing is nasal valve suspension. So I've done this operation for a long time, and it works almost every time, and the complication rate is very, very low. So the first description of this, I think, was in the late 90s, and I don't recall the author. Michael Friedman wrote about this modified approach in 2003, and this is really the basis of it, or the basics of it. So an incision of the orbital rim here, a MyTech bone anchor is placed, a suture's tunneled through soft tissue to grab lateral crura and the upper lateral cartilage, and then lift it laterally and superiorly. It's an easy thing to do. So when I examine the patients, I'll usually examine them before they've gone off to sleep or in the pre-op area, and make a little mark intranasally where I think their maximum collapse is. They go off to sleep, we numb them up. There's an intranasal incision where I make a small cut in the mucosa where I want my sutures to come out, and then a dissection to the orbital rim. Placing the MyTech bone anchor is quick and easy. There's two needles that come with the MyTech bone anchor. In Dr. Friedman's article, he talks about a specific curved needle that he uses, that he says you have to use this needle. It didn't work for me. I use a Keith needle, and I put a little bend in it, and I'll show you the next slide. So there's where I mark the patient intranasally, and that's where I'm going to make a mucosal incision. This is a patient who had a reconstructed ala, so this is, forehead flap ala. She's got a narrow angle of upper lateral, and I don't know any other way to fix her. So this is the needle I talked about. I put a little bend in it. It gets tunneled down through the nose. You pull it all the way out, and then back through, and then back up. And usually at that point, I'll have my assistant lift up slightly with a freer just to hold the cartilage in the position where I want it, and then I tighten it down. Here's another patient, external valve collapse. You can see the narrowness here. This is immediately after we're done with a much improved airway. I did this week. It takes 10 minutes. So what's the catch? So this procedure no longer covered. So when Latera implants were introduced, it was billed under the 30465 nasal stenosis code. That didn't last. So there's a new code for Latera. I'm sure you all know this. At the same time they created a new code for Latera implants, specifically CMS said this procedure, the suspension, no longer covered under that code, so it's an unlisted code. So you can still do it, but it's an out-of-pocket procedure. And some patients are willing to pay that because it really does work. But it's a shame because this procedure has been around a long time. And in that time I had some fail. I used to put a proline suture on the MyTech bone anchor because early on I had a patient get infected and I thought it was the wicking effect of the braided suture, it's an ethibond, that allowed bacteria to travel into the cheek. I had the proline suture break in a couple patients over the years. I went back to just using the ethibond, but now I make that little window of mucosa inside the nose and then close the mucosa over it. I've had no one get infected since then. I had one patient several years ago complain of some numbness laterally, not the entire infraoral nerve, just a patch, but that's just one person. So at any rate, I continue to offer it to patients, but it's a long conversation about how it's not covered and how you're going to have to pay for it. Some people are on board and some people not. Anyway, that's all I have. This is a picture from Dr. Kang's old office. Thank you, Dr. Kang. We just moved to that office. Thank you very much.
Thanks so much, Dr. Olson. Any questions?
At Weaver in Seattle had used modified the suspension stitch by just drilling into the piriform bone, so you're not having to mess with the long stitch going potentially cheese slicing or whatever through the skin. And
No, I have a friend in town who has talked to me about doing it that way, but I might consider that now. I mean, up until the last year or so, the MyTech bone anchor just was simple, worked well. But now that it's a problem getting it covered, I might think about alternatives, and that's one of the things I might think about. I'd be a little concerned about tunneling the suture through the bone. I mean, with wear and tear, will that, that little bony edge cut the suture?
I do a 2 millimeter little hole. You got to be 2 millimeters from the edge, and then I take like an 18 gauge needle to help pass the stitch through it because it's hard to find the hole.
Yeah, right.
But it works pretty well. It's about the same length of time it takes to do
Yeah,
that.
no, I think that's a reasonable thought.
Along the lines of Laterra and things that many people are now doing, are you a believer at all in the Vivair, or even that a septal swell body even exists?
I have zero experience with it.
I was wondering if you have ever used any if you have a subtle defect or something, any fillers on the nasal.
I have. Long ago, when I was a fellow, we would put a drop or two of liquid silicone, medical grade silicone. It worked amazingly well, and it was permanent. More recently, a few years ago, I put a little filler, HA filler, in the nasal dorsum. And as I was putting it in, the entire nasal dorsum and tip blanched. My heart rate went to about 180. About the time my heart rate got back to normal level, it had resolved, and I decided that was the last time I was going to do that. I've seen some patients with tissue loss after filler in the nose. I mean, we're probably less likely to get that than at the med spa, where we're going to put it down on the periosteum or perichondrium. But I've seen some patients treated at medical spas that have lost tissue. I suspect it was higher up and they got it in a vessel, but I don't. If I see a little defect like that after rhinoplasty that I think I can treat easily in the office, I take a little bit of conchal cartilage and through a closed approach, slide it in there. I'll make a pocket, I'll do an intracartilaginous incision, mark out where I want it to go, slide it into position, and to hold it there, I'll pierce the skin with a 30 gauge needle so it's held in a position, and then pull the forceps out. That's, for a touch-up, that's worked well for me.
Any experience with a butterfly graft?
nasal valve collapse?
No. You know, Stephen Goldstein, who was here for many years, used a lot, I think with pretty good success. Like everything, you know, it doesn't work every time, but no, that's not something I've used.
I can comment on that a little bit. If that's okay. Yeah. So I do use butterfly grafts from time to time. I trained in Oregon with Tom Wong, and he describes a modified butterfly graft that's narrower, so it's less likely to show up through the skin, and longer, so it actually rests on the piriform aperture. I think it's pretty effective for a lot of patients for internal valve collapse. The one downside is that I think in some patients, especially with thinner skin, it does create a little bit of supratip fullness. That's my go-to technique for patients that I'm purposefully increasing their projection, increasing their rotation a little bit. So sometimes they end up with almost a little bit of an iatrogenic saddle after rhinoplasty. And that butterfly graft serves the purpose of both improving the nasal valve collapse and also aesthetically alleviating that little bit of depression. All right, thanks so much. Yeah. All right, so the title and scope of my talk today, nasal reconstruction, is very broad, but that's intentional. If you had told me when I was 18 years old that I would spend 4 years in college, 11 years in medical training, and hundreds of thousands of dollars in tuition, just so I can spend most of my time doing surgery on noses, I probably would have become an engineer like my parents wanted me to be. But alas, here I am. And truth be told, nasal surgery is something that I love. It's pretty amazing. It's a lot of fun, and I wouldn't have it any other way. So today's talk is meant to be kind of a comprehensive, cross-sectional glimpse at some of the different facets of nasal reconstruction that I encounter in my practice. This talk is broken up into 3 parts. So reconstruction of nasal defects, external defects from cancer and trauma. That'll be the bulk of the talk. And then I'm going to go into reconstruction of both saddle nose deformities as well as a little bit on septal perforations. And we think of these as very distinct surgeries, but at the end of the day, it's all surgery to reconstruct the nose. And I think, as you'll see, there are a lot of overlapping considerations. So I'm going to start with talking about reconstruction of external nasal defects. And we're going to start with something super easy. So this is a patient who did not have cancer. He had 2 benign moles that he wanted removed. And so we excised those. They left 2 about 6 millimeter defects on his nasal tip and his alar crease. So the nasal tip defect closed pretty easily with just a simple advancement, and then the alar crease being one of the concave parts of the face that heal really well with secondary intention, we actually just left alone. And so you'll see after a few months, interestingly, I would argue that that alar crease scar that I basically did nothing to looks about the same, if not a little bit better than that nasal tip scar. And I think this just goes to show how, although it's very limited real estate, the location that you're working on the nose really can affect the repair options and considerations for scarring and scar contracture. I think both of these scars are going to respond really well to tincture of time or possibly a PDL treatment to reduce the erythema and some fractionated resurfacing to improve the contour. That's something that he's deciding on. But nevertheless, whenever we're working on the nose, the location of a defect really matters. So as we're probably aware of, the upper part of the nose is very thin, elastic, mobile skin. Defects in these areas are relatively easy to reconstruct. And then lower down near the tip and the ala, you have very thick, sebaceous skin that's it's very fixated to the underlying adnexal structures and not very elastic at all. And so these pose more reconstructive challenges. So in this patient with a seemingly innocuous, basal cell carcinoma, it's biopsy proven, ended up getting Mohs surgery, and the defect came out to be a little bit larger than she was expecting. And so as I mentioned, any defects in this area, the challenge is to be able to mobilize enough tissue from the surrounding area that's pretty rigid, not elastic, in order to reconstruct that defect. And so kind of the classic local tissue rearrangement we use for defects of the lateral nasal tip like this is a bilobe flap. And so this is a flap that's designed to essentially walk down elastic tissue with more give from farther up the nose, walk that down sequentially in 2 steps into the defect. This is the flap after it's been raised, and so the first lobe is designed to be about the same size as the defect itself, and then the second lobe of the bilobe flap is much smaller, and that is designed to reconstruct the secondary defect from the first lobe. And we're able to do that because the skin up here is just stretchier, it's more accommodating. This final defect here ends up getting closed by advancement. So this is what it looks like when it's all done. I'm sure we've all seen these before, and this is 1 month post-op. You can see there's obviously still some post-op erythema, but she's maintained good symmetry, and the scar is healing well. One of the biggest questions comes up when we're doing nasal reconstruction is, when do we need to do a forehead flap? And so the traditional teaching is that if you have a larger defect defined as a defect greater than 1.5 centimeters, of course this depends on the location, you need to start thinking about a forehead flap. But interestingly, this paper came out a couple years ago comparing outcomes of 2-stage interpolated flaps. So these are forehead flaps and 2-stage melolabial flaps. Comparing those to single-stage local flap techniques. And they specifically looked at defects that were what they called intermediate in size, so those measuring 1.5 to 2 centimeters, to 2.5 centimeters, things that would generally be considered in the range of forehead flap territory. And interestingly, they found that when you look at it across the board, the single-stage local flap techniques actually had better aesthetic outcomes for defects all across the size range. And there was lower likelihood of needing revision procedures or needing a post-op Kenalog injection. And so this paper came out shortly afterwards, about a year ago. This is a bulletin published on the AAO website. And it's authored by some prominent names in facial plastics. It's called Nasal Reconstruction, Not All Roads Lead to the Forehead. So I think all of this, the take-home message is not necessarily that forehead flaps or interpolated flaps are bad, but I think within the intermediate size range of defects that we see, there's still room to consider all of the other reconstruction techniques in our toolbox before jumping directly to a forehead flap. That said, there are defects out there that do require forehead flap, and that ends up being the best option. And so I think this is one of them. This is a patient with a not large, but a full thickness total defect of his left nasal ala. This gentleman had Mohs surgery years ago. For whatever reason, did not pursue reconstruction, and ended up bothering him, and later on he came in to see me. So one of the most important factors here is, obviously, we're thinking about how to reconstruct the external lining, the skin, and we need to reconstruct the cartilage framework underneath. But we also need to figure out how we're going to rebuild the internal lining of the nasal vestibule. And so you essentially have a few options for these cases. You can use a mucosal flap from within the nose. You can basically take tissue, skin from the surrounding area, turn it inwards, and have that skin become the new internal lining. You can fold the distal edge of the forehead flap so that it's essentially double-sided and serves as both the external and internal lining. And you can also pre-laminate the forehead flap with a skin graft and then delay it so that essentially becomes a double-sided flap. And so this patient had really nice nasal mucosa, never had surgery in his nose, so I decided to go with a septal flap. And these are described as flaps that are pedicled anteriorly along the nasal sill and the base of the columella. It's perfused by the septal branch of the labial artery. And so you raise these flaps from basically posterior to anterior, kind of fold it on itself to recreate the arch of the vestibular lining. And that allows you to then rebuild the cartilage framework of the nose on top of that vascularized tissue using cartilaginous grafts. So this is what that flap looks like in real life, and then with that cartilage framework in place. So for the external lining, we obviously used a forehead flap here. We used a template of the contralateral ala, the normal side, to design this forehead flap. And this is him about 9 months out, so you can see we have pretty good symmetry. Doesn't have any collapse through the side. He can breathe through his nose. And so he was pretty happy with that result. A brief historical aside on nasal reconstruction, which is something that I find fascinating. The residents are smiling because they've heard this ad nauseum. So feel free to tune me out, guys, for the next 3 minutes. So the history of nasal reconstruction, forehead flaps, actually goes back way farther than you might think. In the ancient world, one of the punishments for crimes like adultery and theft would be to have your nose cut off. So this would be kind of a mark or stigma that you're, a thief or an adulterer, and there are these people walking around with no noses. So there's a market for surgical reconstruction of the nose. Interestingly, the first written account of a surgical surgery to reconstruct the nose was a cheek flap that's described in Indian medical text from 600 BC called the Sushruta Samhita. And then the pedicled forehead flap, which is very similar to the exact procedure that we perform today, is known to have been performed as early as the 1400s and possibly even before that in India. And early on, this technique was actually passed down verbally within clans and families. And so these were kind of closely guarded family secrets. Just for reference, this is around the time of the beginning of the Italian Renaissance, so pretty early on. The surgery didn't really reach kind of the Western world until the late 1700s, when British colonialists in India saw the operation being performed and decided to write about it in this article called "A Curious Surgical Operation" in the Gentleman's Magazine. And then just a few decades later, Joseph Karp, a British surgeon, is credited for performing the first successful paramedian forehead flap in Europe. And interestingly, apparently this surgery was performed in 15 minutes without any anesthesia of any kind, which is generally not recommended nowadays. This is a lady who I saw with a defect involving the cheek and the nasal sidewall. Apologies for the blurry picture, but this is actually a full thickness defect. So this is going all the way through her nose, and what you're seeing here is actually her septal mucosa inside the nose. And this is how she came to see me with a xeroform bolster inside the defect. So for these full thickness defects, you can also use a septal flap to reconstruct the internal lining. These are designed a little bit differently. So this septal flap, instead of being pedicled anteriorly, is pedicled dorsally. And so what's done is you make kind of an incision along this dotted line, leave the pedicle along the dorsum. And so here's the flap right here. It's actually passed through the septum, so you make a fenestration in the cartilage and the contralateral mucosa, and you raise your flap and you pass the whole thing through to the other side of the nose. And the purpose of doing this is so that the raw surface of this flap, which is normally in contact with the cartilage, is facing the defect, it's facing outside. And the normal mucosalized surface of the septal flap is facing the inside of the nose where you want it to go. You can put a septal cartilage graft on top of this. And so this is what it looks like. We typically raise these flaps endoscopically. So this is a flap. After it's been raised, so right along here, you can kind of see the cut tissue edges of the septal mucosa. This is septal cartilage right here. And then right along here is that fenestration through the cartilage and through the contralateral mucosa. This tissue here is basically the base, the pedicle of that septal flap, right before it goes through the septum to the other side of the nose. From the outside, this looks like this. So you have your, this is essentially perichondrium right here. Reconstructed internal lining with septal cartilage graft to recreate the framework. On top of that, this patient also had a medial cheek component of the defect, so we did a cheek advancement flap. This is everything as we're putting it together. We make, again, a template of the defect using the contralateral normal side of the nose to design the forehead flap. And then here the cheek flap as well as the forehead flap has been inset. This is her a couple weeks after surgery. She looks super beat up and her eyebrows attached to her nose, so she's not happy. But fast forward a few months, and she's healed up quite nicely. And so you can barely see that forehead scar from the donor site. The pedicle scar has blended in nicely with her native glabellar creases. A little bit of pin cushioning along the edges of this flap, but overall, I think she kind of regained a lot of normalcy in appearance despite her defect. This is a patient with an infiltrative basal cell carcinoma of the dorsum. So she actually came to me between stages of Mohs surgery. They had done a few stages, could not get negative margins, and so I saw her to talk about surgical reconstruction before she went back to the Mohs surgeon to complete the resection. So this is what it looked like when I first saw her, and then when she came in after Mohs surgery to the OR, the defect got a little bit bigger. Hard to tell from this photo, but this is also a full thickness defect. So this is the remnant kind of dorsal edge of the septal cartilage, part of which has been removed. And then on either side of that, there's actually an opening into both sides of the nose. It's hard to see because the whole nose is actually collapsed inwards. She's lost all of the structural framework of her nose. So she actually has pretty bad nasal obstruction resulting from that collapse. And if you look at her nasal tip, you can see in the profile view that the angle of her tip, the rotation of her nose is totally changed. Right? So her tip is kind of drooping down because there's just nothing holding it up anymore. So for her, again, used nasal mucosa to recreate the internal lining. And so there were two sides to this. This time I used septal mucosa for one side, and then I actually used an inferior turbinate flap. Basically, you kind of break out the inferior turbinate from back to front, pull it out of the nose, leave that pedicled anteriorly, remove the bone, and then you have a mucosal flap that you can use that's vascularized. So I reconstructed the internal lining. I took septal cartilage as well to rebuild her L strut as well as her dorsum, and then auricular cartilage to reconstruct the lateral support for her nose. For the external lining, again, made a template here of the defect and traced that out onto the forehead. This donor site defect obviously ended up being too wide to close primarily. So for these patients, I let them heal by secondary intention. This is a piece of Integra. It's a bilayered collagen matrix that I use to kind of accelerate the granulation process. And so, the classical forehead flap is done in two stages. The first stage, you raise the flap, you thin it out to the desired thickness, and then you put it down on the nose. And then in the second stage, you divide the pedicle. So Fred Mennick describes the three-stage forehead flap, where you add an intermediate stage. Basically what's done in these cases for larger, more complex nasal defects or defects involving multiple subunits, you add in that extra stage whereby in the first surgery, you raise up the flap, you keep all of the frontalis muscle attached to the undersurface of the flap. You don't thin it out at all, and you just inset it as it is. It's super bulky, it's a big blob, doesn't look like a nose. And then you bring it back a few weeks later, and then you raise up this flap in the subcutaneous plane. And how Mennick describes this is everything underneath now has the fat, the frontalis muscle, and the underlying cartilage construct has healed together into kind of one structure. And you can essentially carve that like a bar of soap to achieve the appropriate contour of the nose. And so this is the intermediate surgery, kind of re-raising of that flap. And that process of delaying the thinning of this tissue by a few weeks, it's essentially a vascular delay. And for whatever reason, in doing so, you really improve kind of the long-term kind of robustness and skin texture of this flap. You really reduce wound contracture. The skin itself just looks a lot better, and it looks more like a native nose. For smaller defects, you obviously don't need to do this because it's not that much of a vascular compromise to thin out a flap. But if you were to kind of thin this out all the way to like very thin subcutaneous tissue in the first stage of surgery, there's a good chance that you could kill at least the distal part of that flap. So this is her after that intermediate stage. It's super swollen, so you can't really tell that the contour is that much better. But fast forward, I think this is 3 months post-op. You can tell that you can still see the margins of the flap, and there's still a little bit of color and texture mismatch, but the skin here really matches the native skin of her nose and face quite nicely. For being critical, I was pretty bothered. She has a little bit of medial brow ptosis from this donor site when we divided the pedicle. And I offered to kind of bring this back up, but she decided she had enough surgery for the time being. If you notice, her nasal tip is kind of back to its normal rotation, right? She no longer has that ptotic tip after the Mohs resection, so we've kind of restored the tip support and the proper rotation to her nose. Another patient with an infiltrated basal cell of the nasal tip, pretty large defect involving the entire tip, some of the dorsum and the side wall, some of the ala on both sides. The soft tissue triangles are gone, and the entire columella is gone too. And so This is actually, part of this defect is, again, full thickness because the inside of the alar rim here, the vestibule, is part of the defect that's absent. So in this case, because this is the only internal lining that needed to be reconstructed, I essentially plan to restore that internal lining just with the distal edge of the forehead flap. So when we're designing our templates, we basically leave additional tissue here to be folded into the nasal vestibule for the internal lining. This lady had a pretty wicked septal deviation, and so I did a septoplasty on her at the same time, and that gave me cartilage to use for a Collie-Muller strut graft and a nasal tip graft. So actually some concepts from rhinoplasty that we're using here to reinforce the rigidity of her nose so that it can withstand a lot of the contractile scar forces of this big reconstruction. So we want it to look good, not only kind of in the immediate months afterwards, but for the rest of her life. This is after the first stage of surgery. You can tell, again, very, very big, bulky nose. We haven't thinned this out at all. And then at the intermediate stage, I actually made my incisions right along the planned location of the actual alar rim. And so part of the flap that I had inset, I actually left behind. That's the part that's reconstructing this nasal vestibule internal lining. So I raised the flap with some new incisions, thinned it out to the appropriate thickness, and then now that the internal lining is repaired, we're able to put in auricular cartilage to, again, reconstruct the lateral aspects of her nose, of her nasal framework. And this is her, I think, also 3 months out from surgery. And then finally, a patient with very aggressive, rare eccrine carcinoma of the nose, underwent Mohs surgery and basically had essentially a subtotal external lining defect. So again, we designed a very large forehead flap to resurface essentially the entire external lining of her nose. And the thing that I want to point out here is how well these donor site defects heal. So this is obviously granulating pretty well, but pretty big hole in the forehead. And this is 6 months later. You can see how much it's contracted. So in doing so, it's pulled in hair-bearing scalp from the surrounding area. And, she normally wears bangs, so kind of had her pull her hair back for this photo. Even with her hair up, it's hard to tell that she had this big gaping hole in her forehead. You'll also notice that she had a really hairy nose, right? Because we needed enough tissue to bring everything down. There are a few ways to deal with that. So you can use laser hair removal if you have darker hair. For lighter hair, if you have gray or white hair, lasers don't work quite as well. So electrolysis is an option. Because of the nature of this patient's cancer, she actually needed post-op radiation, and conveniently that removed all of the hair from her nose. So we didn't have to worry about any of that. All right, so I'm going to talk a little bit, change gears just slightly into saddle nose deformities. So these can be pretty challenging deformities to reconstruct. There's a variety of different etiologies. So how much scarring or deformity there is of the soft tissue, whether there's any nasal septum left or septal cartilage you can use, varies quite a bit between patients. And the goal here is similar to what I touched upon earlier, which is you want to create a result that's aesthetic, but can also withstand the forces of scar contracture over time so that you have a stable result that lasts for the rest of the patient's life. Lots of different great techniques out there for saddle nose repair. My preferred technique is to use a solid rib graft for the dorsal reconstruction. I've done this both with autologous and cadaveric rib cartilage. The back end of this is basically a standard dorsal augmentation graft. It's kind of a canoe-shaped piece of cartilage. It's tapered pretty aggressively along the edges to kind of smooth out the contour. And then the caudal end of this essentially has two prongs, and what this is designed to do is just basically fit in a tongue and groove fashion to a caudal septal reconstruction graft, also from rib cartilage. And so this is essentially both reconstructing that septal L-strut superstructure, as well as the contour of the dorsum. The lower lateral cartilages are put on tension, they're suspended to this construct, like so. And so this is her post-op result a few months later. You can tell that we've, apologies for the blurriness of this photo, we restored the contour of her dorsum, but also her nasal tip definition and her projection. Frontal views changed as well. And it's 3/4 view. This is a really poor lady who had osteomyelitis of her nasal septal bone for unclear reasons. She presented for months and months with just intractable pain. And over the course of weeks and months, her entire nose just collapsed. Couldn't really figure out why until she ended up getting a bone biopsy, an intranasal bone biopsy that diagnosed osteomyelitis. So she ended up getting treated with long-term IV antibiotics, cleared the infection, her pain went away, but she was left with the saddle nose deformity. So similar technique. There's still some residual saddling right here, but overall much better contour, much more normal appearance to her nose. And then another patient with a history of really heavy cocaine use in the 80s, which is a common story. Completely absent structures inside her nose, no nasal septum at all. You can use the same technique to rebuild that dorsum. And the last thing I want to talk about, very briefly, is reconstruction of septal perforations. And so, this is kind of really switching gears. It's totally different surgery. But again, there are considerations and overlap with other aspects of nasal surgery that we do. And so, in residency, we learned about kind of dozens of different ways, techniques to reconstruct perforations. The challenge I've always had with a lot of those techniques, particularly with the local flaps, rotational flaps, bipedical flaps, is that septal mucosa is pretty awful in terms of how much give it has. Every time you raise it, the mucosa contracts. There's always less of it than you think there will be. And it's a challenge to get these closures done without tension. And so the technique that I gravitated towards is the anterior ethmoid artery flap. This is actually a talk that was given by a visiting speaker from Mayo Phoenix a couple years ago, Dr. Amr Miglani. So sat up here, listened to his talk, and thought I'd give it a try. And I like this technique a lot. So this is a pedicled flap off of the anterior ethmoid artery. You make an incision behind the head of the middle turbinate, just behind or just below the olfactory epithelium, goes all the way down to the floor, across the floor to the side wall, anteriorly to the level of the perforation, and then back medially onto the septum. And so this whole swath of mucosa in pink here is then rotated and advanced into the defect. And so biggest advantages here, it's a super robust flap. Never had issues with necrosis, losing vascularity. It's an axial flap. And you're able to close pretty large defects with it, especially if the perforation's kind of oval shaped, so it's longer than it is tall. You can pretty easily close 2-centimeter perforations with this flap. The downside is that this flap does have bulk to it, and when you rotate it, it causes some kinking of the mucosa and some redundant tissue here, and so it can cause nasal obstruction. I would say about half the patients I do this on complain of some degree of nasal obstruction. Now, in a fair amount of those patients, that just goes away as the flap contracts with time and the postoperative edema goes down. But in some of those patients, I will have to go back in a few months later in a second stage after everything's healed debulk the flap, and then possibly do a turbinate reduction and out fracture as well. So this is kind of my go-to technique. The one situation I don't like to use it in is in patients who need a functional septorhinoplasty. Right? So they have a septal deviation, they have nasal valve collapse, and they also happen to have a big hole in their septum. And I don't like this because what happens is, you fix all the issues with their nasal airway, and then you do this flap to repair the perforation, and it basically cancels out the effect of the rhinoplasty on that side. They say like, well, the other side's great, but this side is no better than it used to be, or it's even worse. So there's a technique, a paper came out recently, and this is actually a technique that's been around for a while. This is a multi-center retrospective analysis that came out, I believe, last year. And basically what this is just a really fancy interposition graft. So it's a PDS absorbable plate wrapped in temporoparietal fascia. So not temporalis, but TPF, so the layer of SMAS that's superficial to it on the temple. The reason they give in the paper for why TPF is that it's thicker, more robust tissue, and there's more vascular scaffolding that supposedly improves granulation and mucosalization. But you essentially wrap the TPF around this PDS plate, which takes a few months to absorb, so it's a long-term kind of rigid construct. And this is just inserted as an interposition graft between your septal flaps through an open approach. It's pretty tough to do these because usually the holes are a little bit bigger and the graft is a little bit bigger, so it's really tough to do it through a closed approach. But it's perfect if you've already opened the nose for a septorhinoplasty. And essentially, the idea is takes a few weeks to months, but because this sticks around for so long, the mucosa of the septum just grows over the graft. And so the results from this study were actually really impressive. So in the several centers where this was done, they had really good success closing pretty big perforations, almost 100% across the board. And by big, I mean perforations that are 2 centimeters or larger. So I've only done this recently on one patient. My results remain to be seen, but I think it's something that's potentially promising. And again, the benefit of this is that it doesn't create any excess nasal obstruction if you're trying to fix the nasal airway. All right, so that's everything that I have for you. Thanks for your attention. Next up, I want to introduce our visiting distinguished speaker, Dr. Sean Desai. Dr. Desai is an associate professor of otolaryngology at the Johns Hopkins University School of Medicine. He is the chief of facial cosmetic surgery, as well as the co-fellowship director for the FPRS fellowship at Hopkins. Beyond cosmetic surgery, Dr. Desai really does it all, from advanced head and neck microvascular reconstruction to rhinoplasty to pediatric cleft lip and palate repair. He is a man of many talents, and I'm especially happy that he's here today because he trained me when I was a resident. And so ever since then, he's become a really wonderful mentor, friend, and role model. And really enjoyed working with someone so talented and also dedicated to teaching. So thanks for being here, Sean.
Awesome. Disconnect this guy. There. Let's see if this works. USB-C. Correct.
All right, great. Can you guys hear me okay? Well, thank you, David, for having me in the Department of Otolaryngology at University of Arizona. This is truly an honor. Before I start, I would say one thing, David, that you didn't learn is never give a talk on septal perforation repairs, because you're now the expert on septal perforation repairs. This is what my mentor told me whenever he thought of a way to treat empty nose syndrome. He says, I'll never publish it though. So it's just part of it. So, all right. So, I have to give up the next 1 hour to keep your attention. So I've got a bunch of flashy videos and photographs and stuff like that in here. But, when David asked me to give a talk, I said I'd give one on nasal reconstruction. He says, we got that. How about functional nasal surgery? And he's like, no, we got that one too. So I thought we can do kind of a potpourri talk on a bunch of different aspects of ENT and how it relates to facial plastics. But I think the rhinologist, the head and neck folk, the comprehensive people, and even some of the otologists would probably have some interest in this. So nothing to disclose. Why focus on the zebras? Skull-based tumors are incredibly rare. And in residency, you probably only deal with a few of them. So this is a story of a 40-something-year-old male who's got right leg pain and neuropathy, and sees the doctor, and they say he's got sciatica, to do physical therapy, and if things don't get better, then get an MRI. So they do that. Gets an MRI, and the radiologist says everything is normal. Just stop picking up your kids all the time, and stop doing the exercises that you're doing, and So this MRI is actually mine, and if you look, is there a pointer? This one? Oh, this one? Oh, perfect. So I haven't looked at an MRI of the body in many years, but when it's your own, you obviously study it. But right there's a tumor, and it's coming out, and it's emanating off of the L5 nerve, which is what mimics sciatica. So this is I did a PubMed search of this. There's maybe 1 or 2 case reports, and of course it happens to somebody who deals with zebras all day long. At a tertiary care place, and it was missed by the neuroradiologist, and ironically, the skull-based neurosurgeon that I work with, who doesn't actually do spine surgery, spent about an hour looking at my MRI, because the folks that do skull-based surgery are so incredibly diligent at the anatomy, and he's the one that said, I don't know what I'm looking at, but there's something on your right L5. And so I had surgery a couple months ago through my abdomen, and with a vascular surgeon to get access, and then a specialized neurosurgeon to remove this. This is the L5 nerve, and this is the tumor emanating off one of the fascicles that's causing all the pain down my foot and leg. And he managed to tease off the entire tumor onto that one fascicle, because nobody wants to paralyze another surgeon, and if you paralyze L5, you have a foot drop, and forever. And so it was pretty remarkable that he got it right off of that one fascicle and end block, removed it, and I'm for the most part fine, and my foot works just fine. So this was a multidisciplinary team that did this surgery, and in the same ORs that I operate in every day. So it's I think only fitting that I'll give a talk on zebras here. But so as David said, my practice is sort of a kind of a mix of everything. It's a lot of head and neck free flap reconstruction, facial nerve stuff, skin cancer, and then also the cosmetic aspect of it. And when people ask, well, why are you kind of doing skull-based stuff, or what does that have to do with facial plastics? I just developed an interest in sort of the skill set that you have as a facial plastics person and as an ENT surgeon. We have an appreciation for the face, the aesthetics of the face, and the function of the face. And I think we've come a long way in head and neck reconstruction for the jaw, for the maxilla, but skull-base surgery is still one of those frontiers that I think still we've made so much progress as a field, but could still be better. And I think form and function really is where we need to go with this. And some of the cosmetic principles that I learned along the way is sort of drives some of the approaches in reconstruction here. So again, with evidence-based medicine here, these are such zebra cases that they're not a large case series. So I think what you have to take a grain of salt with what I say here, because a lot of this is just cases of what we've done in the last so many years. So kind of broke this talk up really on kind of two talks because it's 60 minutes here, but one is the ablation aspects and the transfacial approaches to the skull base and to the face, and the other part sort of the reconstruction, and really that's broken up into the soft tissue reconstruction, and then I want to focus a little bit on facial nerve reconstruction, which is what we do a pretty high volume of. And then what are the complications? We don't like to talk about complications, but they are front and center when you're dealing with skull-based surgery. So some of the ablative approaches, sinonasal tumors come in so many different forms, and really biopsying them is really the way to diagnose what you're dealing with. The risk factors are a lot of them are exposure, viruses, what we learned in medical school. But just like my presentation for having a right foot pain, which 100% mirrored sciatica, which is the more common thing to happen, we see things like this every single day as the ENT doctors. And so you have to have a high suspicion that something doesn't seem right. You sort of get that sixth sense that, this isn't just nasal obstruction, this isn't just a polyp. Whenever some of these cases get referred into us, some of the residents or people say, well, how did they miss that? How did this doctor say? It's very easily you can miss this. You see 30, 40 patients a day in clinic, 20 of which have these symptoms, and only one of them out of 1,000 are going to have a tumor. You just need to have that sense that what is deviating off the normal story here. So the workup, nasal endoscopy, biopsies, MRIs, and then really these tumors I think need to be treated with a multidisciplinary sort of view. I think taking ego out of this is really important. You never really want to have, I think, one treating doctor in a lot of these cases, because it really does affect the form, function, and the treatment of the cancer. I think one of the big things is, can you achieve a negative margin resection as surgeons? That's what we're looking at. And are they going to need treatment like radiation therapy? This is a team I'm lucky enough to work with. A lot of these are my closest friends and great colleagues, but these are rhinologists. He's an open skull base rhinologist and head and neck surgeon. This is the guy that found my tumor. He's a neurosurgeon, a skull base surgeon, oculoplastic surgeon from ophthalmology. My partner, who's another facial plastic surgeon who also does skull base. So, and there's countless other people that are on that team. So a lot of these slides are sort of joint slides between my partners, and these are cases that some of them I've treated, some of them they've treated. This is an esthesioblastoma with hyperostotic features. Just kind of taking a step back, the history of skull-based surgery. I also kind of share similar interest in history as David. And really in the last 25 years is skull-based surgery endoscopically kind of taken off. And a lot of this has been driven by our field of otolaryngology. So we all sort of probably in residency training have seen these massive open approaches through a Weber-Ferguson approach towards those that have trained in the last 20 years. A lot of the endoscopic approaches have become much more popular for a lot of these tumors. And then really what I think we're sort of dealing with now is there this sort of in-between realm of endoscopic assisted approaches, or are there other minimally invasive ways to access tumors? Because what we're trying to do is avoid these large incisions on the face, especially when they get radiated, because it leads to much bigger problems. So, it's sort of this hybrid cross between craniofacial and endoscopic surgery. This is sort of the traditional open craniofacial resection with the bicoronal and doing a frontal craniotomy, harvesting a pericranial flap, and then and tumors of the anterior cranial fossa. But what we found in a lot of these cases, and I'll show you some of the complications toward the end of the talk, is these patients most of the time do okay, but there's a lot of long-term sequelae of these patients, and they're living longer because of immunotherapy and new drugs that are coming out, which is fantastic from a survival standpoint, but it's a nightmare from a reconstructive surgeon standpoint because they develop problems over time. Frontal bone osteonecrosis is something that tends to happen years later, and I'll show you cases of that. This is a case we did a couple of years ago at a skull-based tumor. It was a squamous cell that was invading from I think it was a lacrimal sac going into the anterior cranial fossa. We just did transorbital with the endoscopic assisted with a rhinologist, a neurosurgeon, and myself, and then we I did a radial forearm preflap to reconstruct his eye socket and skull base. This was one of my first cases as an attending, where this guy had a basal cell carcinoma that he just let go, and it had eroded into his eye socket, into the anterior cranial fossa. You're seeing a dural patch right here because it had gone into the dura. They had to do a total maxillectomy. I kind of call this maximally invasive surgery. It's the exact opposite. So we did a big giant ALT flap to reconstruct the palate, the anterior cranial fossa, and the outside. But so kind of taking it a step back from a minimally invasive approach, what a lot of the rhinologists will do is these endoscopic surgical techniques. It's the same principles of identifying landmarks, removing the bone beyond the tumor, devascularizing the tumor, define the margins, and doing a dural resection if necessary. It should be the same margins of resection as if you're doing an open approach. It shouldn't, the head and neck principles should stay there. So one case here, a 64-year-old male with nasal congestion, reveals biopsy shows esthesioneuroblastoma. This is his MRI. It's the anterior cranial fossa and the cribriform plate, which is where they classically come. And this is my partner's, the rhinologist's video of sort of defining the margins of the tumor and essentially debulking the tumor. As you go further along, the tumor is kind of defined there, and then with the neurosurgeon, they'll do the resection and the reconstruction. So on the reconstruction aspects, again, this is my partner putting in an inlay, collagen graft, and then putting mucoperichondrial septal flap, which is sort of the workhorse, and they're really become quite good at doing these flaps. They do it for all these smaller to medium-sized defects, and they're very robust, and usually we don't get involved in these cases. This is what it looks like in the end here, where again, this is putting a pack against the defect. This is what it looks like post-op. The pack is sort of against the reconstruction. This is what they look like 1 year after radiation, and that's what it looks like endoscopically. So again, these are all one of my partner's cases. So that's sort of the mainstay, I think, at most centers now. But what about some of these hybrid approaches? So this is where one of the first approaches we sort of did was open rhinoplasty approaches. I think for dermoids, you learn this when you're in training, but applying this to the skull base is another potential avenue. So this is a 46-year-old male who had basically a septal squamous cell carcinoma that was going up into the frontal beak. And the rhinologist basically said they couldn't get access that high, and the head and neck surgeons say we would have to kind of go do a rhinectomy to get there. So this is where, there's, you can see the cancer sort of high up and going up into that frontal beak area. And so we did basically a open rhinoplasty approach, and let's see here. And what we're doing here is you can spare the external skin and basically do what we normally do in a rhinoplasty or septoplasty. And the lower lateral cartilages have nothing, are not involved in the tumor, but you basically separate it all out with a margin, and then you have access all the way up to the frontal beak area, and you can make the cuts endoscopically where you can see endoscopically. That's what my partner would do, and then we would can just pull it out. Now, what do you do with a septectomy defect where there's no cartilage left? They would obviously get a saddle nose, but these patients, almost 99% of the time, are going to get radiation. So you don't want to do reconstruction on them because the radiation is going to destroy a lot of that reconstruction. So in these cases, we've been using what we use for like pediatric facial trauma, which are absorbable mesh or absorbable plates. We'll put a little absorbable plate underneath the skin envelope. This goes away roughly in about 1 year to 2 years, which is when the radiation is done. And part of it is it allows the skin envelope to stay open, and so it doesn't contract. And then once they're done and they're cancer-free and they want to do a reconstruction, we'll then go ahead and do a reconstruction with that. And so that's what this person looks like post-surgery. Again, this is actually a case I'm going to see on Monday. This is from one of the rhinologists and the neurosurgeons. This is a 38-year-old girl who has a meningocele. And if you look on the MRI, it's sort of going right into that frontal beak area and then connecting to the dura. This is one where the rhinologist says, I can't get access in that direction. Can you do an open approach? And we'll do it as a combined approach. And so that's what we'll do, an open rhinoplasty approach with the endoscope. The other technique I think has been particularly helpful, and I didn't learn this in training, but when I met some of my colleagues as an attending, they were already doing this, and so they kind of gave me the idea with this. So this was a lady who had she had an incidental tumor on her orbital rim going into the anterior cranial fossa, and the only way to biopsy this was the neurosurgeon was saying, well, we have to do a bicoronal and get access that way, and et cetera. It's a lot easier where we just did a transbleph approach, just like we do for cosmetic blepharoplasties. You raise a little flap up, and then you have, and for these older folks that have a lot of dermatochalasis or extra skin here, their skin is very flexible. You just elevate it all up. That's onto the orbital rim. You watch out for your supratrochlear nerve and artery bundle. Preserve that. You go medial to that, and that's where her tumor was sitting. We can at least biopsy it in this case. And so this is her CT scan where that tumor was, sort of straddling the anterior cranial fossa. Again, that was the tumor, and we published that case. But and so this is another case of 25-year-old healthy female, persistent frontal headaches, a bad osteoma right in the frontal sinus, and you can see it's retaining secretions and all that. So this is her CT scan. Again, this is going to be really quite challenging to get to endoscopically alone, because laterally, it's to be able to drill that out, it's going to be quite tough. So this was a kind of another case where we did a transbleph approach. We made a little small window into the frontal sinus, and then you can see sort of connecting to where my rhinologist partner went from below to create a better outflow track. But again, sparing her sort of the bicoronal or scar, because she was very concerned cosmetically. So it's kind of similar to like the Lynch incisions people have done in the past, but going through the eyelid is, I think, cosmetically a little better. The combined approach, you preclude the need for a big osteoplastic flap. A lot of times, you can do this if it's like a big tumor. You can take a little osteoplastic flap out through the eyelid area. Or in these like cases like this, you just make basically a little porthole. So you take like a 1 by 1 centimeter square of bone. I'll drill it out, put it on the back table. At the end of the case, put a little calcium hydroxide with a little bone putty and put it right back. And you don't have to put any kind of mesh or anything, and it heals just fine. It gets you pretty good access to the superior and lateral and back wall of the frontal sinus. So it was really important in this case, which was another case referred by one of my rhinology colleagues to do together, history of bilateral nasal congestion, frontal headaches. He was taken by one of the community ENT doctors for, it was presumed nasal polyps, but they aborted because there was extensive bleeding. And was sent over. The final patch showed inverted papilloma or papillary squamous cell carcinoma. And so this was the preoperative CAT scan that we had with extensive disease, particularly emanating in that right frontal sinus. This was his MRI, and again, it seemed to be pedicled off the posterior table of the frontal sinus laterally, which could not be a more trickier location to remove. And so this is the same group that's my colleagues that have published on this in terms of taking a little bone window out to get access. This was the surgery view when we first got in there. So this is the video of, this is my partner debriding and debulking the tumor from the intranasal side. And then this is going through the eyelid. So that's the port of the eyelid hole. And you can see the tumor is pedicled on that back wall. And so this is what it looks like when it's all clear. That's the posterior table of the frontal sinus. This is going through the eyelid. And that's what it looks like. It's just again, it's an eyelid incision that we closed. In some of these cases, with the benign cases, we've actually had them say, well, can you do a cosmetic bleph on the other side at the same time? And we've done that for benign situations. So this is what it looks like, just radiation, and he's a couple years out and free of disease now. Just for completeness sake, this is another potential approach, is going the far mandibular, transvestibular approach, but I'm not going to talk about that too much today. All right, so reconstruction. So a couple of things that you have to reconstruct when dealing with the anterior skull base and the lateral skull base. So bone, soft tissue, and nerves. And so the evolution of dural reconstruction, again, I think the rhinologists have sort of paved the way with doing fascial grafts, pericranial flaps, fat grafts, mucosal grafts. The main workhorse, I would say, that they use is the vascularized pedicled nasal septal flap. It's very hardy and I think works in 90-something% of their cases. But there are other options, and usually if there's something goes wrong with all of these, or it's multi-operated, or radiation, and there's complications in terms from the radiation, that's when they tend to get us involved with doing vascularized tissue from somewhere else or locally. This is a paper we discussed, sort of what's our algorithm. But the main thing is that the first line therapy is fascial grafts and septal flaps and all those, but what do you do when it's a little more complicated? And so using regional flaps and free tissue transfer are sort of options. Sort of when you're looking at how do you raise a nasoseptal flap, this is a sagittal view of the septum. It's really pedicled off of blood vessels right here, and you're making cuts all the way along and reflecting it back. And it's really quite a good flap for many of these reconstructions. This is just the flap being raised, and this is And they're basically doing like a septoplasty on one side with the cuts, and then this is looking at the back of the skull base, and you're then going to you have to make cuts superior and inferior to release it and allow it to move. And then it goes in the back there. So this is again, a CSF leak repair. Oh, sorry. Nope, didn't want to do that. Don't allow. Okay. Oh, God. Let me see here. Nope. All right, let me go back to this. All right. So this is a CSF leak repair, and again, it's using so this is putting in basically like a gel foam around it, and sorry, I don't know where and then basically a pair of nasoseptal flap is put on top of that. So what do you do for cases where it's refractory? The septal flaps are used and you're still having a CSF leak and they're radiated. So that's where free tissue transfer comes in. This is a technique where you can take a radioform free flap, which is really thin, and it's got a long pedicle so it can reach all the way up to wherever you need to go. And this is just a diagram where you're basically making an incision on the neck, and then you're going through the buccal space, tunneling the radial artery and vein. You do a little maxillary antrostomy, go through the maxillary sinus, and then up into the ethmoid area where there you can have pretty much a vascularized flap of whatever size you need. And they don't have any sort of sequelae of scars on their face. That's what it looks like. You just have to be careful with these patients because you have to tell them that if they ever see an ENT doctor or anybody looking in their nose not to biopsy anything because they'll biopsy the radial artery. So that's what it looks like right there. This was done in 6 patients. It worked in, I believe, 5 of them. So sometimes patients are too sick to have those big free flaps. This was a case that we had of a guy had a big tumor, had a big resection. It was like a 15-hour section with the neurosurgeon and the head and neck surgeon. But he had a heart attack the next day. And I was supposed to do the reconstruction as a staged reconstruction a day later. And, what do you do in that scenario? So they allowed me to do a less than 1 hour surgery to just we had to cover the dura in some fashion. So this is sort of a rescue flap in those situations if you need to get somebody off the table. It's basically temporalis muscle, temporoparietal fascia, and pericranium, so it's like a mega flap with a blood supply from the superficial temporal artery and the deep temporal arteries. And you can basically lift up the entire side and tunnel it over, and that will cover pretty much anything. So it's always a good backup in case of any really bad problems.
Yeah.
So that's just tunneling the flap over to the orbit there. What's new in terms of reconstruction of the skull and in the plastics world? So this was a patient that had a complex orbitocranial tumor. So she had a meningioma, and then she presented at us right as like when COVID was starting. So she had to wait a little while because it was a meningioma, but it wasn't exactly urgent. And unfortunately, it grew a little more. So it was basically involving the superior lateral orbital rim, the entire calvarium on that side. It was going into the dura and into the frontal sinus. And so this is a complex problem for a lot of reasons, but it also has a significant amount of cosmetic issues as well, because the superior orbital rim is a really complex area to reconstruct. So we have to deal with the frontal sinus as well as dealing with potential CSF leak and pneumocephalus. So this is what our MRI looked like. So this is where virtual surgical planning can come in handy. This has been around, like if you look at the KLS stand out there, I was noticing that they have the guides and stuff that we use for fibula flaps for reconstructing the jaw. And that's been done for the last 15 years, but for doing it for the skull is sort of recently. And so this was her tumor. This was a 3D printed model of her head before we did anything. And we had a good 1-hour planning session with me and the neurosurgeon of where we were going to make cuts and what was going to need to be reconstructed. And so you can virtually do the surgery first with their software, and we can make the cuts exactly on the orbital rim where we want. These are the cutting guides that are then put on the skull with landmarks to show exactly to the nearest millimeter based off of the CT scan. And the reason that's important is because of this complex three-dimensional shape. To be able to mold a cranioplasty there is pretty challenging. It's also challenging to know exactly where there's going to be symmetry. And so we basically created this peak implant for the surgery based off of what we would virtually be cutting. And so this is what it looks like after the tumor was removed. The dura is patched here, the tumor's gone, but you're staring right into the left frontal sinus right there. You can't put an implant near a frontal sinus that's exposed, so it will get infected. So we took the contralateral pericranium, which we lifted from this side. This is the supratrochlear and supraorbital vessels, and we flipped that into the frontal sinus to block it off from the brain. And then on top of that, you leave a little space and you put the preformed 3D printed peak implant that you made before surgery. And it kind of just fits like a glove, which made this a much more easier surgery for us. And so the implant went in. That's what it fits like on the model, and that's what it looks like there. This is what it looks like afterwards. But we have a big problem post-op. And the problem is she still has pneumocephalus. The flap of tissue that we put in there is right there, but we had a drain in, but I think I took the drain out too soon, and it became like a one-way valve where when she was breathing, it was just plopping into like breathing air, going into the frontal sinus and pushing air into the brain. So we sort of had to figure out a way, how do we stop that from happening? I did not want that implant, which is right there, to get infected. And so that's the pericranial flap that I was talking about. So what we did was closed off. So this is what we did during surgery. What we told her is just don't blow your nose. We gave high flow oxygen. One other option you can do is, which one somebody, I think a resident or somebody came up with, is why don't we to seal the sinus? So go in and in the bedside and see if we can just squirt to seal into the sinus. We only needed to basically close off for a couple days, and then it would seal off. Plugging the nose is what I ended up doing. So we just put like Maricel packs and Rhino rockets and told her, don't use your nose. Keeping a suction drain probably would have been smarter. Luckily, it did close off a couple days later. This is what she looks like. She's 3 years out from surgery now, and that's what that pericranium looks like. That's what the implant looks like. And this is before surgery, and then after, you can see the contours a couple years later. But this is after radiation too. So it definitely, the technology definitely helps us in these cases where I never could have been able to form that myself. So facial nerve reconstruction, this is something that I think is really have come a long way in the last 20 years. Even when I was in residency 15 years ago, this stuff was sort of just starting to get popular, but really for a lot of the defects that we did for like acoustic tumors or parotid tumors, it was like a static sling and a weight, and that was it. Maybe a nerve graft if there was appetite to do that, but I think we've come a long way here. So this is another kind of algorithm that we've come up with in terms of, I'm sorry the writing's a little small here, but it's basically saying with lateral temporal bone tumors and lateral skull-based tumors and parotid tumors where the facial nerve is sacrificed, what can we do to reconstruct those people? Because a lot of times, we just put a big PEC flap or ALT flap or something, and you close the defect and you get out of there. But these patients have significant functional issues with having a dense facial paralysis. They tend to be older patients as well. And so basically, if the facial nerve is still intact, there's definitely things that we can do. If the facial nerve is not intact, but the facial musculature is still there, meaning they didn't resect the muscles of the face, then at this point, there is a lot of different nerve grafts that we can do now to create a smile again. The most important of which is a masseteric transfer. The masseter nerve to the masseter muscle is rarely affected in these tumors, and it's a 20 to 30 minute procedure where and it's already exposed. You find the masseter nerve as it exits out of the sigmoid notch, and you just transfer that nerve to the main buccal branch for smiling using a nerve stimulator. And it really takes 20 or 30 minutes, and within a couple months, they'll be able to get a smile back. And so the other way we think about this, again, really a lot of times with acoustic tumor resections, is the facial musculature present, and is it, and are they physiologically viable? If they are, then potentially upgrading the signal of that facial nerve, and I'll kind of talk about that a little more. So, for example, for acoustic tumors, if you get a facial paralysis, the classic teaching is we always wait a year before we consider reanimating those people. My partners, before I got there, have kind of challenged this idea of waiting a year and potentially doing this much sooner. And so what they've kind of shown is that really if by 6 months, if they had a dense like House-Brackman 5 or 6 paralysis, if it has not come back by 6 months, it's unlikely to get much better. And so at that point, you're wasting essentially good nerve viability and atrophy of the facial muscles. So every month sort of counts in terms of getting the axonal growth back to those nerves. And so the idea here is if nothing has come back by 6 months, consider doing a nerve transfer to that facial nerve sooner rather than later. And they did this, my partner did this study where essentially if you let them go and you didn't do anything, most of them, the House-Brackman 5 and 6s, stayed at a House-Brackman 5 or 6 for months later on, years later on. But those that got nerve grafting, basically where you intervened at the 6 month or 7 month or 8 month mark, you keep the facial nerve intact. You're not cutting it. So there's very little downside to this. If the nerve's going to recover on its own, it can still recover on its own. But what you're doing is signal upgrading it. So you're basically either putting the masseteric nerve and you're hooking it up as well end to side into that facial nerve to get axonal growth from the masseter into it, or the hypoglossal is the other nerve. And that, if you look, this group that had that early intervention had much better outcomes in terms of facial nerve function. So when you think about the timing of repair, it's sort of this really, it's always a controversial thing at our conferences about when to do this, but really that intermediate 6 to 12 months is what we're talking about, where when I was trained, it was always 12 months plus. And I think this has sort of changed the way we think about it. So this concept of signal upgrading or trying to reinnervate a reversible paralysis. What nerves do you use for this? I think there are really 3 that we think about. The classic is spontaneous recovery using a cross-facial nerve graft, where you take it from the other side, you do a sural nerve from the good side, and then you let it grow across, and then months later you basically see if you have signal in that graft, and then you hook up a flap or et cetera to it. That is, gets you spontaneous recovery, spontaneous smile. But as I mentioned, the masseteric nerve gives you probably the best motor in terms of when you bite down, you'll see the nerve will fire to that, those buccal branches, and it recovers very early, and it makes sense that it recovers sooner than the other nerve grafts because the masseter nerve is right there. It's within 1 to 2 centimeters of those facial nerve branches, so it doesn't have to travel very far. And so that's why we like that nerve, because nerves grow a millimeter a day, et cetera. It doesn't have to go very far, and that's why we see results as early as 4 months out. And I'll show you videos of that. So if you have a very flaccid paralysis, the hypoglossal is sort of the best one for giving resting tone. So this was a study done by the group in Toronto, but it's basically looking at the axonal counts and concentration in these donor nerves. And when you look at it, the cross-facial nerve graft is way less, roughly 1,647 myelinated fiber counts from that. So meaning when you have to have it travel all the way over through a graft, you lose a lot of the axonal fibers. But the masseteric nerve is almost 5,200, so almost 3 to 4 times the concentration of fibers. And the hypoglossal nerve is the strongest. That's why it gives the best tone. So the masseteric 5 to 7 transposition, we can see this as early as 4 months out. We do this almost routinely now in all radical parotidectomy cases because it really doesn't add that much time. And at least within 4 months, they will get a dynamic smile back. It doesn't give great tone, so if you're just going to do a masseteric nerve and the facial nerve's totally out in these cancer cases, you may want to consider doing something, either doing enticide into the 12 as well, or doing some other things like a static sling or a temporalis transfer, and I'll show you that as well. Or just nerve grafts to basically like an interposition nerve graft that's been around for years. This concept of babysitting the zygomatic nerve, this is if you have a nerve that's been out. So say you have a tumor that's knocked out a couple branches of the facial nerve and it's been out for like 3 or 4 months, and now you're going to do the cancer surgery to remove it. It's already been out a few months. So it's that same idea that if it goes beyond 6, 9, 12 months, you're not going to get any function back to that facial muscle. So in these situations, sometimes what we'll do is immediately innervate that the masseteric to one of those branches to try to see if we can get reinnervation as quickly as possible. So this is just a diagram of where does the masseteric nerve comes out. It comes out just out of that sigmoid notch, and about 1 centimeter down and 3 centimeters anterior is sort of the landmark that we use. And it's really, the anatomy of that nerve is pretty constant. This is me stimulating the nerve during a parotidectomy. You can see the masseter muscle is moving right there. So this is a gentleman that, David, how I can get my pointer. I don't know why my mouse is not working. Well, anyway, this gentleman had surgery in Ghana many years ago. He had a pleomorphic adenoma. Unfortunately, the tumor was ruptured when he had the surgery as a child, and the facial nerve was also injured. And so he had a massive recurrence of the parotid tumor, and there was recurrent pleomorphic adenoma everywhere and going into the temporal bone, and it was just a mess. And so we did a radical parotidectomy. He also had a lateral temporal bone. The facial nerve was just fully sacrificed because it could not be saved in any. So this is doing an ALT flap. This is the nerve to vastus, which is what you find in the muscle of the ALT. It looks very much like a facial nerve. So we do that where we hook that up to the main facial branch, hook these up to the upper and lower division branches. That gives you good tone back after 6 months. We take fascia lata from the same donor site of the ALT for static slings. We'll do multiple static slings Somebody was, you were giving a talk on suspension of the nasal valve. These patients get a lot of nasal valve collapse using the same concept of the MyTech anchor. We'll just do it with fascia lata in these cases. We'll put a piece of fascia lata from the ala to the orbital rim because their dilator and nasal muscle doesn't work because of the paralysis. And then we use the ALT fat to then give volume back, and then we'll do a 5-7 graft. So this is the volume for the ALT. This, because we know these patients are going to get radiated. This is the contour defect if you don't do anything. And so this is hooking up an ALT flap, getting the volume back. And this is...
All right, raise your eyebrows up.
Darn, I can't... my mouse isn't working, but I'm trying to show it's only letting me... maybe see if I just... Yeah, maybe I'll do this again here. There we go. Play from current slide. Okay, so let me do this. So this is what he looked like right after surgery.
Smile.
He's a bit swollen. The nerve is totally out because it was sacrificed. He's got some static slings in there. And this is what he looks like at this 1 month post-op visit. Swelling is going down.
Now, try to smile for me.
And
try to bite
he
down.
still doesn't have a smile yet, so it's about a month out.
Relax.
Nothing there.
Bite down again.
And so then let's look at him. This is now about 4 months out.
All right, raise your eyebrows up.
You're starting to see twitches here.
Close your eye.
And now it's just starting to move a little bit. And you can see that the lip is starting to twitch here as well.
Good. Now smile as much as you can.
And now,
Good, and relax. And I want you to bite down and smile.
so you can see it's starting at 4 months, you're starting to see some movement come back, and you're seeing it starting to create a nasolabial fold.
Very good.
And these patients do need training to, with smiling in terms of biting. But eventually, there's some plasticity that we think in the brain that they start doing it spontaneously after time. And so this is what he's like about a year later. The contour is pretty symmetric to the other side. We did a little bit of eyelid surgery to get first facial paralysis.
Close your eyes.
And now the movement is
Open them.
significantly more.
Wrinkle your nose. Good. Bite down.
And so it's not perfect. There's still some asymmetry, but
Relax.
at least for somebody with a total facial nerve sacrifice, it's better than
All right, raise
where
your
we were in the
eyebrows
past. So this is another lady with a lateral temporal bone, infratemporal fossa tumor that was going into the lateral skull base. We did a submental island flap to fill the volume.
Flap, the epithelialized for a lateral temporal bone, total parotidectomy, resection.
And then we did a bunch of, her facial nerve was totally sacrificed again. This is her a couple months out. We did a masseteric nerve transfer on her. This is about 3 to 4 months out. Sorry, 4 months out. So you can see she's getting pretty good excursion that soon. This is what she looked like. I just saw her the other day in the office. She's like 3 or 4 years post-op now.
Good.
And
And can you smile?
and she gets pretty, this is the tumor side. She's getting, again, it would be nice if we even got a little more, but she's pretty happy. So, and that's after radiation.
Submental
sorry.
the epithelialized.
How do I get to the other one? There we go. Sorry. Another tumor, squamous cell going into the parotid, going into the temporal bone. Did a ALT free flap for the skin on the outside, facial nerve grafting, 5-7. But in this guy, we also, with these older gentlemen with really kind of heavy faces, fascial slings sometimes aren't going to be enough. So we did a temporalis tendon transfer, which is also right in the field, so you don't have to make any extra incisions. And in that case, what we're doing is just taking the temporalis muscle. You're not actually doing anything to the muscle, you're just disarticulating the tendon from the coronoid. So you're doing a coronoidectomy. the temporalis tendon attaches to the coronoid, and you're just basically, you have to release it in that infratemporal fossa area, and then you pull it down. And that gives you a really significant static sling. People say it gives you a little bit of movement. It gives you a little bit, but the better reason to do it is really it gives you just a very stable suspension that will last probably a little longer than a sling. Classic textbooks like, we'll also talk about temporalis muscle, where you flip that over the zygomatic arch. The problem with that is you get big, bulky zygomatic arch, so this is going from the other direction. So this is what he looks like immediately after surgery. He had a total facial nerve sacrifice. And so you can see with the temporalis tendon, it gives you really good, this is like day 2 after surgery. It gives you good static symmetry. And then this is what he's like. I talked to him about doing eyelid surgery, brow surgery, but he doesn't want to. And again, this is biting down. We did a masseteric and a temporalis muscle transfer.
One more time, bite down and smile.
And you're getting movement as well as the static suspension. And he was happy with that. He didn't want to do any more surgery.
Bite down.
So what are I think I have 5 more minutes. So what are some of the complications? I think it's a good thing that we have newer drugs to be able to treat some of these complex tumors, but it's been a really tricky situation on how do we deal with these patients long term, because some of these immunotherapy medications are really miracle drugs if they respond, and you've got previously unresectable tumors that are now responding to them, but then they're leaving reconstructive challenges in their way. Some of the goals of reconstructing the skull base, you want to separate the brain from the aortodigestive tract, you want to obliterate the dead space, reinforce with vascularized tissue, and restoration of the aesthetic form and function. These are all cases I've seen that have been sent to me from various ways where they get misdiagnosed, first of all, a lot of times dermatologists will biopsy these things, unknowingly know that these patients had big skull-base surgeries previously, and what they expose when they biopsy is metal. And so it basically always presents as this non-healing scab, and it keeps draining and et cetera. And all 4 of these patients presented in the same exact way, and it took a while for the proper sort of diagnosis to get made. And so this is what I was talking about with this frontal bone osteonecrosis. We always talk about jaw osteonecrosis, but the frontal bone, when these patients have tumors, you're taking a flap of frontal bone out when you access these tumors, and then you're putting the bone back in, the neurosurgeons are, and it's an avascular bone graft, and then you're going to radiate it. And we know what happens when you radiate avascular grafts. They don't take. And so it's no surprise these things tend to happen. And when you have hardware next to it, the hardware just gets exposed. And so these are all communications in various ways into the frontal sinus or into the cranialized cavity. And these are difficult problems to treat. This gentleman, what you're seeing is titanium hardware. This is his CAT scan, and you can see that's their previous tumor resection was there. He's 5 years out from an aggressive snuck tumor, which most of the time is a 20% survival, but he survived and then had immunotherapy and all that, and he's alive, but he's got this big problem 5 years later. So this is the hardware that's loose. It's sort of flapping against the dura. You've got sinus drainage coming out of his forehead. So what do we do with this? So I did a free flap on this, thinking I'm a free flap surgeon, I'll put a free flap. And we take out the dead skin, you put a free flap, I'm showing the pictures everywhere, look how great it is, and then he comes back 6 months later with this. And there's my nice, well-vascularized flap, and that's another big hole. And so this is where it becomes really humbling to do these surgeries, because you realize along the way that a lot of the things that you think are going to help are not enough to help these cases. And so That's more dead bone and more exposure. I have to convince the family to do another surgery. That's what it looked like by the time I got him to the operating room. You're staring at just a big hole into the brain behind it. So this time I did an ALT. We did it like a chimeric ALT where we took muscle to plug into the whole cavity, another flap of tissue to plug in and basically obliterate the space where the dura and the skin are. And that's what I learned along the way, is that the way to fix these problems is you can't just put a tissue on top. You need to obliterate the space, and that fixed the problem. So for the next guy, I didn't make the same mistake when he came from, and I was like, this is what we're gonna do. We put a big ALT and muscle against the brain, and then that worked. Other complications that tend to happen with this, ocular complications. This is a gentleman with esthesioneuroblastoma. I thought I could just put an orbital, this is early on in my career where I said, I can just put a titanium plate on the floor to fix his orbit. Then he gets radiated, and everything just goes to, to basically having a giant hole now right in the medial canthus. His eyelid canthal region is not suspended anymore. He's got enophthalmos and he's got diplopia, so I didn't really help him that much. And so now we have to do a whole bunch of reconstructive surgery to fix that whole problem. Another maxillectomy patient, squamous cell carcinoma that was going up, and again, a medial canthal fistula or nasal fistula. This patient had a Weber-Ferguson incision, which is what we're trying to avoid in a lot of these cases because we don't want to devascularize that skin. So we're trying to do whatever we can to not raise that skin up because this is such a common complication. This was a lady at another esthesioneuroblastoma that came from out of state who, again, medial canthal fistula. I put a radial forearm flap to fix it. It was fine. We were, when she came back for a 1 month, when she flew back in for a 1 month post-op, I'm staring at another hole. And the problem is we did not just fully fill the sinus cavity up. Just onlaying something with nothing on the underside is not gonna work. Good to, again, work with folks. That's my wife. She's an ophthalmologist and does pediatric surgery, but she does strabismus for adults. So any of these patients that get skull base, that where the eye is involved, I make her do measurements before because I want to have a pre-op, and then she can at least, her and the oculoplastic surgeons can work on getting their eye alignment back. Things that I've learned over the years doing this, try to avoid alloplastic materials in these patients, consider prophylactic vascularized tissue in these cases. If you need to put bone, you can wrap it in vascularized 5. Try to avoid these rhinotomy incisions. This is a lady at a skull, another tumor, frontal sinus going into the anterior cranial fossa. You can see her brain is beating through her skin right now because she's not reconstructed yet. This case, we had to put an implant in. I knew she was going to get radiated, so I wrapped it in TP fascia and temporalis muscle like a sandwich so that it will protect it from the radiation. And now she's 3 years post-op, and so far so good. Last slide again, I mentioned this before. This was an unresectable tumor going into the brain with metastases all over as an eccrine carcinoma. Went everywhere in the body. Unfortunately, a Mohs surgeon tried to start removing this on the scalp and basically stopped when he was starting to see bone. But when you looked at the MRI, this was clearly going straight into the superior sagittal sinus of the brain to begin with. So was sent over to us, to the group, and the oncologist started immunotherapy. We all didn't think she was gonna live very long. She's here a couple of years later, but now she has skull and brain with no evidence of tumor. So what do you do now? All the Mets have disappeared. She's responded. Do we do a big surgery now on the brain? So just to sort of summarize, The endoscopic approaches by the rhinologists and head and neck folks have really kind of revolutionized the way we treat these tumors. I think a multidisciplinary approach is good for some of these tumors that extend beyond the endoscopic approaches or preclude the need for like a huge open approach. Ultimately, these approaches should give a negative margin resection. We should never compromise on that. And finally, these are humbling surgeries. There's a lot more complications I could show you. But it's been a interesting work, and it's been fun to work with all the other specialties because I've learned a lot from them. We have room for significant growth, so for the residents out there, it's a place where we as a field can get better. These reconstructions should be kind of thought and planned in advance. And then lastly, radiation is a challenge, but you have to really factor that into everything we do. These are some of the team members, and that's the clan. All right, that's all I got. Questions?
For us as rhinologists, we're always so happy when we can keep that frontal sinus open and patent. But I've been burned a couple of times from cases just like yours where if there is a defect, we end up needing to put like a pericranial flap and end up obliterating it in the long term. And so our neurosurgeons are always saying, well, look, it's an open space, just strip off all the mucosa, plug it up, and forget about it. And so I think that paradigm always shifts, right? Because we've seen obliterations go bad, fat get infected, necrose get infected, and then now we've moved to keeping everything nice and open, but you've shown some really nice cases where that might not be the best approach. So how do you decide, whether to keep things open, whether to obliterate cavities? How can we kind of find a happy medium?
Yeah, I think it's a great question. I think there's definitely situations where you would, not obliterate, and ones that you do. I think radiation is the main driving factor for me in terms of thinking of what to do here. So if there was an osteoplastic flap there, and they're going to get radiated, then I think if you're not going to put any vascularized tissue to protect that bone, you have to assume it's going to degrade over time. And if the brain is, if the brain is cranialized, the sinus is cranialized, then I think there's a high risk of having a connection into that high frontal area. I think, so that's one consideration. I think I also, there's a case I just got consulted on literally yesterday by the neurosurgeon where a guy was skiing, a 38-year-old guy, and the tree branch went from the orbit, spared his eye, went through the medial orbital, superior orbital wall, through the cribriform plate out, and through the posterior table of the frontal sinus. And so literally the neurosurgeon was emailing me yesterday saying, should we obliterate or should we, et cetera. And I think whenever we can not obliterate, I think in trauma cases, I'd rather not, because I find that there's always the chance of leaving something there. And so if the outflow tract is okay, then I'd rather do less is more and leave it alone. So for this case on Tuesday that we're going to do is we'll take the bone fragments out and we'll just put pericranial down to protect the brain from the frontal sinus area, just to have a layer. But if the outflow tract is okay, I'd rather not strip all the mucosa of the frontal sinus and all that and just let it be. But I think it's a nuanced situation. So, and I think probably 1 out of 4 times I'm probably wrong on it. So. It's right before the break, so I'm sure everybody wants coffee.
Great. So as we said, we're going to take a half-hour break. A couple things I forgot to mention this morning. On the inside of the program is instructions on downloading the WebEx Events mobile app. And so if you haven't done it already, ask you to follow the instructions. This is real critical for us it has a lot of great information about the meeting on your app, but also it's how we're going to get session evaluations and feedback from you guys, which is real important, obviously, to us, as well as a necessary thing we need to do in order to get the CME hours. So if you guys all could do that. And then the other thing I want to mention, just before we take our break, is backed by popular demand, we are going to have a raffle again. And so please get one of these sheets over in the registration table. We have some really great prizes, and you don't even have to fill out all of them. I think, let's see, if you get 4 stamps, you can enter once into the raffle, and the more stamps you get, the more chances you have of winning. First prize is a 2-night stay in the Lowe's Ventana Canyon Resort here. So thank you to the Lowe's for offering up that as our grand prize. And then we're also giving out a free registration for next year's meeting. So get one of these and go and visit all the exhibitors and get your raffle entries in. So we'll reconvene here in about half an hour, but go ahead and please enjoy the break. Many talents.
What kind of inputs do you have there? USB-C?
Including the AV. So
That's great.
Jack of all trades. Multifaceted how we do things in here.
What's your name, Chris?
Chris.
Yeah, I just want
We'll get you one of this.
great. Thanks. Just need to
And if you need power, like if you're worried about your battery, you have a little outlet right here you can plug into.
Oh, great. Great. Awesome. Thank you.
Yeah.
You know, sometimes, who knows why, the HB.
Yes.
Yeah.
Oh, that's right. Tomorrow you got.
I'm excited you let me talk about this. I have just niche kind of talks, and I hope I hope people will resonate.
Well, I'm worried about the same thing. This is like a very different kind of talk. A little adapter. Oh, you got?
Oh, do you need a adapter? Oh yeah.
No, he had one here. Yeah, this is.
And if that doesn't work, you're welcome to use this bad boy.
Yeah, he. I'm kind of surprised he invited me. I finally resurrected a little bit my academic career. I gave a talk last week to the oral surgery residency program.
There you go,
up in
suit.
Phoenix.
There you go, suit.
So I'm.
I should have got one. When you unplug, I'm gonna get you. Get that picture of the. All right. Oh, you lead this one off, right?
Yeah.
Do me a favor. Unplug that for a second so I can get a close-up shot of you with the cactus. That's the center.
Yeah.
Okay.
Oh,
Yeah. There you go. Very photogenic. Photo.
Tomorrow.
Oh, there you go.
Probably around lunchtime. What about you? Are you taking the afternoon off? Do some stuff? Yeah.
See about that. And just like that.
Nice. Yeah. You know where? It's downtown.
No, it's 6 miles west.
Let me see what the timing looks like.
Yeah, I know.
Yeah. No, that's actually, it's kind of in my direction. What's it called?
Oh, okay, got it.
Yeah,
Okay.
light
Yeah.
goes off.
Oh, I don't know if we're gonna do the- Yeah, but I don't know if Sonia was going to do the light thing or something. Yeah.
Oh, you want something to get one back in?
So if we can all come back and sit down, and we'll get started in just a second on our second session of the morning. And so, yeah, I think if you look at our schedule, we're mostly organized session-wise by the various subspecialties that make up the field of otolaryngology, but this one's a little bit different, and something I just thought we'd try and might be fun and interesting to talk about something that's more related to some of the general issues in healthcare and medicine, and kind of particularly focused on what's to come in the future, what those challenges might be. And so that's what we're going to focus on for the next hour and a half before lunch. And so to introduce our next speaker, let me give you a little bit of a background. So in 2015, the University of Arizona and Banner Health formed an academic affiliation of these two very large organizations. Banner Health is one of the largest nonprofit healthcare hospital systems in the country, operates 30 hospitals, not just in Arizona, but in 5 other states. But they didn't have any facilities in Tucson prior to this affiliation agreement. But what that has become is an agreement where Banner Health is the primary academic clinical affiliate for the University of Arizona for both the College of Medicine here in Tucson and as well as in Phoenix. So I would say that has been really a fascinating partnership that has grown and developed in a lot of positive ways over the past 9 years. And so that leads me to introduce our next speaker, Dr. Michael Kupferman, who holds the title as Senior Vice President of Physician Enterprises for Banner Health, as well as the President of the Banner University Academic Division. But his past is one that I think is important to note because he's actually an otolaryngologist, which I think is always a great thing to see our specialty represented in some of these physician leadership roles. So important for us to have a voice in the kind of things that are going on at the macro scale. And so Dr. Kupferman, as I mentioned, is an otolaryngologist, a fellowship-trained head and neck oncologist surgeon, was on faculty at MD Anderson Cancer Center for many years before joining, as I said, his current position with Banner Health about a year and a half ago or so. So I'm real excited to hear his talk. He's going to give us sort of his viewpoint of some of the emerging trends in healthcare today and beyond. So Dr. Kupferman.
Thanks, Steve. All right. Well, thank you, Steve, for inviting me to speak today. As Steve pointed out, this is not going to be an otolaryngology-specific topic, but I'm going to try to weave in some elements of what's happening not just broadly within healthcare over the next few years and what we've experienced, but also to tie in some of the trends that you may be seeing in your own practices, whether you're a generalist in otolaryngology, you're in an employed group, you're a head and neck surgeon, and spark some conversation. I do have a couple of disclosures to make, and I only make them only because I'm going to be talking a little bit about payer relationships and where the insurance world is going. But as we think about what are the major healthcare trends happening, it's important to bucket them in a few different domains, and this is not an exhaustive list. But there are certainly a number of these that touch all of our lives in medicine, whether we practice at an academic medical center, we're in a private equity-backed group, or we're retired, because a lot of the elements that are listed here affect us in our day-to-day practices. And so, of course, one of the largest trends that's hitting the United States healthcare systems is the spend, the rate of rise of spend across the United States. We'll talk a little bit about that. We'll talk about how the insurance world is evolving, both from a structural standpoint, but also from a functional standpoint. It's also important to talk about how the workforce is shifting in healthcare, rapidly accelerated during COVID, but is leading to and is going to have long-lasting impacts to not just our specialty, but other specialties. We'll talk a little bit about who else is out there in the healthcare space that we didn't have to work with or interact with or even think about 5-7 years ago. And then lastly, we'll talk about how is technology impacting our clinical practices, our lives, and how it's impacting healthcare more broadly. So to get started with, I think it's important to contextualize where we are right now in 2024 in healthcare. And there's been a number of trends that we have seen across the last 5 years of the United States, the Western Hemisphere, our global positioning here as a political military entity. And so, of course, many of you are familiar with some of the migratory patterns that have occurred in the United States that rapidly accelerated during COVID, a shift away to some degree from the coasts and large cities, more towards southern, southeastern, southwestern states. And this shift has had a number of impacts, but probably most prominently not only on the tax base in this affected cities and states, but also on care delivery and how access has changed dramatically for patients in some of these markets. Of course, inflation, we're all dealing with inflation, whether it's at the gas pump, in the restaurant, but also how inflation has affected deal flow in healthcare, either has accelerated some things in healthcare, such as the demise of certain companies who need to go up for new loans because they've got a new business that they're starting, or some of the bottom feeding that has gone on to take advantage of some of these economic imbalances. And so thinking through how the inflation, the economics, the geographic disparities and changes that have occurred are all important as we think about healthcare right here in Tucson, healthcare in the state of Arizona, and healthcare in some of the other states that we, as well as others, have operated on. And it's led to dramatic shifts in delivery from the standpoint of the ability of health systems to grow, practices to grow, opportunities in novel technologies, the delivery of care in a number of different ways. And as you all have seen in your own daily lives, the rising cost of labor, whether it's a physician labor, an MA in your own practice, or how much it costs to hire a waiter or waitress in a restaurant, have all led to dramatic shifts in not just in the broader economy, but also in healthcare. And then, of course, no talk in medicine is complete without it touching upon AI, and I will touch a little bit upon it, but I don't want to take away any of Dr. Holsinger's discussion of AI. And so I'll just briefly touch, again, very broadly on how healthcare is being affected by AI. No surprise to anyone, healthcare, the cost of healthcare are rising dramatically. The red line shows the percent of our GDP that is going toward healthcare. None of the initiatives that have been undertaken in the last few years, the last decades, has abated any of that dramatic rise. And it's going to hit about 20% of GDP in the next 10 years. And while the economic growth in the country has gone up and down and seesawed a little bit because of COVID, it's been relatively flat the last few years at around 4.5% to 5%. And so we're seeing an outpacing of our economic growth in comparison to healthcare dollar spend, which has broad implications to how Medicaid is going to be funded, how Medicare is going to be funded, how payers are thinking about this, and we'll touch a little bit upon each of those factors. We're also facing an aging population. Many of our population is shifting more and more to the over 65 age group, and you see this dramatic rise in the second column shown here in Medicare, that by 2031 we'll have over 76 million people enrolled in Medicare, compared to only 5 years ago when we only had 60. So that 15 million increase related to the aging population, the replacement of that population with a young population is not necessarily occurring organically here in this country, is having, as well as the rising rates of Medicaid, state-funded health care, is also going to have an impact on our day-to-day practices. And that Medicaid shift happened dramatically during COVID, draw a lot of funds from other resources and needs across the country that does not seem to be abating either, even in the face of the Medicaid, the ending of the public health emergency, which subsequently is leading to Medicaid disenrollment. That is basically people who were automatically put on Medicaid on a yearly basis, as well as those who qualified for Medicaid when they otherwise wouldn't have before COVID, where now the states were mandated in April of 2023 to start disenrolling people. We had over 23 million people enrolled in addition to what we had expected because of COVID, and now there's going to be an abatement of that. And so how is that going to affect not just the local economy, but how is that going to affect our economics, whether you're in your own practice? I have to say, here in the state of Arizona, unlike in Texas, there's a supplement that the state provides for Medicaid patients. And so it tries to equilibrate Medicaid payments up to that of about Medicare, somewhere between Medicare and commercial rates, depending on where you are. And so that Medicaid disenrollment, and we're still going through that. Last I checked, there were about 1.7 million people in the state of Arizona who were disenrolled because they didn't qualify or there was an automatic disenrollment because of age. But it's going to lead, and we're already starting to see signals of more uninsured patients in the state. Of course, bad debt, medical debt is a topic of deep conversation across the country. A number of health systems have been flagged, whether it was the University of Virginia last year or Providence Health, who were flagged by the press for their aggressive tactics at addressing bad medical debt. And then, of course, that leads to the rise of charity, the need for charity care, whatever shape or form that comes in your own practices in a big health system like ours. Hard to say no and close the door to people. It has an even bigger impact to what are quote-unquote called payviders. Those are health systems or organizations that are not only providing direct care, but are also take on some of the risk premium and run insurance businesses. Banner Health is one of those. University of Pittsburgh Medical System is another one of those. Providence Health, Intermountain Health. They have both payer as well as provider impact. And so with that disenrollment, as well as the need to take on those patients, you get hit from both sides. And so it can potentially lead to a deeper degree of impact to systems that are trying to play in both spaces, as well as some of the, not that we worry too much about the insurance companies, but it's something that we have to think about. And so these trends are not new, they just accelerated during COVID. What's even more interesting is where are big systems, where are big insurers putting their dollars right now? And commercial health insurance has been relatively capped. It doesn't grow a whole lot. It's not growing. In fact, many of you may hear from your colleagues who are in the business world, if anything, there is a desire to reduce commercial spend on insurance. And so where are the dollars flowing right now? Where are the big insurers investing their time, energy, resources for growth? And it's in government coverage. And so the introduction of Medicare Advantage many years ago has rapidly accelerated in the last few years. And so Medicare managed by private insurers has now become a much more robust business with a rapid rise, and you can see this in some of these charts, probably about 10% year over year growth. Not clear where it'll cap out. There are many initiatives being put forward from the standpoint of benefits, from funding to move more and more patients who are in Medicare into Medicare Advantage. And those of you who are over the age of 65 know exactly what I'm talking about. Very aggressive push from the standpoint of the insurers. We are one of them into moving more and more patients into risk-based Medicare. A lot of the impacts that we've seen over the last few years, primarily related to COVID, have been pretty significant from the standpoint of how health systems and hospitals have been operating. And because of a number of factors we discussed, some of the things that we haven't talked about yet, but I'll bring up another slide, such as new entrants, where the dollars are going, a better understanding of how hospitals are operating. We've seen significant deteriorations in hospital margins, which then require a spend down of cash. Dollars can't be invested into other things like new buildings, new clinics, employment, whatnot. But we are seeing some improvement in hospital margins in the 1% to 2% range over the last few months. And you can see this chart starts in January 23, and we're starting to see about 1% to 2% margins now. So not a whole lot of excess fat in the system. While the margins are improving to some degree to support system-wide initiatives, we're still about 10% below where most systems were in the pre-COVID era. And so systems are looking for other hospitals, practices, looking for other ways to manage profitability. This just something I pulled from last month on what are systems looking like at the end of 2023, and you can see, while on average it's been about 1% to 2% margins, you can see that there's been a lot of winners and losers. And if you can read very closely, there's a lot of well-known players who are still running in the negative because of a lot of the factors such as labor costs, inflationary trends, loss of business to other entrants. So where are healthcare dollars going now in 2024? The dark blue boxes represent where this is going. There's a shift more and more to ambulatory. We're seeing more and more dollars going into healthcare IT to support value-based care payments, to support AI, back office operations, and then certain areas on the payer side that are growing in size, such as duals. Those are people who are in Medicare but also need Medicaid because they live under a certain income threshold. There was a great talk earlier about the GLP-1 agonist, huge impact to health system and insurance spend. My previous employer, the entire state of Texas, they banned any funding for the use of GLP-1 agonists through their UT Blue Cross Blue Shield contract because it was costing the system tens of millions of dollars a year. But with all the excitement happening in new technologies, new capabilities around biomedicine, molecular biology, new rheumatologic drugs, new neurologic drugs, new oncology drugs that are driving an ever-increased amount of spend across the country, deeply meaningful to the patients who need them, really tough on the employers who are having to foot the bill, or the federal government or the state governments. There's also been a lot of pushback both against the 340B program, which is how many specialized drugs are paid for. It's a very complicated system for those of you who aren't familiar with it, but in a way it's how many systems are able to support both underinsured and at the same time support some of these expensive drugs. Very controversial federal program. And then the most recently passed Federal Reduction Act around the ability of the federal government to negotiate for very expensive drugs is still a hot topic. Just in the interest of time, I'm going to skip through this only to highlight again, and this is really for this group in otolaryngology, that we're not seeing a whole lot of impact on value-based care. It's primarily in primary care, and it's because of the size of our specialty. It's the size of the patient population that we see. But we're seeing huge entry, of course, in primary care, and we'll talk a little bit about what that looks like. But we're starting to see it in the management of kidney disease, in the management of cardiac diseases, and then in oncology, really a push toward cost savings. And this slide really highlights that. A lot of this is happening in primary care, but if you look at the bottom band, much of this is really heading toward cardiovascular care, oncology care, and practices are now taking risk on patients in terms of the cost of care, achieving certain value-based outcomes. I don't think we in otolaryngology are going to see that for a long time, but for those of you who take care of patients with head and neck cancer, we'll start to see and feel this. I want to shift over just one slide or two on workforce trends. 50% of our physicians are over the age of 55, heading into retirement. We're seeing a great deal of physician burnout that accelerated during COVID. Many of you may have noticed that there's an increasing trend for resident as well as physician unionization that are going to have a broad impact, not just on our trainees, but on our physician practices and freedom to practice as we would like to. The changing healthcare workforce, we're seeing a broad entry into healthcare, nurse practitioners, physician's assistants, something that's happening in this state. I don't know if it's happened in your state, but anesthesia assistants. We did not have anesthesia assistants in the state of Texas, but they are similar to physician assistants, but for the anesthesiology world. And so new entrants within the healthcare delivery space is also going to have a broad impact on what our practices look like. And then of course there's the battle for talent. And sometimes we're not trying to compete with Tucson Medical Center up the road or Northwest Hospital. We're sometimes competing for physicians, nurses, MAs with Amazon, Walmart, CVS, and it's not just for those at the professional level, but sometimes getting an extra $1 or $2 to work at an Amazon distribution center makes a big difference in the life of someone who's doing the scheduling at your front desk. And so we need to take care of our people to retain them. In otolaryngology, over the next decade or so, we're looking at an over 1,000 FTE gap in care delivery, so something for us to think about as a group, as a community of otolaryngologists. This, I think, is the most exciting and concerning part of healthcare, which are the new entrants in the market. Big tech, retail, private equity, and insurers are all wanting to play in our space. And what are they doing? They're stripping away the easy parts of the business. Imaging, surgery centers, pathology, telemedicine, all the things that used to be part of the care delivery, our practices are being stripped away in easy to run models, but are having fundamental impact on healthcare delivery in Tucson, in Phoenix on a day-to-day basis. And I mentioned earlier that focus on where healthcare is going. It's into government programs, Medicare, Medicaid. And you are familiar with all these companies that are listed here, not necessarily because of their involvement in healthcare, but because they're integrated into your day-to-day life. You shop in their stores, you buy from them online, they may send you something through the mail, and they're all impacting healthcare in many ways, shapes, and forms, with big dollars, bigger dollars than any single healthcare delivery system can undertake. So they have the deep pockets to do so, and look at what's happened in healthcare delivery over the last few years. Walmart now employs physicians, CVS, Walgreens, Amazon, all of them are employing physicians, APPs, PAs, NPs, and not always in an effective manner. In fact, you can see the rationale for it, and we'll talk a little bit more about what that rationale is, and it relates to the foot traffic. Think about how many people walk into a Walmart. There's a Walmart 15 minutes from every single American's home. And so that entry into healthcare is an easy one for them to think through, hard one to actually deliver on. So Walgreens made a big investment into VillageMD. It was a practice started in Houston many years ago. Then they invested even more money into VillageMD. Then they bought Summit Health. Does anyone know Jeff LeBenger? Jeff LeBenger is an otolaryngologist. He took over Summit Health about 2 decades ago and turned it into a monolithic multi-specialty system in northern New Jersey. And that company was bought out for $9 billion. I don't think Jeff is practicing otolaryngology anymore. And then or taking call. And then 3 months ago, Walgreens says, we can't be in this business, we're shutting 60 stores. Think about the impact that has to communities. Think about the impact that has to the physicians and the APPs who are in those practices. We can't do that. We can't just shut our doors one day, but When you're a Walgreens, when you're an Amazon, it's very easy to do that, which Amazon just announced yesterday. They're they're laying off hundreds of people in their one medical business. The other concerning trend that we're seeing in healthcare is the entry of private equity that is leading to a significant amount of disruption, but also consolidation, and you're seeing it in your own markets, these big roll-ups of cardiology practices, orthopedic practices, ophthalmology practices, GI practices. But some of them have not panned out too well, and you can see there's been an acceleration of private equity. They used to go into businesses, bricks and mortar businesses, manufacturing, and then wherever there's a dollar available, private equity will follow that money. But it doesn't always play out that well. Here we happen to have a very large Envision footprint in the state of Arizona. KKR, one of the biggest private equity groups in the country. For any of you who saw the Barbarians at the Gate movie, that was really about KKR. They just filed Chapter 11 a year ago, led to major disruptions in anesthesia in multiple markets, including Phoenix. APP closed down. Within 2 weeks, we had to find emergency medicine coverage for one of our biggest hospitals in the state. And then Genesis Care closes their shop. Everyone goes into bankruptcy. And think about the impact to all those oncology patients who are under that care. In otolaryngology, we're starting to see an acceleration of that, primarily in the southern part of the United States, as well as in the southeastern part of the United States, like in Florida. And, oh, that's great. That's the timer in the back there. Awesome. Okay, I was looking at my phone. All right, that's perfect. And then you can see in otolaryngology, look at that rate of rise. They're following the dollars. And why is otolaryngology have so few? One, because we're a small specialty, but it's also a hidden gem, and I think it's a hidden gem of a specialty. We have a lot of ancillaries in our practices. We tend to be smart and we run good businesses. And so I think private equity is starting to see some of that in Texas, in the Houston market. There was a big private equity buyout of a number of the practices that were both from an investment standpoint. So they took a piece of the business from one of the large otolaryngology practices, but then they also rolled a few other independents into it. And you can imagine what's the rationale for it. You start stripping out costs, you bring everything into the back, you centralize all your back office operations, you control how your physicians practice, test the order, and so on and so forth, and stripping out all the margin. With the goal not to provide better care, but to sell to somebody else in 5 to 7 years and then make a 10 to 20% IRR for their investors. And so what's happened in healthcare is that we've traditionally had two mouths to feed, right? It's the physicians and the hospitals. Those are the two big mouths to feed. Now we've got a big third mouth to feed. And that mouth is much bigger than any one of us. And so that's one of the concerning trends that we're seeing. And one of the big roll-ups in the Texas market that occurred in anesthesia had led to a near monopolization of anesthesia services. I'm sure all of you have had issues with getting anesthesia coverage, either for elective cases or for emergency cases, because the anesthesiology group wants ever-increasing subsidies to cover call, to cover the number of rooms that your hospitals or your ambulatory surgery centers may have. And then, of course, private equity's entry into the hospital business has not been met with resounding success, and there's some studies on that as well. And so a number of things happen when private equity enters our business, but it's the patients who lose the most, and it's the physicians and the nurses who lose the most. Similar trends are happening in the payer world. That is this verticalization of care delivery. What started out as CVS, they bought Aetna, and I'm using CVS only as an example. That's a company that we have a partnership with. And then, lo and behold, they start getting into provider services. Does anyone know who is the largest employer of physicians in the country? United Healthcare. Optum has employed over 90,000 physicians, and it's not abating. They continue to employ physicians at an ever-increasing pace. And you can see why when you own the healthcare dollar. Anything you can do to control cost at every level, whether it's owning a PBM, whether it's owning the specialty pharmacy and being able to negotiate directly with the pharma companies, or whether it's managing the practices as a way to control the premium dollar. And this explains why. I mentioned earlier that the dollar flow into the commercial business is not nearly as robust as it is in healthcare delivery. And you can see Optum continues to grow. Optum is a subsidiary of United Healthcare, and it continues to grow 25% year over year in terms of their profitability, their operating margin. And then that bottom slide shows how United Healthcare's businesses, how their profits are now distributed. It used to be 10 years ago was maybe 15% care delivery, and in 2022 it's about 50-50. I'll shift now in the last 5 minutes or so to where healthcare technology is going and how technological innovation and artificial intelligence is affecting healthcare in the last few slides. So first off, I think a lot of us are seeing some of this to some degree in patient care and care delivery. Automated reads of pap smears, automated reads of chest x-rays, automated reads of certain pathology slides. A lot of this is already embedded in some of the workflow, but massive dollars are going to this. Back office operations in terms of financial management, better management of our practices, load leveling of the day, load leveling of your ambulatory surgery center, hospital operations, managing operating rooms, managing the workforce. One of the major areas where there's interest in AI is in fraud detection and compliance, making sure that there's direct linkage between care delivery and the bills that are going out the door. And then, of course, research and discovery is a major thrust of interest, using AI technologies to drive drug discovery, new therapeutic targets in bioscience and the like. And there's a strong interest in this, of course, not only from a delivery standpoint, but the ability to control costs, and some estimates that are reduced anywhere from 5 to 10% of costs in the future. That's not meant to be read. It just shows you this is just a small snapshot of who's in this space and who's in the artificial generative intelligence space. But most importantly for us in the room, how is AI, how is artificial intelligence going to affect patient care delivery? Well, one, we're already starting to play around with things like ambient listening, pulling medical records from across disparate health information systems. Number two, it's moving into the space of automated diagnosis or better diagnostics. Or, as many of you may have seen in the lay press, that really exciting story about the woman who typed in her young child's symptoms into ChatGPT and spit out the diagnosis of tethered cord syndrome. And so identifying novel use cases for AI on the diagnostic side continues to evolve. Obviously on the treatment side, and Dr. Holsinger is going to talk about where this fits in surgery, care management, helping us with decision support, precision medicine, inpatient monitoring, and then of course, how do we prevent admissions? How do we control disease once it's under control? Wearables are a hot area right now in artificial intelligence. And then lastly, managing our populations writ large. Who's at risk for developing X? Who's at Y for the following to happen to them? And so there's a strong degree of investment in this area. This is not meant to be read. It's only really a good rubric on how to think about AI technologies. Where does it fit in? Which big bucket of healthcare does it fit in? What is the likelihood of implementation? Where is it? Is it still in the discovery phase, or is it all the way in the maturation phase? What is the cost to invest? And then what is the long-term impact? And those are probably the ways to think about it. And we need to think about it as, what problem do we need solved? Not what problem is this company trying to solve, but is what problem do we need to solve? And as you engage with some of these companies that are trying to bring new technologies, that's a good way to think about it. I know the flashing light, so I'm going to finish up. Just touch upon digital and virtual health. Gained a lot of momentum during COVID, abated for a number of different reasons, people wanting to go back into the office, patients wanting to be seen in person. But it's also led us to evolve into having a number of new modes of care, such as virtualists, people who admit patients into the hospital but are sitting virtually, PCPs who are working in an office distant from where they're actually having that direct patient interaction. We can debate whether there's value in there or not. Telehealth, we have a robust telehealth platform across Banner Health because of just the scale that we have, the remote locations, the rural hospitals that we have. Easy to think about, easy to talk about, really hard to implement. And then lastly, underserved communities are an area that in healthcare we need to start thinking about, because the cost of care delivery to underserved communities, the risks that some of these underserved communities have from the standpoint of surviving cancer, surviving a heart attack, is much lower. And so what do we as a healthcare economy need to do to support some of those groups, whether it's in better behavioral health services? CMS this year just noted that, and they're starting to pay for navigation services. They're starting to pay for social determinants of health consultations, providing food and housing security. And I think it's Kaiser that's investing $400 million in housing around their markets. All the insurers are doing this as well. And so lastly, a lot of things happening in healthcare from a broad financial, political, demographic standpoint that are starting to have its impact on healthcare. We're seeing a lot of different modes of care in terms of delivery. We're also starting to see a lot of new entrants that we need to think about. And the workforce is changing. For better or worse, we need to think about how are we going to adjust for these changes. And then how is technology and the impact of social determinants of health going to impact care delivery? These are all things that we grapple with day to day. So with that, I'll stop. I'm sorry for going a couple of minutes over, and give a chance for Dr. Holsinger to share his thoughts.
Thank you, Dr. Kupferman. And we'll go ahead and move on to Dr. Holsinger's talk. After that, we'll kind of open it up because I'm sure there are questions in there. That was a terrific overview of what's going on and what we have in our future. Somewhat depressing, I'd have to say, but it is the reality, and it's important that we know that. My next speaker is Dr. Chris Holsinger, who I've known for a long time, a good friend of mine, fellow head neck oncologist surgeon. He'll be talking again tomorrow, so I'll just kind of keep this brief and let him come up here. I asked him to talk today as we're thinking of the future and tell us a bit about how AI might be incorporated into medical management and medical care, and so looking forward to him talking.
Good morning, everyone. And thank you, Steve, for the chance to come here. It's absolutely beautiful, and it's really nice to have a chance to interact with y'all. Yeah, that was sobering, but also kind of it's good to understand what's driving underneath the surface of our clinics. So thank you, Mike, for that. Mike and I were at MD Anderson for many years together, and so it's great to see his success. Let's see here. I want to go to. I want to clean that desktop up here. Give me 2 seconds. There we go. Okay, fantastic. So I'm a head and neck cancer surgeon at Stanford, and I want to talk to you about new technologies, specifically in AI, and how they might impact our surgical and day-to-day endoscopic practices across the specialty. I'm going to focus on really a head and neck surgical focus, but really, good Lord, we hear so much about AI. Like, why are we talking about it? It's exhausting, right? It's sort of AI is reaching this fever pitch. It's clearly some kind of bubble. We're going to talk a little bit about that. But when that bubble bursts, I think there's an underlying set of tools that we're going to have in the wake of the bursting bubble that will really help us do a better job care for our patients, and as an academic surgeon, how we teach, and maybe in the future how we actually maintain quality assurance in our surgical practices. So, speaking of hype, there's a football game coming up this weekend, and, the hype around AI actually exceeds the hype around this game and all the personalities involved. But this goes back for years. In 2016, Andrew Ng, who is a Singaporese-born but Stanford professor, said AI is the new electricity. It transformed countless industries, and AI will now do the same. And there's just page after page, and who on the internet on this, and then who hasn't dabbled with ChatGPT? How many of you have a ChatGPT account out there? So plus minus. Okay, good. And then each one of the tech companies now is suddenly trying to make up for the fact that Microsoft purchases a company that was founded as a nonprofit in San Francisco in 2015 and now is a billion-dollar behemoth. And Bard AI has now been launched from Google, which for years had hegemony and way huge lead. In fact, the OpenAI company that now was bought by Microsoft was founded by a gentleman you're going to hear about in a second in my talk, to provide a counterbalance to the overwhelming strength of Google in AI. In fact, Andrew Ng used to work for Google, right? Now Meta has Llama, not so much of a great logo for an AI chat assistant, but takes all kinds. And on Sunday, you're going to hear that Copilot is launching and is going to be integrated, if you wish, and I'm sure if you pay a fee, into all of your Microsoft apps across the Office suite, across everything that's Microsoft. The innards, if you will, of ChatGPT through Copilot will help navigate you as your personal assistant. So that's apparently coming on Sunday, and I learned that in preparation of the talk. I have not watched the commercial, that's maybe the best part of the day. So is there a bubble in AI? Probably. And Forbes certainly thinks that there's a bubble in AI stocks. And I think there's a lot to learn from the dot-com bubble, the original British railway, and even this South Sea. Apparently, Sir Isaac Newton lost close to the equivalent of $3 million by investing in the South Sea Company. And that was the first time the word bubble was used. I learned that in preparing this talk. And so you have the hype and the bubble, and we're just the poor doctors trying to care for our patients in an increasingly challenging environment. It's a dizzying array of all the factors that Dr. Kupferman just reviewed for us. But let's take a look at where we are. Yes, there's all this hype and there's all this uncertainty, but amidst this, there's real progress happening. And James Zhao is a computer scientist at Stanford. For years, he worked in industry and joined us several years ago, and he published just this past month, finally online, in New England Journal AI, a description of how AI-driven medical devices are actually now being used. And here you see the total number of claims, the condition addressed, and now new CPT codes that are actually being used to submit for billing, which is part of the cost, the expanding cost that Mike was talking about. And here you see the effective date of all these. So a very clever AI analyst looked at all this and looked at the 692 AI-enabled medical devices. By the way, in otolaryngology, we just have 2. Looking and showing the overwhelming preponderance of the use of AI in radiology and in pathology. And this has been a boon to these companies in radiology. But where do we stand as surgeons, right? You're going to see again and again specialties that have images and highly annotated data built into their workflow will leapfrog ahead of us. And as surgeons, we're too busy doing operations sometimes to collect the very images that we're seeing and creating through our endoscopies and surgeries. But nonetheless, a new era is happening. We even have New England Journal AI. And amidst all this hype, at Stanford and our group, we've tried to take the approach advocated by the biodesign group. These are the folks, Paul Yock, who was instrumental in developing cardiac cath back in the day. Their approaches with new technologies like, hey, very cool, lots of bells and shining lights, but what's the real problem that we're trying to solve? And I think, do we really need AI? Mike just rattled through the list of problems facing us, so there's clearly a need for solutions. But as surgeons, how can we start to think about what we're producing in our practices on a day-to-day basis, and I want to tell you two stories, one in ophthalmology and one in gastroenterology, that sort of bring home and maybe pave the way for the field of otolaryngology as we talk about the future in the coming minutes, about how we might start to just take a little bit of extra time to capture images, to think a little bit differently about how we do our surgeries. Because specialties that integrate images and data and video into their workflows will be transformed. How many of you have heard about the story of diabetic retinopathy and Google at all, just out of curiosity? So, yes. So I just want to tell you, it's a fascinating story. Varun Gulshan, who's a PhD computer scientist, has nothing to do at all with ophthalmology, has no medical connection whatsoever, but as part of Google, he knew about this vast image vast image collection in the ophthalmologic field, and in 2016 published this paper looking at the validation of deep learning algorithms to detect diabetic retinopathy in a completely automated way by exams that were done essentially by ophtho-technicians or nurses. And here you see their workflow. This study was published, and very soon a large-scale effort in India, where many of these images were actually taken originally, suddenly went into use. And this is a case study from Google Health that points out before the implementation of this technology, the patient would be seen, and in 2 to 10 weeks, a score of that patient's diabetic retinopathy risk would be generated. But with this new technology, it would be essentially 10 minutes. And very shortly after that, in 2019, Verily, which is part of the Google Alphabet family, they created this device that allows a technician to do all of those screening exams. And this happened in 3 years, and that was essentially now 5 years ago. And in 2021, the FDA approved an ambient AI assist agent for use during gastroenterology. Let me tell you a little bit about this story. This is a really interesting collaboration between Jacksonville Mayo and the Humanitas University in Milan. And this is the technology that you see here. It's a collaboration between computer scientists and GI endoscopists. And once they had developed a similar technology, I'm going to quickly go through the story and show you their product in a minute. They did actually a multi-center international prospective randomized crossover trial to evaluate the role of AI to improve the detection of adenomas that might be risk. And in fact, in this study, they showed a 50% reduction of the rate in patients with colorectal neoplasia. Here's the overall schema. This launched in 8 centers in the US, the UK, and Italy, and they did a 1-to-1 randomization where colonoscopy was performed with AI first, and then a colonoscopy, and then a standard colonoscopy was done, and then a colonoscopy was done with the AI agent, and they compared these two approaches. And as you see here, AI first actually helped the GI endoscopist do much better. So as a result, Medtronic purchased this technology. It was sort of a combined Israeli-Irish startup that reached out to the right hospitals with an infrastructure to quickly do high-quality clinical trials research and a good tech infrastructure. And GI Genius is now launched. And this is the device here. I have no connection with any of the companies that we're talking about today. But you see now GI Genius is, just like we have our endoscope, the light box, and the video source now, you'd have a third box that's constantly analyzing every image that you're generating and providing real-time feedback. I mean, this is the potential vision of the future for something like this. So those are 2 examples, and I think they're relatively compelling. But what are we going to do with all this in otolaryngology? And I would say, actually, what is the field of surgery going to do with AI, and how can we address a significant need? And I'll say that I think and again, I'm at a university-based practice, one of the central challenges that we have is how to teach residents. They're not in the OR as much as we were back in the day, 100 hours a week, et cetera, et cetera. but there has been a change in the number of hours that our medical students, residents, and fellows spend with eyes and hands on tissue. And what tools are we going to provide them to help them maintain the same quality that hopefully we're providing? But also, how can we accelerate their learning? And most importantly, when we get sick, we need to make sure that they're really well trained for the future, right? And it's extremely difficult to do this, and our educational programs are really built around the old apprenticeship model and just show up and spend a lot of time. Obviously, this is going away. In Denmark, for instance, they're only working 37 hours a week as doctors, and in France, apparently, it's actually 34. And this is where I think there's a really, I know, how is that possible? A friend of mine in France basically is just retiring at the age of 63 because it's just not worth going to work anymore because he can only work 34 hours. I don't know that's where we're heading. Mike and everyone will tell us, but this is a major problem in terms of just how we're going to care for patients in the future. And, you know, education maybe isn't as compelling as a use case to, say, a private equity group, but maybe that's a good thing, and maybe in the setting of how we improve teaching, we can actually learn quite a bit, and more critically, start to collect the images and the video, which again, I think is our secret sauce. It's what we provide that no one else can. If we can take advantage of that to develop something for the future, I think not only will we improve the care of patients, but we'll actually create the tools that moving forward in the future will help transform our specialty. So where does this begin? And it begins with a really cool lady, Fei Li, who's from Chengdu, China, immigrated here when she was very young, which is, I think this was 8th grade. She moved to New Jersey. And in the year 2010, she did something very simple. She started ImageNet. It's a competition, taking advantage of the fact that everybody wants to compete, everybody wants to help out, but also it's fun. It's a game. It's sort of the gamification. And I'll tell you that she's very famous. In fact, we're going to come back to ImageNet in a minute, but in November, she was highlighted in the Wall Street Journal Weekend Edition just about her life story. Of course, she'd just written a book, which I highly recommend, by the way. But in 2009 and 10, she said, look, we've got the fundamentals already. And of course, this was in the quote-unquote AI desert. We know how to do so much with neural networks. What is a neural network? We're going to talk about that in a minute. It's the engine that underpowers everything that you're hearing about, from ChatGPT to some of the innovative healthcare products that are out there and FDA approved now. But she knew about neural network technologies, and as she watched her son, who was just born, and he was 1 or 2 or something at the time, and she's an AI scientist really interested in pattern recognition and computer vision, has no interest in, venture-backed funds and billion-dollar companies. But she noticed as she annotated the world around her son, his mind absorbed things, and the more she explained and the more she annotated, as the more she said, this is a strawberry, and that's a cherry, and this is a dog, and that's a cat, she realized this is a built-in inherent feature of the neural networks. But we need tons of data to train this intrinsic neural network that drives everything. And so she started publishing with her group that you see here in 2009 and launching in 2010. And then in 2012, something really interesting happened. She has still, and you can sign up right now and get access to these. It's an open source. It's based at Stanford, but you can sign up and get your own account and start to play around this. But she created an image set of over 2.5 million images. And her team here that you see categorized them all. And there's a long story about how they, even with that team and so many images, couldn't do it. But this was the spark of our current AI revolution, literally. And so these 10,000 strawberries and 10,000 images of many other categories suddenly ignited this amazing opportunity, right? So you know what ImageNet is, but what you don't know is really maybe too much about what a neural network is. I'm gonna talk very, very briefly about that. But I think it's A, a really interesting story, and B, I think it's really empowering to know how we got here, because we've got to know how we got here to figure out where we ought to be going in the future. And it's a really neat story. So in 2010 and 11 and 12, she has launched ImageNet. And this group that was considered a fringe group of computer scientists at the University of Toronto, and it's led by this gentleman, Geoffrey Hinton, and I hate to tell you, I keep telling you all these historical features, but Geoffrey Hinton is now Sir Geoffrey Hinton. I believe he may be originally from the UK. His grandfather was George Boole, the Irish mathematician who created, George Boole, who created Boolean logic and Boolean algebra and stuff like that. So he comes from a very interesting scientific pedigree. But he had been working for years on neural networks, and people said, that guy's crazy. And he left the US ultimately to found a group in Toronto. And working with Alex Kashevsky and Ilya Suskinder, they took all of those images and showed a massive incremental net. And here in 2012, this was sort of the creation of this new era using a simple thing called AlexNet, which we're going to talk about in a minute. But what's a neural network? What is all of this technology based on? The human brain. And it was Fei-Fei Li's fortuitous observation about how her son was learning and how she was annotating the world that data plus a neural network ignited the growth and learning of her son. That's what's happening now in the field of computer science and really all throughout societies. But the term neural network has nothing to do with computer science. It was first coined in what later became Nobel Prize winning work in 1959 by two neuroscientists at Johns Hopkins, Hubel and Wiesel, mapped how visual information flashed on the screen. And of course, this I imagine this work would be very difficult to do now, but they mapped the occipital cortices of cats and saw that there was a neural network between the inputs provided on the screen and electrical signals seen in the direct measurements of the brains of these mammalian cats. It was this fundamental observation that led Yann LeCun, who now runs AI research at Meta or Facebook, and it was this same concept of the neural network that he used in 1985 to do an automated assessment of zip codes on letters. So this is a Bell Labs contract funded by the United States government to use neural networks to help sort your mail better. That's literally a big part of the story. But it didn't quite work. They didn't have the data that Fei-Fei Li was collecting. And here's Jeff Hinton again and David Rummelhart. He figured out, and this is the real magic of neural networks, that it's the weights of different paths of inputs correlated to a desired outcome that is the real magic, and that is called backpropagation. And when you put that together, a neural network with backpropagation with dialed in weights and tens of thousands of images, what happens is you go from an AI winter into this current, this age of AI that we've now entered. So Fei-Fei Li is still on campus, and she's got some great graduate students, and there's a really exciting paper that was just published this past month. But what does that have to do with us as otolaryngologists and head and neck surgeons? And I think that whole journey from ImageNet and the neural nets is a journey that plays out when we train our residents. This is Arfine Rahman, and we did some good thyroid surgery recently. And as I was trying to have her see the different layers we go to identify that beautiful recurrent laryngeal nerve, it suddenly occurred to me years ago that we need to be collecting our 10,000 strawberries to help do this. And so what I want to encourage our field to think of is the opportunity of really using our video and images as the most precious data that we can provide. And just a brief case report of how this might be useful. So Claudio Chernea is a Brazilian surgeon who, over the course of 10 years, out of sheer love, photographed 1,500 recurrent laryngeal nerves. And His images plus mine created the foundation for us to show that it was possible to actually use deep learning to identify the recurrent laryngeal nerve. It varied on a variety of conditions that you see here, micro versus macro. All these things are important. And so now we're actually collecting with this 4K, very light camera that we use instead of our LuxTech. We're actually collecting images now for all of these different surgeries so that we can train algorithms to, in real time, teach residents better. And it's also transformed as an educational experience the operating room. Instead of on a thyroid surgery when 2 people in the room would be looking down on the room, now with this headlight, which has a video feed that can be passed through all the panels, everyone is having a heads-up experience. The nurses are more engaged. Even some of the anesthesiologists are actually watching what we're doing. But it highlights the point that Andrew Ng made, which is that a lot of the technologies have been figured out, and what we need to move is a data-centric approach for users like us. And I would suggest that the fundamental math is that if we want transformations in AI and algorithm development and refinement, video is this central tool around which we can use teaching for resident education. It's this linchpin for progress around AI. But there's a little bit of a sort of a negative and a sort of a dark edge to this. And for those of you who have heard of the OR black box, it's horribly named, make you think of plane crashes and Big Brother always watching you. This is now happening at a variety of institutions around the world where algorithms, in a totally de-identified way, are watching what's happening and incorporating activity in the surgical field, activity in the nursing pod, perhaps with the anesthesiologist, in a really unique way, all of it de-identified to help us actually provide education and information when things go well, and maybe sometimes for when they don't go well. So that's where we are, and we have a long way to go, and surgery represents such a minority of the AI-enabled medical devices out there. I'm just going to take, as we wrap up here and move to questions, just a brief moment to connect some dots, just so you understand a little bit more about generative AI. It's the word that everyone's talking about. And so generative AI stands for a generative pre-trained transformer. It has nothing to do with this guy, but this group also at Google actually took together the idea of a recurrent neural network that you're now an expert on, and reinforcement learning, some concepts from psychology, where with massive sets of data, where you would see a pattern in language, in text, when you would put those 2 things together, you could actually, in an automated, completely unannotated way by a human being, get to that desired output from the inputs that you're providing for the AI. And again, I mentioned earlier that in 2015, Ilya Suskinder founded OpenAI, again, as a hedge to the hegemony that Google had at the time. They founded OpenAI in San Francisco, and then somewhere along the way, Sam Altman enters the story, and of course you've all heard the soap opera around this. They became a for-profit company. And it's sort of a remarkable story, and who knows where they're going with this. And ChatGPT launched now a year ago, version 4. And I think it's important to understand a couple of things about this. Number one, the quality of data and the bias in that data is absolutely essential. There are these hallucinations that happen when you have a desired input and an output and data that pushes you in a completely erroneous way. But nonetheless, this is the foundation of transformers that has taken in what started in 2012 and rapidly accelerated us into this new era of AI sort of involving everything. As I finish up, I have, I think, just 2 more slides, and I want to sort of show the way forward very specifically in 2 additional ways that I think are tangible for us. We don't have to wait for GI Genius or the Verily diabetic retinopathy screening tool. Danny Kayasek is a computer scientist from Caltech, and he's now back at in LA at Cedars-Sinai. And Andrew Hung is a urologist. And they are actually using, through a collaboration across multiple centers of urologists, doing mostly robotic surgery where all the video feeds are captured. They're now showing that you can actually use vision transformers, not text as you see in GPT, to decode activity and then predict the next move. Very exciting work. It was a cover from Nature Biomedical Engineering. And I think this is the way forward, and I think this is what we're hoping to do in our field back home. But finally, these things seem very pie in the sky. The 10,000 strawberries and a transformer. I mean, what does that really have to do with my day-to-day experience? Well, there's some very interesting things coming together that will help us as the physicians there in the trenches. And what worse problem is there that we are facing now than our EHR? What a disaster, right? We spend hours away from our family at night. We want to code what we do, but it's impossible using radio buttons and a 1990s interface. It's a horrible problem that we're in. And I just want to, as I conclude, just tell you this small story about how things can come together to actually help us. And that is with, again, I have no connection to any of these companies, but Microsoft, seemingly out of nowhere in 2012, is funding OpenAI, bought OpenAI, has a 49% stake in them, thereabouts. They bought Nuance Communication, which was an expert dictation and natural language processing service that was based on the East Coast. And so Microsoft, now getting incredible AI, natural language processing, and GPT expertise, then partners with Nuance, and this past year, Epic reached out to Microsoft. And now, Mike mentioned the term ambient technology, and now this is taken from my phone. I was part of this pilot. This stands for the Dragon Ambient Experience Copilot. We will now hopefully have, in the very near future, if we wish to have it, and if our patients consent to it, an ambient AI device that can listen to our visits and create a note for us, rather than for us spending all that time. So I think while there are some really exciting things in the future, there's some really tangible things that are happening in the here and now. But currently, there's very little role for AI in otolaryngology, and I hope this sort of whirlwind tour of AI will inspire you to start to incorporate some video and images into your own workflow so that we can do better for our patients. So with that, thank you, Steve, for inviting me. I look forward to a fun discussion. Thank you.
Well, thanks. That was terrific. I want to open up now to questions for either Dr. Elsinger or Dr. Kupferman, as well as invite two more panelists to come up here. I'm going to bring up my conference co-chair, Dr. Eugene Chang, who will be leading the sessions this afternoon as well in rhinology, as well as my partner, Dr. Sheethal Borelli, who is our department's residency program director, among many other tasks that he does. So questions for either of the first two speakers?
This is for Dr. Kupferman.
Yeah.
Over here. Is there any initiatives to address the educational process for physicians especially? It seems like we're going in opposite directions. They're having, there's not a lot of direct admit from college to med school. You have to do a mission, solve a puzzle, all these hoops they make these kids jump through now. But even just, you look at Europe where they do the direct tracks into healthcare and cut some of that college experience. We're getting, older physicians, burned out physicians, but yet the educational process seems to be getting longer, not shorter.
Yeah, that's a terrific question. And speaking from experience, having a daughter who just went through the medical school application process, I can attest to the challenges there. It's a great question. In the past, there had been a number of universities that had partnerships with medical schools, the college to medical school transition. Some of them are re-emerging. I've seen a few of these coming up. So if you know where how far upstream do you want to get is really the question. There's I'd say the bigger initiative, and you're right. I think there's something that the AAMC needs to think through. Do we have enough medical schools? So there's a number of new medical schools that have opened. For many years, the medical school numbers were stagnant, but there are an increasing number of new medical schools opening up in the state of Arizona, Texas. I keep using Texas. ASU, Arizona State University, just announced the opening of a medical school up in Phoenix. NAU, Northern Arizona University, is also opening up a medical school up in Flagstaff. So the number of medical schools that are opening up to increase the size of the base is increasing. So I think that that's a very positive initiative. On the other end of the spectrum, the cost of medical education continues to rise. And so we need some better strategies to mitigate against that. One of those areas where I think we're seeing some of that shift is some of the schools offering near full scholarships, like NYU has gone that trajectory, and a few others. There's now schools that will provide nearly free education and a shorter duration of education, 3 years only, for those who commit to primary care. The federal government has introduced a number of loan repayment programs for those who work in the nonprofit sector. In full disclosure, I was the recipient of one of those. In a former life, I was a surgeon scientist, and took advantage of the Clinton administration's interest to fund the development of physician scientists. So I think that there's different points along that spectrum. I'd say we're definitely not training enough residents, as you saw from the slide I shared. However, it's very specific to a specialty. So you can all go online, go to the HRSA website. You can see what are the trajectories for each specialty. Emergency medicine, I think they're going to have probably 20,000 more physicians than they actually need. So it's not just the pipeline, it's right-sizing the workforce. And so I think this is a combination of federal, public-private partnerships in order to really achieve what we need. And then what we're seeing from other disciplines such as nursing, in having many more students being trained in the nursing to go straight into nurse practitioner schools, CRNA programs, physician's assistant programs. So who are the other allied health specialists that can provide direct to patient care?
I was just going to ask a follow-up question on this, gentleman. So those projections you showed, did they take into account some of the loss of jobs that might happen in, for instance, the field of radiology and other specialties? Do those workforce estimates take into account the impact of AI?
They don't. They do not, nor do they take into account, for example, if you were to look at primary care, internal medicine, family medicine, it does not take into account NPs or PAs taking on comparable roles in those areas. So you really have to factor in a number of other features into some of those projections to better understand what is the right size of the physician workforce that we actually need.
Great. Any other questions? Any questions about Dr. Holsinger's talk, for example?
Yeah, excuse me. I just have a basic question. If you want to talk about physician unionization.
I can try to answer them. I'm not an expert in it. I just know that it's a trend happening across the country. But please go ahead.
Oh, no, it's just a general idea about it. What's going to happen? I'm an individual practitioner. Are we going to band together, or are we going to be hunted separately is my question.
Yeah, where it has cropped up, and Chris, I don't know if you're seeing it in California, we're not seeing it here in Arizona. The most recent, very prominent physician unionization efforts occurred up in Minnesota at Allina Health, a big health system, for a number of reasons. One was obviously physician pay, two was workforce burnout. Those tend to be the two major drivers, is pay and burnout. Chris, what's been your experience?
Yeah, I mean, the residents now are unionized at Stanford. I think multiple other California. Are the residents Can I ask that out loud? Are the residents here?
Not here,
Not,
no.
No, not yet.
No,
Yeah.
but I know at UC that took place after I
It's
left.
coming.
Yeah.
It's very interesting because we get guidance from leadership not to discuss certain things. As faculty, when it comes to these hour issues, we get very clear guidance about how to discuss it, and there's a leadership structure developing within whatever union it is that the residents are in. And if there's a grievance, then it goes through this process, and then on the faculty side, that same grievance will be vetted on that side, and the communication happens in this way. So it's a very interesting time.
Yeah. You got a question? Go ahead.
Yes. When you were talking about AI and things like OR black box, I'm just wondering how much research or thought or, I don't know, has gone into the medical legal impact of that. So it's de-identified, but is it really? And who wants to use that? That could be good, that could be bad. I don't know.
It's incredible. I think there was a really great talk that's online, and we'll exchange emails afterwards. Michelle Mello is a lawyer at Stanford, and Fei Li founded. She just 2 weeks ago gave a talk on this very topic, and it was a fascinating talk. She's a hilarious, engaging speaker, Michelle Mello, but she's not very mellow. She's go. She's a lawyer. She discussed that there is virtually no framework for understanding how harm and risk is mitigated by software, which is essentially the world that we're entering. And so I direct you to that talk. It's funny, I actually watched that talk yesterday. I was trying to figure out a way to work that into this, but we had 30 minutes. I'll tell you that a little bit about the story of Black Box, because I didn't believe that either. So Black Box was founded by Teodor Grancherov. He's a Bulgarian, Danish, Canadian, American now. Very innovative guy, just keeps moving, and he's at Stanford now, and is a trauma and MIS surgeon there. He founded this company in 2014 when he was at Toronto, and has a team of engineers. And it's funny, they record the entire, and I asked him about this very issue. Yeah, sure, you're not recording. They built into the contracting with the hospital, the videos taken are blended, so they extract these things called embeddings, and they in the way that we think about maybe the features of 10,000 Strawberries, all of these different activities, whether it's images or text or data from the OR feed, the patterns that are seen are captured at the level of embeddings, and it's those embeddings and the data streams separate from the raw data that are actually captured from the case. They can't store all the data. I think they started doing this initially because they could not possibly store all these data streams in an efficient way. And so they capture the embeddings, and that's what's being used now to analyze. And so I actually believe that they can de-identify and blur the faces out. And of course, that's built into the contracting with all the hospitals. Yeah.
Great question. Yes, sir.
It is pretty tricky, this de-identification thing. What we call de-identify, a computer system's going to be able to check everything. And they're going to find out which shift worker was on that day and this and that. And this stuff can still be worked out. If it can figure out all these other problems, it can re-identify if somebody wanted to for some nefarious purpose or whatever.
It is, and I think there's
a lot to be considered as this develops.
Yeah, and whether it's Black Box or Big Brother, I think there's a weird feeling to it all. And I guess in my personal interactions, which are not certainly at all generalizable, but as I've started to listen to these people talk, the technologists speak, because I try to straddle a little bit of both worlds. I barely keep up with what's happening as a practicing surgeon. I think the complexity of what's happening is so vast that while it would be possible to identify somebody from their date of birth and their zip code, you don't really need to know their name, that kind of a thing. The systems are so convoluted that I think that it would take a really nefarious agent within the systems to do that, and the systems won't allow it because they're just so complicated. So I think the complexity somehow offers us some defense. But again, that's yeah.
Those complicated systems are figuring out some very complicated things. So it could go either way.
Yeah. I'm a glass is half full, even when it's half empty kind of a guy.
So these are great questions. I'm going to just take one more, and then I want to also bring some of our other panelists in here. So you, sir.
Yeah, thank you. I just was thinking, I mean, with the 10,000 strawberries and, ultimate, as a teaching tool, I understand that, but really are we that far away then to integrating it with some type of robotic integration so that it can actually perform the surgery better than we can?
No.
Well, we hope, but I mean...
The first bit of good news we've heard this morning.
Yeah. I think that, so I had some slides on that, and we're really, really far away. Number one, as a busy, active tour surgeon, I might do in a good year 50 to 60 cases because I'm really selective. So in our field, it's a very niche application. Maybe I just underoperate. I'm sure the radiation oncologists would like that. But in urology, though, to the point and the slide I made earlier, I could see not an automated management of the movements within a completely digital system like a Da Vinci system. I could see that happening in the next 10 years, but not next year and not 5 years. And I think there's going to be a massive regulatory push before that happens. Where I think that we will see improvements is in the vision and in guidance given real time during those surgeries. And I think that's actually a good thing. And again, I love our residents, and I remember my residency, and I just look at them and they just don't have enough time in the OR. And so I think as we have a new generation of surgeons coming to fore who are used to digital technologies and are expecting to have digital technologies, we need to provide those tools, which I think will start as a vision assist first, and then later, you're right. All we need is the API from how all those instruments are moving. It's a very short step to a fully automated surgery. Michael Yip at UCSD has a framework for this in surgery that I direct you to, and happy to share with you his paper. And Peter Kim, who's a pediatric surgeon who's now created his own company, has shown that it's possible to actually do fully automated bowel repair. So it's coming.
Chris, I want to add up onto that question, both questions actually, in terms of the AI de-identification. With the 10,000 strawberries, when you showed that picture, it reminded me of those things, those websites that you have where it's like, pick the picture with the bridges, and I can never pick the pictures with the bridges because I'm a human and not a robot, and robots should do that really well. But the reason why those things are important and why AI identification, I would say, is really important is because AI is all based on data. And so what I mean by that is if we are videoing surgeries and it just shows the first part of the surgery, the third part of the surgery, it doesn't have the outcome, then AI can't generate that data. Right. And then it gets very tricky. And going on to the second part of the question in terms of motion analysis, I think we're actually quite close. So we've developed a simulator that's really important for collision avoidance. And so I think that is being used in real time right now in terms of endoscopic brain biopsies, being able to guide you to the place at a minimally invasive segment. But the work that we'll show a little bit later on today is we're also looking at path guidance. And so what that means is if you can help with collision avoidance, we can also help push you away from structures that you might not want to get into. And it's kind of like, the analogy that I give is, when you go to Disneyland and you ride that car ride, Autopia, it's really interesting. When you look at the pictures back in the 60s, there was never a metal rail there that would guide you along that path. What ended up happening was people got a little crazy and they would start driving into Tomorrowland and causing accidents. And so the engineers and the designers said, well, look, we can't just let everybody just go willy-nilly. We have to have a metal rail so they can't jump that rail. So you've got maybe 4 or 5 degrees of freedom with your steering wheel. You feel like you're driving, but if you're actually going to crash, then it'll push you away. So I think from that standpoint, it's going to be there. I think what AI doesn't do very well is judgment. All of us are we pride ourselves on our expertise, our experience. Like this smells like Pseudomonas. Like that doesn't really make sense, right? But you see enough of that, and you kind of see it. AI doesn't have enough, I don't think, to do that yet. But if it can develop all good data, then it might be able to do that in the future.
Yeah, and I think your comment around surgical innovation reminds me of a quote by a radiologist at Stanford, Kurt Langlotz, who said, AI is not going to replace radiologists in the near future, but radiologists who use AI will replace radiologists who don't. And so I think the paradigm is not AI and full autonomy and no human in the loop, but rather AI as an assist, AI as an augment to difficult situations. That's I think how to roll out first.
Yeah, that's terrific. I think that's a great way to look at it. I want to talk a few other just sort of my own personal topics that I've chosen in terms of this future of medicine. And so, like I said, I think we'd probably talk about AI for hours. So I wanted to switch gears to the realm of education. And that's part of the reason I asked my colleague, Dr. Borelli, who's our residency program director, to talk a bit about, what are the ways, and we talked about some of them already in terms of use of technology and AI, but I think we're facing a rapidly evolving field, and yet the structure of the training of otolaryngologists has also evolved. And I asked Sheethal to sort of give us an overview of sort of what's been happening maybe over the last few years, as well as what we can look forward to, because again, it affects all of us. It affects who is going to be our future colleagues, and it's going to be the people that take care of us ultimately as well.
Yeah, thank you. So over the last few years, I think some of the major changes, at least in the residency application process, kind of revolved around the COVID. And with COVID, we had to go to virtual interviews, and that was really challenging, I think, for a lot of different programs and also the applicants, just in not being able to see the actual program, and then the faculty not being able to actually truly assess the applicants. And this past year, well, let's back up here a little bit, and during that virtual interview process, we had to interview probably twice as many people, just in order to really gauge those applicants. A lot of applicants probably could do 2 to 3 interviews in a day, from their couch in New York somewhere, and not really have any genuine interest in the programs. And so there was a lot of I would say wasted time amongst applicants and programs in those exchanges. And this year was the first year where we were allowed to do in-person interviews, and about 50% of programs were basically went back to the in-person interview format. And for us, it was great because I think none of us are really, none of us are experts at interviewing applicants, and we don't have great data on what actually makes a good resident. Maybe a robot and AI at some point can do that job better than us. But I think at least in person, it was easier for us to assess the applicant's personality, get to know them a little better. It's still a 15-minute interview, so very challenging. And nothing's really changed in terms of the competitiveness of the specialty. It's still one of the most competitive specialties for medical students. It's incredibly challenging to pick those applicants for the interview. Previously we had step 1, and that was sort of like there was a lot of pros and cons to step 1, but it did serve as a little bit of a cutoff to sort of narrow down your applicant pool. We're still getting about 350 applications for 2 spots. And so it's hard to be able to sift out those applications and figure out, who, one, who's genuinely interested in our program, but 2, who we think is going to be successful in our department. And so that leads to sort of the second big thing that I think has changed this past year, and it's something called signaling. Signaling is a way for an applicant to convey interest in a program. So, at the time of when an applicant is applying for a program, they also put in signals, and they can, this has been going on for about 3-4 years now, and it used to be 2-3 signals and 4-5 signals. This year, it was somewhere between 25 and 30 signals, which essentially, if you signal a program, you're telling them, hey, I'm interested in your program, I potentially want to go there. And so as a program looking and sifting through your applicants, you look through your signals and you automatically know that that person is genuinely interested in your program. It makes it easier to look through your applications. Again, kind of reduces some of those wasted exchanges and realizing that, if they don't signal your program, then maybe there's no genuine interest there. This is sort of a precursor to an application cap, perhaps, and that's been talked about for many years. The application cap concept is, you can either tell an applicant, hey, you can't apply to more than, 50 programs, which, they have not done. They currently probably apply to around 120 programs on average. And so with this signaling program, it sort of serves as a pseudo application cap. I think the future of residency training, I think this is a hot topic, and I think simulation, VR, AI is definitely going to be at the forefront of this. Residents, as we've all talked about, they have 80-hour work weeks. There's a large desire for work-life balance, and that starts at the at the medical. As a medical student, I get that question a lot. At providing them career guidance, that's a frequent concern: is how can we achieve work-life balance? This is prior to even knowing what they want to do in their career. So I think that is something that is incredibly important going forward. There's no way around that. That is something we definitely have to address. That kind of goes hand in hand with wellness. And so we have to be able to, as educators, provide a way to give those trainees work-life balance, family support, but also it's incredibly important, obviously, that we train good surgeons. They will be taking care of us in the future. These are real patients that they're taking care of. So how can we make sure that they have the medical knowledge, that they have the technical skills, the surgical competence to be able to go out there. And it is, just like sports, you just repetition, and the more hours you put in the gym, the better basketball player you be, or whatever other sport you play. Same deal with surgery, and I think we can't force them to do thousands and thousands of hours in the hospital. So we have to find a different way to be able to provide that, and that might be, like I said, simulation and some other things. But that needs to be thought out pretty thoroughly going forward.
Yeah, no, that's great. Chris, did you have some comments you want to make?
I was just curious about this signaling process. Is that sort of built into the whole? Is it core? I mean, who runs that?
Yeah, so signaling. It kind of sounds. I don't know how it sounds, but it's kind of mysterious.
It's like a dating app.
Yeah, it is sort of. But I don't know. In the room, are you familiar with this concept of signaling? But it's an interesting thing because this was actually developed by otolaryngologists to apply to our specialty, and then was rapidly adopted by basically the entire AAMC and the match process. And it's gone through some very rapid evolutions, but it again was one of those things that sort of it got its start because of the pandemic, where there was this difficulty of how are you going to balance the process with virtual interviews, virtual rotations, and this was I don't want to attribute wrongly, but I know it came from otolaryngology. So there are a couple names that I believe came up with it, but I'll just wait for you to look up. But it developed from our field, and it has been rapidly adapted by the entire medical specialties to do. So I think that's, again, a tribute to it. So we just have a few minutes left, and so I want to sort of end with the final thing. But just to start off with that, we have, as I said, exciting innovations and technologies going on in medicine and in otolaryngology. We also have the sobering reality of what the future healthcare world is going to look like. We also have the situation where, as Sheetha mentioned, otolaryngology continues to be an incredibly attractive field, and people are going into it. And so we're privileged to have these people that are wanting to do it, and I feel a privilege to be in the position I am to help train tomorrow's surgeons. But it is kind of a dichotomy in terms of hearing very disparate views on this. And so actually I'm going to skip ahead. I had some talk about safety, but we kind of hit on that. But here's what we hear oftentimes in news, and I think this was something that was a survey of physicians in general, but it probably was true for otolaryngology. It's probably true in this room, in terms of basically what are the complaints that we face today: less time with patients, increasing regulation and medical documentation requirements, difficulty with getting good experienced support in the clinic and in the ORs, more and more ethical dilemmas that we face with patients. Some of them have issues particularly social issues which may affect their medical care, and what's our role as physicians, and then just in general burnout, as we hear about it all the time. One of the privileges that I have as a head of department, and I don't know if you guys are avid readers of our newsletter, but I get to put in a first page where I can write whatever I want. And so a year ago I wrote about just the future in general and what the future is as otolaryngology as a profession, and I sort of posed the question, are you an optimist and a pessimist? I answered it in the affirmative. In my view, when we look at just the incredible advances that we see in innovations in our field, we span both, so many different aspects of care, from the young to the old. We all know that. And we all hear it when we are hearing our applicants who want to become otolaryngologists. But in my view, I think that makes the future very bright. I think that young otolaryngologists can look forward to a future that's satisfying, interesting, and very busy, clearly. But there are other views. And so here's a quote that I came across. Medical doctors have been mostly stripped of their godly image and position in society. Although it may be an exaggeration, future medical doctors are like to become, quote, technicians rather than respected physicians. Their roles shall be limited to performing procedures and providing part care, but without any professional autonomy and regulatory role in the health system. And this was a sort of an op-ed written by a physician. I would point out in the article that I read, he was talking about sort of global trends. This is a doctor in India, so he was somewhat focused or influenced by what he was seeing in his own country. But I think, quite honestly, that this is not far off from what many physicians in this country would say. So you have these sort of two views, and I'm going to close by asking each of our panelists to answer this final question: why or why not it will be great to be an otolaryngologist in the future. And who wants to start? Chris, you're smiling, so I'll let you start first.
I was like, I have no idea what I'm going to say.
Okay. Then I'll pick on my own faculty, and whatever they say we'll talk about in our next annual meeting. But
I can certainly talk to this part. I tell all the people that I work with that we are lucky to be in this field. What other field do you get to do where you get to see kids, adults, do medical therapy, surgical therapy, and have phenomenal research? But most importantly to me, and this is a huge kudos to both Sheethal as well as Audrey, who are, Audrey was our former residency program director, but still very actively involved as well as Sheethal, is that we get to work with the smartest. Our residents are phenomenal, and they've done an excellent job in terms of guiding them. But you get to see kind of and shape people from the beginning to the end. So that's what I love about our field, about otolaryngology. And it really highlights my ADHD as well too, in that you can kind of do everything and anything. I think that freedom is there. I think in a lot of the practices in Europe, perhaps in India, there's not freedom. But here, I think our happiness does rely on our freedom as well as some of our autonomy.
Oh, me next?
Yeah, well, so because you still see ENT patients, I know.
I still do. I did a case
but you also have a different perspective. So
I do.
Has that changed
It has
your
not.
outlook?
In fact, I did a case on Monday. So I still am a practicing physician, although not to the degree that these outstanding surgeons are. I'm incredibly, despite what I shared at the talk, I'm incredibly bullish on medicine as a profession. I've encouraged my daughter to go into medicine. I've encouraged her to go into surgery and to consider otolaryngology. It is an unbelievable field. We have an incredible privilege as physicians to care for patients across the entire spectrum of care. As you mentioned, the young, the old. We don't have a medical counterpart in otolaryngology, and so we get to play in so many different spaces. And there's no other specialty where one's career can evolve in so many different ways. And I'll just look at myself. I started out a physician scientist, very much driven along the academic route. I started moving into the administrative side, but still having a tight linkage to patient care. I was doing some of the general otolaryngology and also large head and neck practice alongside this outstanding teacher and mentor. And then I was able to evolve my career into an administrative role that gave me a perspective on how we interact with surgeons, but also how we interact with the cognitive specialties, the diagnosticians. There's an inordinate number of technologies that we get to play with in a very unique anatomic space. And so I just love our specialty and encourage anyone who's thinking about a career in medicine to go into it. It is absolutely the best specialty that anyone could aspire to partake in. And great people, and I think we all generally have great lifestyles. You're surrounded not just by really smart people, but people who also love what they do, and people who have similar personalities in some ways. And that's what drew me to the field, were the types of mentors that I had and the people that I was lucky enough to work with as a medical student.
Well said. We'll go with Sheetal next.
Yeah, so this is a hard question. I mean, I think to me, this I sort of want to answer it in a way that explains why I think it's great to be an otolaryngologist now. I think there's a lot of problems with medicine and overall that has nothing to do with actual treating patients. I think it really comes back to, I love to treat patients. I love to do surgeries. ENT in particular, obviously, it's an incredibly diverse field. It's nothing like doing a free flap or a laryngectomy or a neck dissection. And sometimes, I meet with a lot of medical students and I try to give them career advice early on. And a common dilemma is they really have no idea what to go into. And I kind of just explained to them my road to ENT, and I was incredibly lucky to stumble into this field. I mean, I was pretty much going to become an ophthalmologist until I was assigned a rotation into ENT, and I saw a neck dissection, and that was it, and incredibly lucky. I mean, it's to be paid to get to do this. It's honestly not really fair. The things that I hate about medicine are like charting and billing and fighting for resources and getting OR time, but the actual treating of patients and surgery is incredible. And so, when I talk to medical students, I tell them the same thing: find something that you're incredibly passionate about, that you absolutely love, that you can see yourself doing day in, day out. The things that you're going to dislike about it are probably here to stay. I'm not sure that that's really going to get better. So if you're going to go into medicine, go into it for the right reasons. Pick a specialty that's going to make you really happy. Don't worry about the other stuff. That stuff will settle itself out later.
Yeah, again, well said. I mean, I think that we're very lucky. I think all of us feel that way in terms of doing something that we just love and are passionate about. There's always going to be challenges. There's always going to be problems. Those have always been there. They'll always be there. But if you have something that you love, it's going to get you through it. So I'm going to give the last word to my good friend, Dr. Holsinger.
Very dangerous.
Bring us into lunch.
But I'm very grateful. And I'll be brief because I am saying. My wife and I have 3 children, and none of them are even remotely thinking of medicine. So I felt guilty when responding to that question. But they're doing all really cool things. Not surprisingly, 2 of the boys are doing tech. But I think that the privilege of seeing the neck is such a driver. Just putting and watching what it's like to see a medical student, like on Tuesday, put her 15 blade on the IJ, and just to see those beautiful fascia. What a privilege we have to do that. And I have to admit, that's why as you did as well. But I also think that what Eugene said, the loss of autonomy threatens all that beauty and threatens our role. And the changes in medicine really require us as physicians to really try to be leaders like Mike, to really stand up for our role within the system, because ultimately we're not providers. We're physicians, and it's a calling to be there. And in this strange system of AI and all this kind of stuff like that, that human touch is going to be even more important, and therefore the privilege will be even greater. Yeah.
Great, terrific. All right, well, thank you so much. And again, thank you for your participation. So we have lunch next door, and we also have a special, I don't know if I'm supposed to advocate, but there's a presentation next door that is not for CME credit, but I'm sure it's wonderful, and there's also lunch as well. So we'll reconvene in an hour.
What's that?
The role of these biologics for chronic rhinosinusitis. I have no idea.
Yeah, they're very
expensive. Give a talk at one. You should come.
I'm in my own bubble.
Thanks.
Thanks for take that tour.
Good job, Matt.
What's your talk on?
It's on
Panel photo.
Biologics.
Take a photo.
Then we're doing VR. I got a talk on VR, and then I think I have a talk on.
All right, I'll try to stick around. I'm gonna have to.
also-
I got to go back down to
Yeah, of
UMCT.
course. No worries, no
But
worries,
I
man.
think they're videoing it.
They are. They are. You can watch on the YouTube.
All right, thanks, gentlemen. Oh, yeah, no, for sure. How old are the girls? 11. Thank you so much. Yeah, chocolate kid. Oh, yeah. It's always a winner.
kids keep touching them. Like my little one just thinks it's funny. Like every time he thinks it's like not a good shower. You're 11, you should know by now. It's gonna be a problem. Thanks, EJ.
Of course. Thank you again.
We don't have to leave it on, but we don't want to conserve battery. Well, this is kind of cool. This is like a pretty good solid cable. It is. Yeah, that's, I got it because I thought I'd do it for like, oh, this is yours. No, this is the one I asked to buy for the EV. So okay. I mean, it was something else. Yes. Some ways it's, yeah, let me just grab my plug. And I'll just plug it in. Okay. You got your coffee. I do. So yours is Anasanis Terrace, or it's red. Nice. And then as well as it has choice talk, so there'll be a surgical management like some that that'll have they don't have a they have you need to opt in. I'm sure Tara does, but it's I guess it's just
Troy, do any of your video or do any of your slideshows have videos that require audio? No. No.
Yes. Okay. Okay, can you just grab my phone so I can plug it in? And we'll just leave it.
That would be perfect, and that way I can swap it out.
Yeah, that way you don't need the lead right down. For some reason. It locks itself. The pin is.
Oh, is it password? Okay.
It just has a pin. Yeah, that's 6963.
Perfect.
In case it locks. So, yeah. So. Yes, it is. Kind of. And then just put the at the top of the automatic signal on top. It's like, yeah.
Thanks so much. I'm very pleased to go ahead and start with our afternoon session. This is the first of two sessions on rhinitis as well as chronic sinus disease. We've targeted the different sessions so that the first session is more about understanding the problems of disease, what we can do in terms of evaluation, what new treatments are available. And then the second portion of the talk will be more surgical tips and tricks on how to become better surgeons when we're addressing this disease. Hopefully everybody's having a good time at the conference so far. I'm going to start off and lead this talk on biologics and surgery. And many of these slides might actually seem familiar from Dr. Kern's talk in the lunch activity here. Here are my disclosures. I do have some grant funding both through the NIH as well as through Sanofi and Regeneron. And I want to go over a brief outline of what I hope to have you learn about today. This is really a basic primer for the clinician. We can talk about pathophysiology, or I can talk about pathophysiology for hours. But what I really want to impart upon all of you are how do we treat patients with nasal polyps, what are our options, and how can we use some of the evidence that we might have both in the literature as well as in some of my research at the very end to help ascertain who might do better with either surgery or biologic therapy or even just continued medical management. So we'll go over epidemiology and pathophysiology, some really important questions that you want to ask to get a detailed history, some of the tools that we have as otolaryngologists for our physical exam, what other type of comorbidities we should be looking at in these patients, what are the pros and cons of both surgery as well as biologic therapies, and then again rounding it out with some of our research that might help you make some of these decisions. So as we know, sinus disease with nasal polyps is very, very common. It's probably, in my morning clinic, I'll see maybe 2 to 3 new patients specifically with this disorder. Unfortunately, maybe only one of them will have nasal polyps. I think the education of polyps is still varied. Many of these patients will have allergic rhinitis or enlarged turbinates or runny noses. But I think all of our providers around, at least me, know that if they say polyps, it's kind of an easy in into my clinic. And so I do see a lot of these patients. Dr. Kern had mentioned that this number might be inflated, but this is one that I commonly use in all of my grants, 15% of all adults, because it sounds much more impressive than 7.5% of all adults. And so I always pick the biggest number. But I do think that a lot of patients that we see have some element of sinus disease, whether it's acute sinusitis or chronic sinusitis. And this costs an extraordinary amount of money. So studies have looked at healthcare costs, both direct and indirect, and it looks like $5 billion annually in costs, which is a tremendous number. As a definition, the symptoms have to last for greater than 12 weeks, and we'll talk a little bit more about symptoms here. And it can be divided into 2 groups via phenotype. And so this is just a simple, we take the endoscopy and we look. Do they have polyps? Do they not have polyps? And we'll go a little bit into more of a finer detail of what that means. But those with polyps are a smaller percentage of those with chronic sinus disease, probably about 20 to 25%. So then if we do the math, about 2 to 3% of adults. However, their symptom burdens are significantly greater. So how do we measure symptoms? Well, we can ask, what brought you into the clinic today? What seems to bother you? Or we can go through a defined measure of questions. And probably all of you do something a little bit in between. In our clinics, we tend to try and be a little bit more quantitative, and so we will have many of our patients do what are called questionnaires, not 22 questionnaires. These are not, they take about 5 to 6 minutes to do, and so oftentimes patients can do this in the waiting room or as they're waiting to see us. And they are a large number of questions that go over different domains in health. And it's graded on an ordinal scale, with 0 being no symptoms or no problem, and 5 being significantly affected. So I'd like to use a tool called Poll Everywhere. You can see my kids and I tested this out yesterday, so it works, and those are their answers. But both Tara and I will be using this for engagement from you all. And so what you can do is on your cell phone, you can text the number 22333, and then put in that message line Eugene Chang, EUGENECHANG 110. Once you do that, I promise no AI algorithm will take over your phone, but it'll allow you to input answers. And so I've got 5 or 6 questions here. Alternatively, if you don't have a cell phone, I don't know who you are, but if you don't have a cell phone, then you can also use your computer and you can log in onto this. So the question that I'm asking here is, what symptoms are more associated with patients that have polyps versus those that don't have polyps? So can you get a gestalt of what they might be seeing you for, even before you take a look in their nose? And so A is facial pain and pressure, B is loss of smell, C is nasal congestion, D is trouble sleeping, and then E is answers B through D. So I'll just give you about 10 or 15 seconds to be able to answer this. Thank you all for engaging in this, by the way, too. It's a lot more fun when we get to hear some of your questions as well as answers. So it looks like we're seeing a lot of loss of smell as well as multiple symptoms here. Nasal congestion, trouble sleeping. And what I would highlight is that, just like you had picked up, facial pain and pressure typically is not something that we see in nasal polyposis. And I think I have different theories about this. One is that polyps don't happen immediately. They typically can happen, some people say weeks to months. I actually think lifetime. I do think there's a very strong genetic component of nasal polyposis. And so what can happen is, as these polyps form, people get almost numb to some of that sensation of the facial pain. But what they really do encounter are decreases in their sense of smell, nasal congestion, and what I think we don't appreciate is they actually have a lot of difficulty sleeping as well too, probably because they are unable to breathe through their nose. So this is a great question that I always talk about with my patients. I ask them not only, what's your change of smell been, but have you noticed that foods taste differently? And many of them are taken aback by this. And so this is our next question here. What percentage of taste do you think is attributed to smell? So what I mean by that is how much of your taste is actually relevant to what you are smelling at that time? And I think anybody that has had a really bad head cold can ascertain, can definitely provide evidence for this. That what do? We put a lot more salt on our food. We make our food a lot more spicy. And patients don't, or a lot of my patients haven't picked up on this until I ask them about it. And for instance, a patient that I just saw yesterday, mom said, yeah, he's been putting a lot more tapatya sauce, or that spicy sauce, on all of their foods. And he doesn't even realize it. It's just because that loss of smell is really impacting their sense of taste as well. So as otolaryngologists, we have the unique opportunity to use the endoscope as kind of our stethoscope, right? This is an extension of our physical exam, and this is something that we can do that many others cannot. And so when I do my nasal endoscopy, there are certain things that I look for. One is, are there polyps? Is there edema within the surrounding tissue? Is there mucus? Is this mucus purulent? Is it clear? Is it thick? And then also, is there a deviated septum? And the reason why I think about septums is, if this is going to be a surgical patient, it's something you should consider. With decongestion, if you're having trouble seeing where you need to see, particularly the middle meatus, it might mean that you might need to do a septoplasty in the future. So let's take a look at this polyp again here. I'll describe it to you if you can't see it. This is on the right side, the right nasal cavity. You see a nasal polyp coming from the middle meatus. Classically, it has this kind of sheen to it. I describe it as a peeled grape. I think that when you see masses or lesions that don't have this sheen, for instance, if it's more corrugated, if it's more epithelial in nature, I'm thinking more inverting papilloma. But in this case, this is kind of a classic looking polyp. It's extending from the middle meatus, going below the level of the middle turbinate and right above the inferior turbinate. So the next question I'd like to ask is, how would you score this nasal polyp? And if you don't know, that's okay, because we'll go through the scoring system here in just a moment. So this is going to be an ordinal system 0, 1, 2, 3, or 4. Fantastic. So most of you picked grade 3, and I would agree. We use a nasal polyp scoring system within our actual medical clinic template. This is baked into our template, as well as our modified Lund-Kennedy scores. And why that's important, I think, is for documentation as well too. As insurance companies are becoming more and more stringent upon what we are allowed to do, I think they require more and more documentation. Unfortunately, the insurance companies don't know about a lot of this documentation, so I also have to say large obstructing polyp. But from a criteria standpoint, there are 4 nasal polyp scoring scales. They're shown here. And again, this one qualified as a grade 3 because of both the size as well as the fact that it went below the level of the middle turbinate. In terms of the modified Lung-Kennedy score, we include that polyp score. We also include edema on a score of 0 to 2. When I look at tissue edema, I look at swelling, I look at redness, I look at the ability for me to visualize into areas that I can normally see, for instance, the middle meatus, the nasopharynx, the olfactory groove. And then we also characterize mucus. So how much mucus is there? What is its consistency? Is it mucopurulent in nature? And by quantifying this has actually been really helpful in terms of both grading our patients as well as grading outcomes after treatment. Then we also typically look at CT scans. So CT scans are typically our classic laboratory tests, I guess, that we would, or radiologic tests that we would get. For sinus disease, particularly nasal polyps, CT scan is the go-to. You can do this for both diagnosis. Diagnostic CT scans typically have a lower rate of radiation, but are at the expense of thicker cuts, or you can use a navigation CT scan, which is a slightly higher dose of radiation. I tell my patients it's usually about 2.5 chest x-rays worth of radiation, so that gives them a relative ratio. But navigation scans are higher resolution. They're typically less than 1 millimeter in cut, and we can use it to help navigate in the operating room. Nasal polyps on CT scan can be opaque, so I talk about the gradations of white, gray, and black. And I say nasal polyps and mucus can appear gray, and they can also be heterogeneous in nature. And we'll talk a little bit about what that might mean for the diagnosis. When I see patients with polyps, I expect to usually see them bilaterally. And if I only see it on one side, it warrants further investigation. And we'll talk a little bit in our panel about unilateral polyps and what that might mean in terms of your treatment algorithm. Finally, in order to get a full, complete history, we need to know what other disorders do they have. And this might be heart disease, this might be lung disease, but specifically in patients with nasal polyps, we see a high concordance of coexisting disorders, such as rhinitis, asthma, gastroesophageal reflux disease, sleep apnea, as well as eczema and atopic dermatitis. And this is classic for what's called the type 2 or atopic march. So these are all disorders that are associated with high type 2 inflammation. And when I do see this history of asthma, I also will ask them, do they have a history of NSAID allergy use? And that would put them in the aspirin exacerbated respiratory disorder category. That's associated with severe nasal polyps, as well as almost a bronchoconstriction when they do take NSAIDs. This can happen with aspirin classically, but it can also happen with ibuprofen, Aleve, naproxen, all of the common NSAIDs that we might use after some muscle soreness. Alcohol intolerance is also something that we've picked up on. So I was taking care of one of the top-level administrators at the university, and his main complaint was when I go to social events and I drink red wine or I have a glass of whiskey, I start getting really congested. And I told him, hey, that's my life. I actually have I get flushed all the time, but this is probably more for the leukotriene deficiency that they have. And so taking the alcohol in moderation and potentially even using leukotriene modifiers help this patient. So because we see these patients quite commonly, what I'd ask is, what percentage of those patients with asthma, so this is a reverse, so what percentage of patients with asthma do you think will have nasal polyps? It's kind of cool to see those move in real time. So it looks like most of you are around that 10 to 50%, and I would agree. I think if you look in the literature, it varies incredibly. But the figure that we typically think about is about 25 to 50%. Now, they include what's called severe asthma, so those patients that are requiring rescue inhalers on a regular basis, that are on some type of a steroid therapy, whether it be inhaled or oral. But yes, we will see a lot of patients with coexisting asthma. And that's important for us because if we don't know about the diagnosis of asthma, then we might miss that. There are several patients that I've sent to Dr. Carr or Dr. Schroff, who are allergists and immunologists here, that are experts in the diagnosis, the treatment, and hopefully prevention of asthma exacerbations. And this has been a new diagnosis for them. And so it's important for us to be able to realize that. Finally, endotypes of CRS with nasal polyps. So we talked about the phenotype. Phenotype is what we can see. Do they have polyps? Do they not have polyps? But endotypes are more molecular mechanisms or biomarkers of why this disease is occurring. And this is Dr. Schleimer's diagram here. So Dr. Schleimer is a big basic scientist at Northwestern University, where Dr. Kern is from. And he talked about the immunopathogenesis of chronic sinus disease. And all I saw initially when I looked at this picture was just a bunch of circles and dots and arrows. But it's in part because there are so many things that are likely occurring that might develop, that might lead to the development of sinus disease. We think of this primarily as a type 2 endotype, and type 2 initially was described because these are cytokines or messenger molecules secreted by type 2 helper cells, and the classic ones are IL-4, IL-5, and IL-13, but now we're learning that other immune cells can also secrete these cytokines. But the epithelia itself also secretes cytokines that stimulate these Th2 cytokines, and those are IL-25, IL-33, and TSLP. And as an epithelial molecular airway biologist, these are ones that are very, very important to me. They're also characterized by very high eosinophil counts. So if we think about sinus disease with polyposis as a long-term chronic inflammatory disease, how are we going to treat this? How are we going to dampen the inflammation? And I think our go-to is steroid medications, right? These can be oral steroid medications. There are some of my patients that have been on many years of oral steroid medications, unfortunately with some significant side effects. They can get the dorsal hump, they can get endocrine abnormalities, particularly in older women, they can get severe osteoporosis as well. And so significant side effects of taking the oral steroid medications, but in my practice, probably the most effective in the short term. But because of those potential side effects, we've also started to use topical sprays. A lot of my patients come to me on Flonase or fluticasone. I like the non-alcohol-based sprays a little bit more, Nasacort, Nasonex. They typically are a little bit better tolerated, and all these are now over the counter, so their cost is relatively low. We've also been using irrigation. So if you've ever been to any of our talks in ENT in the Desert, the use of budesonide or mometasone in irrigation solutions is very, very common to our practice. You can get these steroids at the pharmacy, although they will often give you a call because they'll ask if this is inhalation or not, and they're not really not used to using these vials in the irrigation solutions. Or there are formulary pharmacies, including ones in our vendor show, that will make these up for you. Budesonide typically is our go-to. I'm not sure exactly why, but there are some patients that have that we have seen, that Chris and I both have seen, with some ophthalmologists that are very concerned about topical irrigations, particularly in the setting of glaucoma, and they are more comfortable using mometasone, or they recommend mometasone, so we're happy to do that. And I think in terms of the type of action in the epithelia, it's very, very similar. There are also exhalational delivery devices, and the only one on the market right now that I know of is actually a dry powder called Xhance. So this is something that you put into your, one flange goes in your nose, the other flange goes into your mouth, you breathe out, and it deposits powder. Their studies have shown good deposition, and this actually might be really good for those patients who say, look, I understand why you want to do irrigations, but every time I do them, I feel like I'm drowning, and I really just won't be able to do that. This is one option that we have. And then finally, we also have stents, right? So these can be stents that dissolve on a relatively quick basis. These can be longer lasting stents, but the whole goal of these stents is to place them into the sinonasal cavity in contact with the epithelia and then leach out steroids to help with inflammation. Leukotriene modifiers, including Singulair or trade name is montelukast, can be very helpful in patients with asthma. It's not a medication that I typically prescribe, but I know that a lot of our AERD patients are on this and actually do very, very well with it. For antibiotics, because this is more inflammatory, I typically won't use antibiotics unless they have signs of mucopurulence within their endoscopy. And the reason being is I don't think that this is more of an infectious component. However, in those patients where you might not know they've had long-standing diseases, it is quite common for me to use both steroids as well as antibiotics concurrently. So now we've come to a decision point. You know, they've exceeded the maximal medical therapy. They're at your office. This might have been done outside of the clinic, or you might have been guiding them through this. And you have to decide, what am I going to do? They are not responding. And why aren't they responding? Well, with the medications, what we're doing is we're turning down the volume of their inflammation, but we're not taking their inflammation away completely. And they are going to have flares, and they are going to have exacerbations. And what I tell my patients is that we are going to be friends for a very long time, because this is a chronic disease. And this is going to be something that, you know, you'll show me pictures of your kids, and then maybe even your grandkids. And we'll talk about you know, how your nose is doing. And this might take weeks and months and even potentially years. But you have to kind of let them know that this is a chronic disorder. And I use a common analogy of diabetes. You know, we can control your sugars with insulin. We can't take your diabetes away. There probably are some gene therapies now where you can, but at least at this point we can. So with surgery, when I counsel my patients, what I let them know is we are going to decrease your inflammatory load by removing all of those polyps. And there have actually been some very nice studies that have shown topically or locally that type 2 inflammatory markers significantly decrease when you take out those polyps, along with all those likely ILC cells that are associated with them, even those type 2 helper cells that might be entrapped within those nasal polyps. And so that's one element that we're doing. And then the second element, again, confirms the chronic nature of this. I let them know we are opening up your sinus cavities so that we can do a better job of providing topical steroid therapy. And there have been, there's one landmark paper that actually did a cadaveric analysis looking at fluorescently labeled irrigation solution, and they found that 98% of that fluorescently labeled irrigation solution just goes out the nose or out the mouth unless you've had sinus surgery. And that's just because the sinuses, as we are designed, aren't easily accessible. And when I think about that in terms of opening up those cavities, that also helps me to determine the extent of surgery that we do. Do we do big holes? Do we do small holes? Do we open up all the sinuses? Do we open up just specific sinuses? So in my head, as I'm looking through these patients, I look at, you know, where are the polyps? What do I need to get to? What epithelia do I need to get open to get those irrigations in play? And that helps me to dictate how much surgery I do. So the next question is, you've done great sinus surgery. You are a great sinus surgeon. But after 1 year, what is the likelihood, and these are typically, you know, again, these chronic polypoid patients, what is the likelihood that you will see some polypoid reformation even after maximal medical therapy? So this is perfect. This gives a great idea of the skill set of the audience. We're all the same. All of us are seeing these, right? I mean, it doesn't matter how good of a surgeon you are, how much openings you've done, how compliant that patient is, you will see patients that have recurrent polyps. So DeConde at UC San Diego actually looked at this. University, tertiary care practice, you know, great trained surgeons, and found high recurrence rates of up to 40% after, they actually quoted 1.5 years, so I want to correct that. so a year and a half afterwards. And that didn't make me feel so bad, and hopefully doesn't make you feel as bad when you see these patients coming back to you with the recurrence of symptoms and with polyp reformation. Fortunately, because they are long-term patients, we can help them through this. You know, we can give them bursts of steroids. We can maybe even take some polyps out in the operating room or in the clinic. But it is a disease that typically does tend to come back in some patients. And again, that's probably because surgery removes some of that type 2 inflammation, but it doesn't slow down the drivers of those inflammation. So this leads into the big problem that we have, right? If we're doing everything right, and we're still only potentially impacting 60% of those patients for a, let's say, lifelong cure, are there other alternatives that are available? And fortunately for us, there are. So there are what are called biologic therapies. Many of you know about these biologic therapies. Many of you have been using them in your clinics or know people that do. But if you haven't, biologics are essentially monoclonal antibodies that target those specific markers of disease. So I talked about those cytokines that are associated with type 2 inflammation. They help to block those areas. And it's a really exciting time because they're the first therapy that we have to really block the primary mechanism of why this might be occurring. So which biologics do you think are currently approved for nasal polyposis? Very good. So we have 3 current biologics, and I apologize, those wrong answers I think were my kids last night. So those, we currently have 3 biologics that are available to us right now. Dupilumab or Dupixent, which blocks IL-4 and IL-13, omalizumab or Xolair, which blocks IgE, and then mepolizumab, which blocks IL-5, so Xolair and Nucala. When I talk to patients about this, I say, look, this is relatively new for us, but this has been used in the medical field for quite some time. Asthma, rheumatoid arthritis, atopic dermatitis, and they've got an excellent safety profile. And more importantly, because they went through FDA regulation, they've got very stringent criteria. So in many of these patients, I would say about 80 to 90% of my patients, they have a very positive effect. But what are the cons? This is usually a subcutaneous injection. There is one now that's being used or being tested in the market that's an IV, but most of these are subcutaneous. The first injection, and Dr. Carr and Dr. Schroff will tell us about this too, typically is done in the office, and then after that they do that at home. But it is likely a lifelong therapy, and this will be one of the discussion points that we'll have in our panel. And so how do we decide? European consensus or the Euphoria guidelines really push more, I would say, more towards biologics than the Americans do. These are the criteria: evidence of type 2 inflammation, need for systemic corticosteroids, significantly impaired quality of life, significant loss of smell, diagnosis of comorbid asthma. What I would say is all the patients that are seeing us with severe nasal polyps probably meet at least 4 of those 5 criteria, if not all of them. What I will say is if they haven't had surgery, you typically need more of these criteria than less. The AAO, which is our academy, which Dr. Woodard is going to be leading here in a little bit, has come out with a consensus guideline that's a little bit more circumventional. There's a lot more diagrams and a lot more arrows, but this essentially pushes people more towards surgery. And then if there is a significant failure, they stress a minority of patients might need biologic therapy. So there certainly is a differing amount of views. So in the last minute, I'll give you some of our exciting research that might be able to help you determine which one you should choose for which patient. So when we looked at the literature, we saw really good results with biologics, we saw really good results with surgery, but we didn't see any studies that directly compared biologics versus surgery. And so we wanted to do the first longitudinal prospective comparative study on this. So we took 20 patients, all with severe nasal polyps, and we gave them the option. We counseled them extensively. Do you want surgery? Do you want biologic therapy? And interestingly, I don't know how this happened, but half were surgical, half chose biologic. And we followed them up every 3 months. And we did stringent symptom criteria, endoscopy, smell even, as well as scoring. So what did we find? We found that, first of all, both work well. But there are certain patients that might benefit better from one than the other. So in terms of symptoms, there was a significant improvement in those with surgery. So again, the surgical group is the blue group. The drop is actually an improved outcome. So as you can imagine, immediately afterwards, their symptoms get better with surgery, and it just takes more time for the dupilumab or the biologic. But after about 12 months, they about even out. In terms of smell, I will say that we did get a lot better smell outcomes after 12 months with the biologic therapies. And I think this is because we don't induce some of that trauma that could potentially occur around the olfactory fossa with surgery. Nasal congestion scores, the biologics did help by 12 months. Asthma, certainly. Interestingly, endoscopic sinus surgery did help with a lot of their asthma symptoms initially, but then they kind of trended back upwards, whereas with the biologic, they remained more durable. And same with the nasal polyp score. So I think what we see is that with a biologic therapy, and this certainly makes sense, right? The symptoms and the outcomes are more durable over time. Because you are consistently giving them a therapeutic that helps to treat this type 2 inflammation. Whereas with surgery, it's a single time point, and so that is a little bit, we see a bigger effect initially, but we need to continue that medical therapy in the future in order to have prolonged beneficial effects. I am going to ask you to hold your questions for our panel because we'll talk about a whole bunch of different practice issues during that time, and I think a lot of them will be asked at that point. So I wanted to thank everyone. I'm running out of time here, but what I will say is that having a multidisciplinary practice is incredibly important if you do see patients with nasal polyps. Many of you might be prescribing the biologics yourselves. We don't do that here. We really lean heavily on Drs. Schroff, Dr. Carr, as well as Dr. Odisio, who are adult allergists, to help with that, and in part it's because they're also dealing with many of their asthma type of issues. But this is a very exciting time for treatment of patients with nasal polyps. So thank you very much. So with that, I'd love to introduce Dr. Carr. Dr. Carr is going to talk to us about the medical management of a lot of rhinitis, or patients that we're seeing in many of our clinics. Dr. Carr is the head of our allergy and immunology department. She comes by way of Northwestern, which is probably the first multidisciplinary group to coordinate both otolaryngologists and allergists, a fantastic partner to be with. Thank you again, Dr. Carr.
Yeah, thanks. Find it. Okay. Yeah, I thought you could do it from the internet. So let me just see if I can get on really quickly. Not on the internet. Okay. Yeah. Hi, Chris. Do I just need to put in the? Okay. Sorry. If we can't get it in 30 seconds, I'll just have people do a show of hands for me, the old school way.
Since we do have just a couple of minutes, any questions from the audience while we're setting up? Pretty self-explanatory.
Is it all in caps?
I don't think so. I think it's just
Yes.
capital D. Sorry.
That's okay.
Yeah, absolutely. So the question was about the use of azithromycin or macrolides to control inflammation. So azithromycin as well as clarithromycin are antibiotics that have been used for inflammatory responses, and they've shown decreased inflammation as well as the anti-infectious component. I have used that, but the biggest issue that I get is GI upset. So typically these are used long term, and in my patients, they can't tolerate more than 3 weeks. I don't know if that's different in your practice, but again, a great therapeutic, but the side effect profile is pretty strong.
We use azithromycin for treatment of severe asthma. For some patients, it does very well, but it's more of a long-term treatment, and so 6 weeks, 6 months, sometimes longer, and there are some people who just do not tolerate it. Hi, everybody. I'm Tara Carr. I'm very happy to be here today, and we're going to skip poll everywhere. I'll just ask for a show of hands. I am an allergy immunology physician at the University of Arizona. I'm a physician scientist. A lot of my research is in asthma, but I also have an interest in rhinosinusitis, and I am a big fan of this conference. I think it's really fun, and I welcome your questions, and thank you for your engagement. My disclosures were up there before. So I was asked to talk about medical management of rhinitis today. And so what I hope to cover in the next 20 minutes or so is recognize the common causes of rhinitis, identify the best patients for allergy-specific treatments, like allergen-specific immunotherapy, and then I'd like to share with you some novel pathways about non-allergic rhinitis that are sort of more, becoming more fleshed out and more informed, and is at the forefront of my thoughts going into the Quad AI. So we're going to skip that. So for patients I treat, allergy is a big problem. So show of hands, who thinks allergy is a big problem for the patients that they're treating? Okay, so almost everybody raised their hand. Okay, anybody think no? Or anybody not sure? Okay. And then can you tell the difference between allergic and other forms of rhinitis through physical exam? Who feels confident that they're able to differentiate allergic and non-allergic rhinitis on physical? Okay, I'm not seeing a little bit. Okay, thank you. So when patients walk into my clinic, just like they walk into Eugene's clinic saying I have polyps, they walk into my clinic saying I have allergies. But the first thing that I tell them is, I'm going to be the one to tell you whether you have allergies. You're here because you have a cluster of symptoms, and we're going to work through what those might mean. So the patients that come in complaining of environmental allergies usually have nasal symptoms, sometimes eye, ear, lung symptoms. But when they have nasal symptoms, what I teach the students is they're complaining of rhinitis. Really, that's the disease syndrome. And though our patients believe their symptoms are from allergy, they could be from other things. And if we ignore those other things as potential causes of their symptoms, we're really not doing them the best service. So as you all know, the function of the nose is to do lots of things to provide us with a nice lifestyle where we get to come to the desert and golf over a weekend in February, but also to filter particles, humidify the air, regulate the temperature, and of course olfaction. And the adult nose makes lots of mucus, and it's supposed to make mucus, and this mucus contains potentially beneficial and productive things like IgA to support immune function, other enzymes, antioxidants, cellular mediators that are maybe released as a result of what the nose is trying to do, but also really trying to protect us and maintain health. And in a healthy individual, it just gets cleared by the cilia, you swallow it, and you don't really notice it. Patients who start to notice it are the ones who are really, it's probably because they're making too much or it's of an abnormal consistency. So coming from Dr. Schleimer's group, Whitney Stevens led this paper from 2016, and this is one of the figures from the paper that basically just shows what the normal nasal mucosa looks like. So it's colonized with microbes. There's a small layer of mucus. There are submucosal glands that are making that mucus and that are secreting other proteins and enzymes, and then we have normal circulating immune cells. So when people have rhinitis, they're usually complaining of at least one of the following symptoms. Nasal congestion, so I'm feeling stuffy or congested. Drainage, dripping out the front, draining down the back. Sometimes sneezing, sometimes itching, and this, generally, we classify it as either allergic rhinitis or non-allergic rhinitis, but the reality is that allergic and non-allergic rhinitis can coexist in a lot of our patients. And the differential diagnosis of rhinitis when we see these patients includes chronic sinusitis with and without nasal polyps. We consider the impact of structural changes of the nose, like a deviated septum, turbinate hypertrophy, but also what about a perforated septum can cause a lot of these symptoms as well. What about cancers, inverted papillomas, other malignancies? When people have rhinitis, we, think about the allergy, of course, but really the nasal congestion that people complain of is because of swelling of that erectile mucosa. And the mucus production happens because there's increased mucus being produced from those seromucous glands, which have parasympathetic and cholinergic innervation. And the erectile mucosa has venous sympathetic and arterial sympathetic innervation. How many in the room use allergy testing to evaluate for allergic rhinitis? How about skin testing? Show of hands. Who has skin testing available in the office? Okay. Show of hands. Who uses blood testing to evaluate for allergy? Okay. Anybody not evaluate for allergy at all? Okay. Great. So we do allergy testing so that we can try to confirm a diagnosis of allergic rhinitis. And allergic rhinitis is very common. It affects more people than chronic sinusitis, that's for sure. And it affects children, adults. We think the burden is increasing over time for really unclear but probably multifactorial reasons. And allergic rhinitis, even though it seems like it should be sort of a minor thing, for some people it's a huge burden. They don't sleep well, they can't function at work, they miss school, they're more likely to get sick, and there's both a direct and indirect cost to that. The symptoms of allergic rhinitis don't really help you too much to differentiate between allergic and non-allergic triggers. However, these patients tend to sneeze and they tend to be itchy, which might give you a little bit of a sense that there's an allergy component. Patients often have eye symptoms and ear symptoms contributing. And then, of course, there's all the more like fatigue, headaches, not sleeping well, sort of generally feeling unwell during those allergy seasons. So what underlies allergic rhinitis? What differentiates allergic versus not allergic is the allergy part. Allergy is what we call a type 1 hypersensitivity reaction, which is an immediate reaction mediated by IgE antibodies. So generally what happens is you're exposed to an allergen. That allergen is presented to your immune system, and for reasons that involved innate lymphoid cells and the cytokines that Eugene was showing you earlier, your immune system starts to produce IgE molecules that are specific for that allergen. And those IgE molecules can circulate around the whole body and land on your allergic cells, the mast cells that are in the tissues and the basophils that are circulating in the blood. And then when you have a re-exposure to that allergen at some point in the future, that helps to activate those allergic cells. Those allergic cells release a variety of mediators: histamine immediately, cytokines, chemokines, arachidonic acid metabolites like prostaglandins and leukotrienes, which causes all the downstream symptoms that we see. So there's this very specific immune component for allergic rhinitis. And what are the things we look for allergic rhinitis? We look for things that are present year-round, potentially inside the home, like pet allergens, dog dander, cat dander, rabbits, horses here in Tucson. We think about dust mites, which can be year-round present, little microscopic bugs that live in our beds. Cockroach allergen can be pretty significant, particularly in some inner cities, and then mouse and rat exposures can be significant as well. And then for seasonal contributors, we worry about the pollens and mold, which can be present indoors, but most mold exposure is coming from the outdoor environment during those mold seasons. There's a Tucson pollen and mold calendar that we share with our patients. Tucson's a little bit special in terms of our pollen seasons, in that they're very long and they overlap. Those of you who are from the Midwest probably experience 3 discrete seasons of allergy, like one sort of in the early spring, which is the tree, one at the beginning of summer, which is the grass, and then at the end of summer, you get the ragweed. Here we have trees and weeds and grasses that start in like February, March, and then continue through August. So it can be really hard to tell what somebody's allergic to just based on when they're having symptoms. But we know what the patterns are, so we know what to expect if they have allergy to any of these given things. So on physical exam, as you guys know, you can look in the nose. Sometimes it's pale, sometimes it's pink, depending on whether you're catching them during a pollen season. Those who like the allergic salute have a bit of a crease here. You can see evidence of eustachian tube dysfunction. You can see the baggy allergic shiners. And then oftentimes we'll see significant postnasal drip and cobblestoning from that inflammation. So when we make a diagnosis of allergic rhinitis in the allergy clinic, the first thing is we're looking for the symptoms, right? Are they actually having symptoms of allergic rhinitis? Could they be having symptoms of another disorder? So we ask questions about the non-allergic disorders that we would consider. Then we look for allergen-specific IgE using a panel of environmental allergens, like I showed you before. We don't do food allergy testing for people who have rhinitis symptoms because it's just not indicated in the absence of other concerns. So we have a panel on the skin that we can use. We also have a panel in the blood that we can send called the Desert panel. And if you find IgE, either because the blood test shows that there's IgE there, or because on the skin test you get a wheal and a flare reaction, suggesting those mast cells were releasing histamine, then we say, okay, well, you have allergies to these certain things. But really the most important component is to match up the allergy testing with the symptoms somebody's having. Because if somebody is allergic on their allergy testing to mulberry tree pollen, which just comes out for a few weeks in early February, but they have allergy symptoms or rhinitis symptoms all year long, we can't attribute their symptoms to just that mulberry tree pollen that's happening for a few weeks in the spring. So it's really important to make sure that the patient is exposed to that thing, that they have symptoms upon exposure, that the testing and the symptoms really match. And if they don't, of course, then we work through our differential diagnosis. Who administers allergy shots in clinic? Show of hands for those who do provide shots in their clinic. Okay, so about half. We do, but we're in allergy practice. So how do you specifically treat allergic rhinitis? So the first tenet of allergy is to avoid the thing that you're allergic to, because then you won't have the disease. Of course, this is very hard to do. I can count on one hand the number of times somebody has given away a pet that they're allergic to. So we do the best we can to sort of mitigate those exposures. For dust mite allergy, we try to get people to put covers on their mattress. For pet allergies, we try to keep the pets out of the bedroom and put HEPA filters in the rooms. If there's mold in the home, get that professionally remediated. And then during pollen seasons, do the best you can, put the air conditioning on if that's possible, but here in Tucson, this is the nicest time of year, so we really like to go outside. Allergy is an inflammatory disease, and just like Eugene was showing, the intranasal steroids are a great way to treat inflammation. We consider intranasal steroids to be the first-line therapy for our patients with allergic rhinitis, because by the time they're coming to see us, they're having symptoms pretty frequently, or their symptoms are pretty significant. You don't have to use intranasal steroids for people who have very intermittent symptoms, where something like an allergy antihistamine pill would be useful. Intranasal steroids work best if they're used regularly, and while there is always that concern from patients about cumulative steroid exposure, I think we all feel really comfortable prescribing those intranasal steroids because there's great data that suggests it's a very low dose, locally acting, and shouldn't cause that long-term disease side effects from steroids. There are a variety of different medications available over the counter, by prescription, and we really prescribe whatever we can get for our patients. Some of our patients can't afford the ones that are available over the counter, and so we have to lean towards the prescription versions. For people who don't like the drippiness that's associated with nasal steroids, there's the Flonase Sensimist, which used to be called Veramist. It's like a less volume mist in the nose, and there's 2 aerosols, and then of course the Optinose Xhance. Another favorite that we prescribe are the intranasal antihistamines. So these are technically second-line therapy per our allergy guidelines, but can be absolutely used on their own or in addition to nasal steroids for treatment of all of the symptoms of rhinitis: drippy, congestions, sneezing. These work pretty quickly, so the onset of action can be within 20-30 minutes, and so it can be used as needed, but they're also very, very safe to use regularly. So as a decongestant, a much better option than the oxymetazoline that your patients might be reaching for. The two that are available regular are azolastine and olopatadine. Azolastine is available over the counter. The taste is an issue for some of our patients. I say it's terrible here because the one time that I tried it, I was sick for 24 hours. But a lot of our patients use it all the time and have no problem. But olopatadine is an alternative where the taste isn't as much of an issue. I think there's a taste bud genetics that informs some of the side effects. Oral antihistamines, a lot of our patients have come in saying they've tried everything over the counter, and what they mean is they've tried a couple of different antihistamine pills. We do encourage antihistamine use for our patients who have allergy. It's easy to take a pill, and the newer generation antihistamines, the ones at the bottom here, Claritin, Clarinex, Zyrtec, Xyzal, and Allegra, are very well tolerated. They tend to be less drowsy than the first generation. And with the first generation antihistamines, there's more and more data about concern for regular use of antihistamines contributing to dementia. I have a couple of patients who have dementia that I'm really concerned are because of overuse of antihistamines. And so I think it's real. And so we go for the cleaner second generation antihistamines, either regularly or as needed. The leukotriene antagonists, there's two available on the market, montelukast and zafirlukast. Montelukast is once a day, that's singular. Zafirlukast is twice a day. This is a medication that blocks leukotriene. Leukotriene is released by mast cells in the tissue. For some people, it seems to be a big problem because these medicines are helpful. For other people, they don't do anything. Beware of the patient who's been taking montelukast for 10 years and has no idea if it's helping them. You might want to stop it and see how they do. Oftentimes, they'll do just fine. I do want you to warn your patients if you're prescribing them montelukast about the potential for mood changes. There's a black box warning for neuropsychiatric disorder that goes along with both of these medications. It is real. I have seen it many times, and if you don't warn your patient about it, you're setting them up for potential for anxiety, depression, suicidal ideation, or worse. We love the saltwater rinses. We encourage our patients to do flushes, neti pot, navage, rinse out that pollen, rinse out the dust mite enzymes that are in there, get the mucus out, and it'll help you feel better. So we use these liberally. We tend not to encourage systemic decongestants. We tend never to offer intranasal decongestants unless there's extenuating circumstances. Some of our patients like the intranasal cromolyn, which is a mast cell stabilizer. It needs to be dosed very frequently. It's available over the counter, but it's really no side effects. So for your patients who don't like medicine, this is something that they might like. And then the intranasal capsaicin I'll mention later. So immunotherapy or allergy shots is like our special treatment that we can offer patients who have allergic rhinitis that might actually improve their disease state potentially permanently. So immunotherapy is a long-term treatment where we're giving sort of increasing doses of an intervention over months and years to change the immune system. This is different than desensitization to an antibiotic or chemotherapy, which is more of a temporary state of tolerance. So what does allergy shots do? When you start allergy shots, it starts to change the immune system. You start to make less of that IgE over time. You start to make more like blocking sort of anti-inflammatory antibodies, and then people start to feel better. And it can happen within the first few weeks to start the immune system change, can improve symptoms over the course of a year or more. There are subcutaneous and sublingual doses of this, but there is risk of reactions, and so it's not the easiest thing for people to do. The three conditions required for aeroallergen immunotherapy to be successful include, one, that the patient's actually having symptoms with exposure, so they really have that diagnosis of allergic rhinitis. They actually have IgE antibody that you know you're going to try to get away with the immunotherapy, and the patient needs to receive a big enough dose to change the immune system. This means enough of a concentration at a frequency and for a duration that's going to really affect that immune change. There is a significant placebo effect of injections, which is widely recognized, but we'd like to do better than placebo. So subcutaneous immunotherapy or allergy shots is, again, not easy to do. This is something that we can give to children. Of course, you don't want children to be dragged in kicking and screaming to get a shot every week. So ideally, you need to have a patient who's able and willing to tolerate injections and who can communicate with you if they're having an adverse reaction to the injections, which can be mild or can be anaphylaxis. If a patient has comorbid asthma, that asthma should be very well controlled. Otherwise, you're at risk for causing them severe asthma exacerbations. Beta blockers can make it harder to treat an allergic reaction and can make allergic reactions to immunotherapy more severe. So the patient should be off beta blockers, and they should be compliant with the treatment recommendations, nice to the nurses, good communicators, and coming in regularly for their shots. In your office, if you're considering starting an immunotherapy practice, you have to have a physician or a mid-level provider appropriately trained at all times to monitor for and treat allergic reactions. Generally, this means that there's epinephrine available, usually through EpiPens or through other auto-injectors, in addition to other kind of supportive care. We always watch patients for at least 30 minutes after the injection. That's really the standard practice in the allergy world because most of the allergic reactions will happen during that 30-minute time period. And there are a lot of details that are required for when you're mixing vials because people get a vial that has the stuff that they're allergic to in it. So they have a prescription, they have a mixture. You have to know when that mixture expires, make sure it's being kind of properly monitored, kind of like a pharmacy. And then when you're starting injections, we use dilutions to make less concentrated levels of the allergy shots, and then people come in dosing weekly, sometimes a couple times a week, with increasing doses, and over time, their symptoms will improve. Once they're at the top dose, many patients can space out to monthly injections, and will continue monthly injections for somewhere between 2 and 5 years, often longer if needed. There are dose schedules available on the internet on the allergy practice parameters, both for ENT and for allergy. Sublingual immunotherapy is a good option for some patients. Here in the US, there are FDA-approved tablets that can treat ragweed allergy, which is a big problem all over the country. The northern grass families, like the Timothy grass family that includes rye, bluegrass, and then dust mite. There are homemade cocktails that people will often prescribe. They tend to be more dilute and so aren't as effective as the subcutaneous forms, and there's not really great data on the dosing required to reach that level of efficacy for the sublingual drops. When we dose sublingual immunotherapy, there are a couple of different ways to do it. For the seasonal pollens, like if you know that your ragweed season starts at the beginning of August, you can start somebody with their sublingual tablets 12 weeks prior to and during that season, and it can help them for that season. They can also take it year-round for a few years and potentially get the same, maybe long-term benefit that people who are taking allergy shots will. For sublingual immunotherapy, you can administer the first dose in the office to ensure tolerability, teach the patient how to do it. They dissolve it under their tongue. They try not to swallow for a minute, and then they don't eat or drink for 5 minutes afterwards. And then they can use all the rest of the tablets daily at home. Usually EpiPens are prescribed just in case. So in summary, if we're treating allergic rhinitis, we can reduce our allergen exposures, we can use medications to manage symptoms, and then we can use immunotherapy as a more long-term treatment to reduce the actual allergy. Of course, there are a lot of people who don't have allergic rhinitis or will have symptoms despite appropriate treatment of that allergy, which includes allergy shots. And so then what are we dealing with? We're probably dealing with non-allergic rhinitis or something else on that differential diagnosis. So raise your hand if you understand the role of the nervous system in non-allergic rhinitis very thoroughly. How about not at all? Maybe somewhere in the middle. Okay. So we'll talk just for a couple minutes about non-allergic rhinitis, which, when we bring people in and we do a panel of 50 different environmental allergens and none of them pop up. And so either we're missing something or they're just not allergic. And so their rhinitis symptoms are being driven by a different pathology. So they have rhinitis, but it's not IgE mediated. We don't really know how frequently this happens because it can coexist with allergic rhinitis, and so if you use this as a diagnosis of exclusion, it's a little bit hard to figure out prevalence. But we do know that non-allergic rhinitis is a risk factor for developing asthma as well as for having asthma in childhood and adulthood. There are a few different ways that we classify non-allergic rhinitis, and this is one of them. So some non-allergic rhinitis is considered to be more inflammatory. There's this non-allergic rhinitis that has very eosinophilic mucus that tends to respond to steroids very well and might be sort of a precursor or comorbid to nasal polyps developing. There's atrophic rhinitis, which is like a inflammation related to destruction of the nasal cavities that can be associated with a lot of bacterial colonization. And then on the other side, there's this neurogenic dysregulation. Usually we think about rhinorrhea of the elderly, where you just have like a little old lady whose nose is running constantly, or this gustatory rhinitis where people sit down to eat and their nose starts running. This vasomotor rhinitis or idiopathic rhinitis is what we'll sort of focus on for right now. This is a nasal hyperresponsiveness to irritants. And I think most of the patients that I meet who have non-allergic rhinitis fall in this category because they describe that changes in weather, going from inside to outside with the air conditioning or the heat on can trigger their symptoms. Strong odors give them congestion or make their nose run. Perfumes, cigarette smoke, the smell of the newspaper. So these are sort of irritant stimuli that trigger rhinitis symptoms. So to teach you a little bit about the nervous system, now I had to really learn the literature on this, and I can't say I'm an expert, but what I will share with you is that there's different kinds of sensory fibers, and the C fiber is a kind of a slow processing fiber, but it contains these nociceptors, which are receptors for noxious stimuli. And so these C fibers get triggered by things like spicy food and heat. And we think that they're responsible for some of the disease in vasomotor rhinitis. And how is that? Well, you have these sort of sensory nerves. Can you see my? There you go. These sensory nerve endings, and if you have a stimulus, an irritant that can trigger vasomotor rhinitis, you can have what's called antidromic release of neuropeptides. So you don't even have to have signaling down the whole length of the nerve. You can have just this very local, like branch to branch reflex, where the branches of the nerve will distribute and release neuropeptides like substance P. Substance P has been in the allergy literature forever, and it's known to induce local vasodilation, serum extravasation from those vasodilated capillaries, mucus hypersecretion, and potentially recruitment of inflammatory cells. Another thing that can happen is the actual parasympathetic response. So you have a stimulus, and you can have, your sensory nerves can go all the way back to different ganglion, and the nerves, the actual parasympathetic nerves, can then release acetylcholine, for example, that acts on muscarinic receptors, neuropeptides like VIP that increase that glandular discharge, the mucus production, vasodilation, and rhinitis symptoms. The TRP channels, this transient receptor potential cation subfamily channels, or capsaicin receptors, are channels on these C fiber neurons that detect the irritant stimuli, and we think these are contributing to the disease process because it turns out that patients with non-allergic rhinitis have more of these TRP channels than people who don't have allergic rhinitis, and if you administer capsaicin to somebody with non-allergic rhinitis, their symptoms get better, but also their TRP channels downregulate. So there's a sort of this interest in understanding how to downregulate some of these receptors to reduce the sensitivity of the nose so that people are just less responsive to those environmental stimuli. And then finally, in this one paper with Dr. Bernstein's group, they studied the effect of different medications on TRP channels, and it turns out that azolastine might downregulate some of these TRP channels and other nociceptors in the nose, and so that might be one reason why azolastine can be helpful for patients with non-allergic rhinitis. I joke because it's an irritant, because it tastes bad, but I think more studies need to be done with additional medications that potentially can help to affect and downregulate these nociceptors and their activity. I'll just say a quick note that ipratropium bromide as an intranasal anticholinergic can be very helpful for some of the rhinorrhea, for some of the mucus secretion component of patients who have non-allergic rhinitis, both the vasomotor form but also the gustatory form. So you sit down at dinner, your nose starts running. These patients do great with ipratropium generally. So in summary, allergen immunotherapy can be helpful for patients with allergic rhinitis in addition to all of those other medicines that I discussed. Non-allergic rhinitis can mimic allergic rhinitis and has these sort of cool potential new neurologic triggers that may help us to better identify therapy for our patients and control the disease. So thanks very much for being here in Tucson, and I look forward to your questions.
Thank you so much, Tara. Just in the interest of time, we may postpone our questions to our panel, if you don't mind. I'd also like to introduce Dr. Troy Woodard. He's our guest of honor. Thank you, Troy, for coming out. I know you had extensive travel plans, so we appreciate you taking the time to come out here. Troy is pretty inspirational if you take a look at his path to medicine, and he's also an incredible advocate for patients, for physicians, and will be the new president-elect of the AAO. I know he's going to do a fantastic job. Thank you again, and he'll talk to us about the surgical management of rhinitis.
All right, good afternoon, everyone. I'm Troy Woodard. Thank you for the opportunity to speak today. We're going to be discussing surgical and office-based management of non-allergic rhinitis. These are my disclosures. So I'm going to give you a brief overview and discuss the etiology of non-allergic rhinitis. We will review surgical and office-based treatment options, really discussing how you select a patient, medications needed, office equipment, how to perform the various procedures. We're going to do it in a case-based format, though. All right, so you're in your office, and in walks a 58-year-old lady with rhinorrhea. All right, she says it's persistent, right-sided mostly. She does report some postnasal drip. Now, her symptoms are bilateral congestion. It's sporadic, but seems to have constant drainage. She notes it's worse with temperature changes, worse when she lays down, and also she noticed it gets worse when eating. She has a history of chronic cough, gallbladder. She's currently on fluticasone nasal spray and occasionally uses saline rinses. All right, so after your history, you go do an exam. You notice copious secretions in the middle meatus. It's aerated though, no pus, no polyps. So you form your differential diagnosis, right? Think of CSF leak because she talked about mostly unilateral rhinorrhea, but you also have to consider the other forms of rhinitis, right? We heard about allergic rhinitis, and could it possibly be non-allergic rhinitis? What tests would you do? Well, generally you want to rule those things in your differential out. So you do a beta-2 transferrin test, it comes back negative. You do either a RAS test or a skin prick test, those are both negative. So that leads you to think, okay, well, she doesn't have a CSF leak, she doesn't have allergic rhinitis, it could possibly be non-allergic rhinitis. And if you think about her treatment, she's already on fluticasone. You put her on azolastine, and we've heard from the previous speaker that that's been shown to downregulate actually some new channels that I've just heard about. But hey, she gets some improvement. Now, what about ipratropium bromide? All right, the patient says, well, yeah, I tried it and it's partially improved, but I still have symptoms. So we as surgeons try to, after we treat patients with maximum medical therapy, the next step is surgery. Based on her history, her exam, her response to various types of nose sprays, we confirm a diagnosis of non-allergic rhinitis, particularly vasomotor rhinitis. So let's talk a little bit about non-allergic rhinitis. I'm going to briefly go through this because we just learned about it, but it oftentimes is associated with chronic nasal congestion, obstruction, rhinorrhea, and it's not related to a specific allergen or skin or serum testing. Typically, it occurs in patients who have an older in age, more common in women. It usually results in an impaired quality of life, like patients You know, I have these patients all the time that come in and says, oh, I'm so miserable, this postnasal drip, this nasal congestion, you gotta help me, doc. I know you can cure me. And then that's when I go, uh-oh, it's gonna be bad. But anyway, and so vasomotor rhinitis is the most common form, triggered by, you know, environmental conditions such as weather, strong emotions, irritant smells, sometimes hormonal. Now, we just learned about the pathophysiology, usually associated with dysregulation of sympathetic, parasympathetic, and nociceptive nerves. Mucus secretions controlled by the parasympathetic nerves, vascular tone controlled by the sympathetic nerves. Let's see, okay. So again, just to quickly repeat this, we have preganglionic parasympathetic fibers coming from the greatopetrosal nerve. They actually synapse in the pterygopalatine fossa in the ganglion, and then they branch to go to the lacrimal gland which produces tears, and the nasal and palatine glands which produce mucus. The postganglionic sympathetic axons come from the deep petrosal nerve. They do not synapse in the pterygopalatine ganglion, and they continue and travel on to, you know, branches and follow the branches of the maxillary nerve and provide sympathetic innervation to the blood vessels. So again, parasympathetic controls all the mucus. Sympathetic nerves tend to control the vasodilation or constriction of the blood vessels. So let's move back to our case. Remember, partially controlled with ipratropium and the Flonase and Astelin. So we confirmed her diagnosis of vasomotor rhinitis. She's failed medical therapy. What are our surgical options? Well, we can do just surgery in the operating room. That really entails an endoscopic video neurectomy or a posterior nasal nerve ablation. All right, let's talk about the different types of endoscopic video neurectomy. Actually, I'm just going to kind of condense this into one type because it's just some minor nuances that are associated with those two types, but the main, I guess, procedures are the same. So when we're doing the transsphenoidal endoscopic video neurectomy, you want to create a large sphenoidotomy. And then once you approach that, you're going to remove the mucosa along the anterior face of the sphenoid and typically go laterally until the area of the video nerve. Let's see if I have okay, let's go back to this CAT scan. Here, this is a coronal view of the sphenoid sinus. You can see the two arrows, and they're pointing at the Vidian canal. This is the area, remember, where the parasympathetic nerves come through and branch into the pterygopalatine fossa anterior to this, and then they go and innervate the lacrimal gland and the mucus glands in the nose and palate. All right, so again, large sphenoidotomy, you're going to remove the sphenoid process of the palatine bone until you actually come in contact with the Vidian canal. A lot of times you'll see nerve fibers, but before then you'll actually get into a pretty good sized vessel. Usually it's controlled with suction bovi, co-blader. You're going to cauterize the nerve. There's been some studies that demonstrate that resection of or transection of the Vidian nerve is actually beneficial. And in a study of about 400 patients, they noticed only three recurrences over a 2-year time period. This is a video that illustrates how to perform the endoscopic video neurectomy. Again, we're going to this area in the lower lateral portion of the sphenoid. So we're drilling out sphenoid sinus, we're going lateral. We're isolating the Vidian canal here. To get down to this bone, you use your suction bovi and just cauterize the mess out of that. You get down to clean bone and then take your drill and kind of go laterally and inferiorly until you come in contact with the Vidian canal. To confirm your placement, oftentimes you can use navigation. You can see the nerve right in here. It's sectioned. It actually didn't bleed too much in this encounter, but oftentimes you will get some bleeding from the associated blood vessel. We apply cautery, and afterwards then we apply like some bone pate or bone wax to prevent any like redevelopment of the nerve or reattachment of the nerve. And it's pretty simple. All right, so what are the potential complications for this? Well, Halderman did a systematic review of 6 studies, and really they noted a couple of, I guess, complications that sort of stood out, right? Remember, this nerve actually innervates both the mucus glands and the tear glands. And so if you transect that, your patient is going to have dry eyes. Also, since it's located in the pterygopalatine fossa area, it may be, you may also have some collateral damage to the trigeminal branches. So they could have cheek, palate, and gingival numbness. I've noticed in some of my patients, I don't do this all the time, especially now with some of the office-based procedures, but when I did perform this and the patients did report dry eyes, usually it resolved in about 6 months to 1 year's time. Other potential complications associated is nasal crusting and hemorrhage. Now, there's another technique in which you are, I guess, more direct in where you're going to ablate, and this actually occurs downstream from the Vidian nerve, and you're actually transecting the posterior nasal nerves. And if you do this portion, let me show you here. There's the maxillary sinus. We remove the mucosa posterior and inferior, and you saw a large posterior nasal nerve right in here entering the mucosa along the inferior turbinate. Now, if you transect that, you're able to bypass the deinnervation of the lacrimal gland. This is on the opposite side. Again, what we do is elevate the mucosa, extend posteriorly. You will see, you will encounter the sphenopalatine artery here. We like to control that by clipping. Continue to dissect inferiorly and posteriorly, making sure you transect all the posterior nasal nerves that exit here. Once you do that, we'll stick. So this is courtesy of Dr. Do Choi. He's elevating, creating a little pocket here. So then he can place tissue such as like an alloderm there to help prevent regeneration of and connection of that posterior nasal nerve again, reinnervation of that. And then just place some Surgisil over the defect. So again, this accomplishes the same thing, except because you're transecting the nerves further downstream, you don't have to worry about deinnervating the lacrimal gland. All right, so the patient says, yeah, that sounds great and all, but I don't want to have surgery under general anesthesia. And so then you can say, well, all right, we do have some office-based procedures. So let's discuss this, all right? There are typically 2 different ways the office-based procedures work. One is by using nitrous oxide to ablate the posterior nasal nerve, so cryoablation. The other is by using a temperature-controlled radiofrequency technology to ablate the posterior nasal nerve. Usually when we do that, we apply decongestant. Oftentimes, because we're dealing with nerves, there's associated pain post-operatively or post-procedurally, and so we'll prescribe gabapentin about an hour before the procedure. It's been shown to reduce immediate and delayed discomfort. Anesthetics is kind of variable, but in my institution, we use a mixture of lidocaine and tetracaine. It can come in a spray, and some people oftentimes use it as a gel and wipe it over the area. You can also inject They have special needles. Certain companies have special needles that are bent so that it can actually, you can actually inject along the lateral wall in the nose. And post-procedurally, I usually don't prescribe opioids. Usually NSAIDs or even Tylenol is good enough. Let's talk a little bit about the cryotherapy procedure. So you're gonna medialize the middle turbinate. Here we are injecting with that curved needle right into the junction of the middle turbinate and lateral wall, right anterior to the area of where the sphenopalatine artery exits. Once it's numb, you're going to place the device in that crotch. You can see placement of this device in that crotch, and you hold it in place. Now the nitrous oxide is performing cryoablation to that nerve that exits in that area. You have to wait, though, before you remove the device or it'll rip the skin. You can see the blanching, the lesion that it forms after you've done the procedure. Oftentimes, the nerves come out at different spots, and it's kind of variable. And so that's why you'll see me using the cryotherapy in different regions, trying to make sure we get all the points of where that posterior nasal nerve exits. So Chang actually performed 98 procedures using cryotherapy and was very successful, able to complete it 100% of the time. They noticed that the patient's symptoms, which they used the TNSS questionnaire to measure, actually improved up to 9 months. They did, however, notice 29 adverse events. And the majority of those were the headache. Sometimes the patients get like an ice cream headache, which can be pretty painful. And that's why we prescribe gabapentin prior to the procedure to help dull that headache. Sometimes, and it's rare, but remember, you're forming a lesion in the nose, and if it's not moisturized, just like anything else, it can form a scab and cause nosebleeds once that scab is removed. Let's talk about radiofrequency ablation of the posterior nasal nerve. This is slightly different. Where the other device uses cold temperature, this is the opposite. It uses temperatures targeted, actually controlled at 60 degrees Celsius. It spares the surrounding tissue, and the patient selection is pretty much the same as how you would select someone using cryotherapy. So basically, you take the wand and you go back in the crotch again, and instead of instilling nitrous oxide, this uses radiofrequency ablation, and you hold the wand in certain areas for a certain amount of time. Again, you're moving from a posterior to anterior inferior manner along the inferior portion of that crotch onto the inferior turbinate, going along the pathway of that posterior nasal nerve branch. Here's a video to just illustrate how this is done. You're inserting your probe into the crotch. Again, it's just above the inferior turbinate, and you place it laterally against the nasal wall. Hold it for a period of time. And nowadays, these machines are very smart, so they'll let you know when the time is up. They'll give off a ding to let you know. And you can start to see, like the cryotherapy, blanching of the targeted area. And so you just continue that, move it along the path of the posterior nasal nerve. So there was a study that looked, did a prospective trial and had 52-week follow-up. They had 47 patients, and like the cryotherapy study, patients who received radiofrequency ablation also had improvement in their symptom scores. They had a sustained reduction in rhinorrhea, nasal congestion, nasal itching, and sneezing at all time points. There were also 16 adverse events reported, and they ranged everywhere from a case of dry eyes to nasal soreness, nasal drainage, and pain as well. It's not released yet, but there is a newly designed radiofrequency device that sort of builds off of the previous device. And basically, it is a mini electrodes, if you can see here. And the thought is based on the premise that the posterior nasal nerve has multiple branches. It just doesn't come out in one spot. And so they designed this probe to be able to come in contact with multiple areas at the same time. Here is a video to demonstrate how this is used. Now, it looks a little funny, but you will see where the other instruments you have to actually do multiple times. The design of this allows you to hit multiple spots in one or two instances. And so if you wonder, okay, well, it's hitting the septum and the nasal pharynx, eustachian tube, well, it's smart and it knows, so it's interesting, it's smart and it knows not to turn on at those particular sites. And so when you place it in the nose, on the device, you will see these, some of the little rings light up green, others will light up like blue or red, and you'll know which ones are actually firing at the time. This is actually still being developed and refined, and is not available for purchase at this time. So in conclusion, non-allergic rhinitis is a common disease that really impairs the quality of life of our patients. As we discussed, it results from dysregulation of sympathetic, parasympathetic, and nociceptive nerve signals. And when medical management fails, targeted therapy via surgery or office procedures are a valuable alternative. I guess we'll save the questions for our panel. Thank you.
Thanks so much, everybody. I'd like to ask our panelists to come up. You've already met Dr. Troy Woodard, Dr. Tara Carr. I'd like to introduce my partner, Dr. Chris Lay, who's one of our sinus and skull-based surgeons, as well as the director of our fellowship. I see Dr. Puneet Shroff coming up as well, too. Dr. Shroff is our allergist and immunologist. Also has a secondary fellowship in alternative medicine. And then Dr. Robert Kern, who's coming up here as well too. We were just speaking of you in terms of one of the pioneers in promoting a multidisciplinary clinic. So I have just a couple of brief cases that I'd like to go over, but it's really for discussion as well as to open things up for questions as well. I know that this afternoon first session was a little bit of a whirlwind. And so I think many of these questions might be answered by this panel, but if not, please go ahead and feel free and ask them as well. We're fortunate here to have both allergists, immunologists, as well as otolaryngologists. Maybe we can start off the panel. I've talked to you a little bit about our institution and our practice, but can you go over in your practice, Dr. Woodard, as well as Dr. Kern, how you interact in a multidisciplinary clinic and what potential advantages you see that happening?
Okay, I'll go first. Well, we started seeing patients together years ago when Dr. Peters was just finishing fellowship. And the patients love it. They get kind of a complete, I think a pretty complete evaluation. Obviously, we're looking at all aspects of the airway. and they get sort of a one. Now there are issues with billing and everything. They have to get 2 co-pays and everything else, but especially in an urban environment, patients love it. We have a CT scanner there. They get their allergy testing. They get it all done, so it's kind of one-stop shopping.
Well, unfortunately, we don't have a multidisciplinary clinic, and I'll just talk about, I guess, the stresses that it causes the patients, right? And so oftentimes we have to co-manage their asthma with their allergic rhinitis or chronic sinusitis. And yes, we can communicate freely and make phone calls, but oftentimes, there's a delay in patient care. And I think by having a multidisciplinary clinic, you guys can avoid that.
Yeah, I mean, you're looking at the CT scan together. You're looking at she's looking at the endoscopy on the screen, and the patient gets the idea that they're getting a complete evaluation. Patient satisfaction is enormous.
I'd also add to that, I think 2 weeks ago, so our allergy fellows rotate with us. The biggest smile I ever got from a patient was when I introduced the allergy fellow and myself, and I said, "You have 2 doctors looking after you today, both an allergist as well as an otolaryngologist." And I think that really speaks to how we can combine our efforts for improved care. So in terms of our case history here, this is a 50-year-old gentleman. These are all real cases from both myself as well as Chris's clinic. Over 20-year history of nasal obstruction, facial pain and pressure, as well as a loss of smell. And got referred to you by his local doctor who had been treating him with multiple courses of oral steroids as well as steroid injections. So he would go to his primary care physician, he told me, a big shot in the butt, and then feel better after about 2 or 3 months. But then 2 or 3 months would pass and his symptoms would come back. He does have asthma, but he's very physically fit. He plays basketball with his kids, and the minute he noticed that this was really affecting him was when his kids started beating him in basketball, just because he was short of breath. And so the outside ENT doctor performed a complete endoscopic sinus surgery, but returns 2 years later to your clinic. And so I'd love to ask the panel here, are there elements in the history, just by speaking with the patient, that can help delineate some of those molecular endotypes that Dr. Robert Kern as well as Dr. Terakar were talking about in terms of the molecular biomarkers for sinus disease? Also, when looking at these patients with chronic sinusitis, what are some red flags that we should be aware about? For instance, if we are seeing these patients solo and we don't have an allergist or immunologist close by, are there certain things that we feel comfortable treating, certain things that we don't feel comfortable treating? And what questions should we ask about comorbidities? So I'll open this up to the panel. Maybe, Dr. Kern, since you gave a great talk on endotypes during the lunchtime, would you mind kind of starting us off with elements of the history for type 2 inflammation?
Yeah, I mean, presumptively this was polyps, but the loss of smell, the concomitant asthma, this is probably 95% chance type 2, 97% chance type 2, something like that. Not always. We had a patient on Monday that wasn't, but overwhelmingly likely that that's the case.
I think his response to steroids too make me think it's probably a type 2.
Absolutely, yeah.
So, hi everyone, I'll just jump in. I think before I address it, part of this conversation that Dr. Carr had and Dr. Chang started is that I think we all, not to undermine our boards, but I think now everyone's kind of an immunologist. So this is exciting for everyone to think about and to be having these discussions as a group. But just to highlight some of the things, obviously I think no one is excited about this patient continuing to receive multiple rounds of corticosteroids, even though he's a male, but certainly male-induced osteoporosis and other side effects may exist, especially in an aging individual. So I know that's certainly a red flag. But just coming to the endotyping, I think as allergists, immunologists, and physicians who see a lot of asthma, certainly the asthma really jumps out in terms of his underlying history, his progressing and worsening symptoms. Certainly, as we were hearing about the involvement of the airway, not just the nasal and sinus, but also the lower airway. And so certainly thinking about, type 2 inflammation for my colleagues here on both sides, and starting to identify biomarkers, or assess, I should say, specific biomarkers, which I'll let maybe Dr. Carr jump into as well, I think is a good, from our standpoint, a good starting point to really, kind of narrowing it down. And if you want to go ahead and touch on that.
I think for just like nasal polyps are a chronically progressive disease, and chronic sinusitis can chronically progress. Asthma can be a chronically progressive disease too, where people get remodeling of the airway and more inflammation. And so that could be responsible for this like progressive worsening of the patient's lung function and inability to beat his kids at basketball. But there are some like more severe disease states that we certainly would want to evaluate and rule out. I think the aspirin exacerbated or NSAID exacerbated respiratory disease, Samter's triad cluster, those patients tend to have more severe disease that's both steroid responsive and type 2 inflammation, but their asthma can be quite significant, and these patients sometimes need more aggressive therapy to improve their disease. And so asking about alcohol-induced symptoms, NSAID-induced symptoms, I think will be very helpful. Another thing I would be worried about for a patient who's of this age, who has a chronically progressive condition, if he's not playing basketball, if it's just the lungs, okay, but sometimes we'll see like the early vasculitic stage of like EGPA, like a Wegener's granulomatosis. So Church-Strauss syndrome, I'm sorry, and that can be a sinopulmonary disease that presents with type 2 inflammation, but that can progress to have neurologic symptoms and can cause people to get quite sick and have it sort of chronically progress. So I would sort of screen the patient for both of those things while I'm doing lung function testing and the regular like blood eosinophil counts, maybe exhaled nitric oxide and IgE evaluation.
Yeah, no, so it's amazing. It's almost as if I gave you these questions before, and I promise I didn't. But I do remember, seeing and evaluating my first Church-Strauss patient, and it's incredible. I mean, we think of asthma, and we say, yeah, well, a lot of people have asthma. It's one of the most common chronic disorders. But if they come into your clinic, they may not have been diagnosed before, and you're responsible for them. I think it's really pertinent, if you're seeing this, to ask them about inhaler use, chest tightness, shortness of breath. What are some symptoms of Church-Strauss that might be able to help us if we see these patients and help us to evaluate, hey, is this somebody that can be seen by our immunologist or our rheumatologist or our pulmonologist in the next couple of months versus a more pressing scenario where you might get on the phone and talk to your colleagues?
Yeah. That's a good question. So, we might be thinking about the same patient who had Church-Strauss, and he'll always be the person that I think about when I think about this disease. Adult onset sinusitis and asthma that was really having flares, requiring a lot of treatment with steroids, occasionally antibiotics, and had some peripheral blood eosinophilia. And it wasn't super high, but it was, 300, 500, something like that. And so what happens with these patients is they have this eosinophilic, like, prevasculitic phase where they just hang out with the respiratory disease and have high blood eosinophils, and their ankle levels can be negative and everything else can be negative, but these are sort of the early markers. And then it turns into the vasculitis, and that's the potentially life-threatening phase where people have more severe disease. They can have more severe lung and sinus disease, but they can also have neurologic symptoms. So my patient had foot drop. He had a vasculitis that affected his GI tract, and so he was having GI bleeding, and just like really, really sick. So if the patient has any neurologic symptoms, or if they're like having failure to thrive, if they have any more systemic symptoms, I would be very concerned, and that's when you are more likely to get those positive ankle levels.
Yeah, I think it was the same patient. Patients will tell you their life history, whether you want to hear it or not, and they'll talk to you about their foot drop and their stomach issues, and oftentimes we're so quick to kind of focus on the airway, but picking that up is very, very helpful.
I would just make one additional plug alongside it, just maybe thinking about it. With this patient having had surgery a couple of years ago, certainly many of you, whether you're in academic centers, hopefully the tissue is being sent for pathology and analysis, but that doesn't always happen, sometimes in the community or depending on where, where you're doing your surgeries. And that's something that can be really telling, whether it's for this particular case that you guys are discussing, but even with other patients, because when they do recur and come back, even though we know that most patients, like Dr. Kern said, or especially in the Western world, are going to be type 2 inflammation, we don't want to miss those, more alarming, disease states, whether it be GPA or others, and that's just something that I know we often discuss as a group amongst our allergists, ENTs, et cetera. So.
Before you start showing the slides there, this may be because I've been practicing with Anju for so long, but from a statistical standpoint, maybe this case is going to be eGPA. It's great to present something like that, but there are probably 7,000 eGPA patients in the country and 3 million polyp patients.
Correct.
So it's going to be rare. You may go your whole life without seeing one. I would suspect Anju would be concerned that maybe this patient is developing bronchiectasis with this sort of asthma and smoldering sinusitis that's probably been undertreated.
Especially if it's not type 2. So if it's type 1 and it's more likely infectious, then we think about primary immunodeficiencies that can contribute to both the sinusitis and the bronchiectasis. Yeah.
Or T2-3, the 2-3 ones is what you'd be concerned about. But I mean, statistically, that would be more likely than eGPA.
Absolutely. Well, I will break the news. This is not an eGPA patient. This is just a standard polyp patient. But more, we were talking about zebras, or one of our facial plastic surgeons this morning was talking about zebras. And so just knowing those, I think, can be helpful in our overall awareness. So I won't have anybody go through the imaging, because I think the imaging is pretty self-explanatory. I go through these with my patients in clinic, and I kind of take them through the entire anatomy, and it's fun for them because it's an anatomy lesson. But what I'd love to gauge from the panelists, particularly the surgeons on this panel, when do you pursue imaging for patients with CRS? And what I mean by that is, do you treat them maximally medically, even if they might have already had maximal medical therapy, and try and get them as clean as you can and get as clean of a CT as you can to see what might be residual? Or do you get this in the very beginning? Do you get this for baseline? Do you get this for surgical procedures? Many of us are seeing patients that have already had maybe a cone beam CT scan or a scan that comes in the office. So how do you look at timing, and what makes you think about when to pursue imaging?
So I think it depends on the type of CRS we're looking at. So if they've been sent by one of our community providers, they've been already worked up. They probably already had really good sinus surgery. They've probably been on oral and topical antibiotics. So at that point, if they're coming to see us and they have old CT scans that's maybe 3 to 6 months old, because sometimes it takes a while to maybe see Dr. Kern or Dr. Woodard or Dr. Chang and myself. At that point, if we're having a discussion and we talk about exhausting medical therapy and we gauge the patient on what they want to do, whether go towards biologics, more medical therapy, or surgery. If they're leaning towards surgery, that's when I would probably get a scan when they've had adequate workup. If it's a patient that's new to us who hasn't had surgery, they have CRS, they're type 1 without nasal polyps, I usually I would offer them another course of antibiotics. Specifically if they didn't have a real good chance, that they're treated by their PCP and they got a Z-Pack only, where I'm sure a lot of people in the audience see that they didn't have Augmentin or a medral dose pack. I'll offer them another course of appropriate medical therapy before I jump to a CT scan, because they may get better from medical therapy alone.
Yeah, I purposely meant this to be a little controversial because I think it can be both before and after therapy. What about those patients that come to us that have maybe a substandard CT scan? So vertex got cut, you load it up on your navigation machine, doesn't load up, and you're thinking, man, I booked this person for surgery. Is it worth getting another CT scan? Where is that threshold for people in the audience as well as in the panel?
I think it's worth it. And I just explained to the patient, hey, our machines, the navigation machines require a certain cut, or thinness of the scans, and we want to be as complete as possible. Also, if you're in a teaching institution or if you use navigation, in your practice, I think as surgeons, you want to make sure you have everything you need before you take that patient and put them under anesthesia.
Very good.
I guess I'll ask a question of our panelists. So we are probably more naturally a little bit more conservative about CT imaging, not because we don't think it's beneficial, but we are lucky to have great colleagues that can do nasal endoscopy. So when would you want your friendly allergist to order a CT? I know, Chris, we've discussed this a couple times, but you know, I presume after medical management. I just had a great case yesterday of someone who, you know, of course, came for allergies, but really has chronic sinusitis, and so we, in fact, discussed, you know, let's optimize medical management, but because I didn't think they probably had nasal polyposis or needed to see Chris or Eugene yet, to maybe do a CT if symptoms, you know, were not improving. So I'm just curious what you guys like from your allergist.
Well, I mean, in a non-surgically treated patient, it's awfully nice to have make sure the diagnosis is CRS. And there's so many people. I didn't see these patients when I was in residency, but I certainly see them in downtown Chicago. Facial pain, they have rhinitis, they have, you know, they need to see a neurologist really mostly, or maybe get allergies. They need nasal sprays and migraine medication. And there's a lot of those customers. So, but once the diagnosis is established, and you know, we know they have sinusitis, they continue to have symptoms up there, then, you know, my endoscopy is probably going to be pretty valuable, and the CT scan is going to tell me really is pre-op. So that's how I would see it. And again, we have the luxury of the scanner in the office, and if any of you, especially if you have 2 or 3 partners, it's an excellent investment. There are usually state-to-state variations in this, and it's very corrupt and absurd, but it's as much radiation as a dental X-ray, essentially. It gives you enormous amount of, you know, patient education opportunities. It's a winner to have it in the office if you can, and it's really I don't know what the cost is now, but it used to be less than $200,000. So if you have a large rhinology practice, I would strongly encourage you to get one.
Yeah, I agree with all of those points. I think getting a CT scan can help with the diagnosis of exclusion. I think right when you got that scanner, Dr. Kern Bruce came out with a really nice paper stating that many of your patients actually had negative scans. And so it allows you to potentially triage and segment many of those folks perhaps after their first visit rather than their second or third visit. We have a lot of practitioners out in the community that come up to us with cone beam scans. I think that they can be helpful. I typically like our navigation scans a little bit better just because the resolution tends to be a little higher, but we can certainly use those as well. But we've been advocating for an in-office scanner. Our problem is that the radiology department has actually been fighting us quite a bit because they earn a fair amount of money from the reads and from the services. And I've also seen it the other way around, and this is very rare, but I've seen otolaryngologists read their own scans. And I take a look at the cone beam scan, and I'm like, what are you reading? Because it's a template, and it says middle meatal inflammation may need surgery. And there are not many practices like these, but all of us know that there are some that are almost factories, and I worry a little bit about that when all of that power is given to the person who has potential financial benefit for it to be positive. So this is an imaging question. We had talked about polypoid disease. It can be, it's usually bilateral, although not all the case. So in these cases, when you do get this image, what's your threshold for getting more advanced imaging? And then also, if you could help us to determine what you see or what you think about when you see signs of either erosion versus expansion versus bony thickening, because these are common things that we will find on our CT scans. What does that help you to do in terms of explaining things to the patient, potentially modifying your surgery, and then again pursuing more advanced imaging? These are some examples, obviously, but if you want to just chime in and talk about maybe certain scenarios that you see as well, that would be a great learning opportunity.
So I'll start. Well, usually I go over the CAT, I go over the CAT scan with the patient, and if I see, let's just say, bony thickening, and sometimes it's associated with chronicity, so they've had this chronic inflammatory process for a long time. If it's unilateral and it looks like it's associated with a polyp, oftentimes I'm thinking in my head, this could be the origin point for inverted papilloma. And so, I go over a lot of those things with the patient. I'll leave some of the other findings with someone else.
Yeah, so I think we touched upon it earlier. Unilateral sinus disease. Part of our nasal endoscopy helps a lot. So you see that clear, peeled grape. We know that's probably a polyp, and we see unilateral disease. We may think of like allergic fungal rhinosinusitis. We see that quite often. Some of the other examples up there, the bottom left. That's when we see that. You probably could look at those maxillary molars. There look like there's some lucencies there. We think about odontogenic sinusitis. That's probably one of the most common causes of unilateral sinusitis, and it's actually an oral boards question almost every other year. So that's a classic one from that. And then the other thing is, Dr. Chang talks about it, is probably that MRI scan there, unilateral disease. If you see something that's not peeled grape, and you see maybe a pigmented lesion, or if you see it's exophytic, or even actually angry or bleeding, we're thinking of probably like a sinusal tumor. So those are the things we're thinking about. And if you see that type of thing on a CT scan, that's when we probably get more advanced imaging and MRI. And I think a lot of the practitioners here in Tucson have recognized this a lot and actually got all these workups before they even send us to Eugene and myself.
Excellent. Well, due to time, I'm going to skip a couple cases because I think that this part is really important. We talked about testing. A lot of us are seeing these patients in the office and in the clinic. This is a screenshot from Devyani Lal's nice paper on histopathologic characteristics or tissue biopsies from sinus surgery. And we actually started having our pathologists do this to help with endotyping as well as recurrence. And we got buy-in for about the first 3 months. And then our pathologist kept on changing. And again, it was kind of a template in terms of it just said inflammation, inflammation, inflammation. So if you had your wish, what do you think can help you the most, either in the laboratory workup, in an allergen workup, in a tissue biopsy workup that can help for the management of CRS? That's my first question. And the second one is speaking about allergic fungal sinusitis. When we are operating on these patients, we have a strong suspicion of allergic fungal sinusitis. Maybe I'll ask Drs. Carr and Dr. Schroff, how helpful is it for us to obtain fungal cultures, and how does that impact your management?
Do you want the first question?
We can go with either question. I think both of them are equally as important.
I mean, I think I think the biomarkers are really cool, and I think there's a lot we're learning about the disease state. And particularly for patients who are more difficult to manage, who have recurrent refractory disease, who have required lots of surgeries despite appropriate medical management. I think the phenotyping and the understanding which inflammatory cells are present and how many of them are eosinophils and some of these other characteristics, like is it type 2, is it not type 2? I think that's really helpful. But I think for the sort of routine patient who has nasal polyps and who doesn't have any features of some other kind of concerning disease, if it's more of a baseline person, we don't really routinely biomarker them. I mean, we will in our clinic do an allergy evaluation because they have symptoms that could be attributed at least in part to allergic rhinitis. We want to make sure we're addressing that at the same time we're addressing the polyps. But yeah, I don't know that it's at the point where it's super helpful in terms of driving treatment in our clinic. In terms of the allergic fungal rhinosinusitis, it's sometimes helpful to know what fungus is in there, but also the patients, whatever they're allergic to is what they're going to end up getting allergy shots for. So, and we'll test for all of the molds irrespective of what comes out of their sinus.
So if we find like a rhizopus in the sinus, does that tell you or convince you to do more of that in your aeroallergen kind of therapy, or not necessarily?
I mean, I think the fungal culture can be a little bit inconsistent too, I guess, just depending on what treatments the patient has had, and it's more of an allergic reaction to the mold and less a mold infection for AFRS, and so I tend to lean more towards what the allergy panel is and just treat people for everything they're allergic to.
Perfect.
Same.
Yeah, I agree with that. I'm a little nerdy about AFRS. I don't know if it's because of my time in Houston where we saw a lot of it, but certainly Amber Long, and we used to discuss this a lot. And so I like to know. I agree. I think the paradigm has shifted. I think in the past, counseling the patient that, it's not that you may grow out the mold, but it's really the reaction to the mold that's driving the pathology, as opposed to needing antifungals, which that discussion comes up sometimes with our infectious disease colleagues. But I do like to know, but it's especially nice if they do react, to Tara's point, on the skin test to the molds. That just gives you a lot more confidence alongside the other findings, certainly the allergic mucin and some of the other histopathological features that Eugene showed up there. So it's maybe more of like a geeky thing, if you will. I think with respect to biomarkers, we certainly in our clinic, blood eosinophil counts and of course IgE levels, those are, often we're checking those, and especially because we have so much, overlapping asthma. But I think from a wish list, because we do nitric oxide measurements for airway, or FeNO, which some or many of you may be familiar with, certainly for our asthmatics as a useful tool, alongside management of disease. I think it's really exciting to think about some of the biomarkers. Periostin's been talked about, nasal nitric oxide has been thrown out, for many years. I don't think there's been any momentum on that as such, and there's a lot of challenges to it, I presume, especially based on some of the conversations or the discussion that we're hearing from our speakers regarding, allergic and non-allergic rhinitis. But so it's very interesting to think about, and I suspect, there's labs and, certainly pharmaceutical companies that want to, promote their particular biologic by use of those markers.
Well, I wanted to take maybe the last couple of minutes to take some questions from the audience. We have a wealth of information and experience from our panelists here. And it can really be on any of the topics of our talks, or really anything rhinology based. Any questions at all? Question over there, Dr. Malmi.
And then the second question is, what's your protocol for post-operative AFRS treatment systemically?
So I'll repeat those two questions so everybody can hear. The first question was, what's the role of food allergy in allergic rhinitis? Do we see a role or a synergy in that? And then the second is, what is the role of post-operative therapy in AERD? We could talk about timing. We could talk about what therapies afterwards.
I can speak to the food allergy question. Food allergy and allergic rhinitis are both atopic conditions, and so they can definitely coexist in a lot of patients, but we do not screen food allergens for people who are just having rhinitis symptoms, because there's a very high false positive rate for food allergy testing, and these patients just end up miserable because they're avoiding foods and terrified to eat and terrified to go out to restaurants where they really don't need to be. So we do food allergy testing when we suspect that food allergy is a comorbid condition if they're having symptoms every time they ingest a food. That can include rhinitis, like sudden onset, but also often includes GI symptoms, flushing, hives, itching, so sort of multi-symptoms, multi-system symptoms. And we limit our food allergy testing to those patients.
Yeah, I agree with that wholeheartedly. Was the second question about AFRS or AERD
The
or
post-op
both?
management of AFRS.
I'm sorry, AFRS. Sorry
Okay,
about that.
sorry, I
said
just wanted to make
AERD.
sure. So, yeah, it's a great question. I think, the biologics were not studied in AFRS. So it definitely, we do know that AFRS is type 2 mediated. So there's a lot of, I'd say, surveillance and monitoring for recurrence of disease, and certainly biologics possibly could be used in those settings with recurrence of disease. I would say before that, I think, if they are sensitized to allergy immunotherapy, as was alluded to before, and particularly including mold allergy immunotherapy, though there's not great data for mold allergy immunotherapy for all allergic rhinitis patients, I would say with AFRS, that might be one of the stronger indications to pursue it. Obviously, aggressive management, surveillance are key, and we know that with irrigations, nasal corticosteroids, including nasal azelastine, but often these disease states recur. I was going to just, since Eugene brought up AERD and postoperative management indirectly, I was just going to speak to that briefly. I mean, the prior paradigm used to be that was the optimal time once a patient had recovered from nasal polyp surgery to desensitize for aspirin. And we still do that on occasion in some of our patients that are more stable, once they've been treated with inhaled steroids and other management for their asthma. But the biologics have changed that so much with respect to Dupixent specifically, but also Xolair, which had been used, has been around for decades, but had been used for that in many of those patients. So I think that part, still the cost-effective part of biologic use postoperatively needs to be really better clarified, but I think certainly that would be much more of a go-to in that setting.
Question over there.
Yeah, in terms of biologics, of the three, Nucala, Dupixent, and Xolair, do you have a preference, a pecking order when you've chosen, when you're at the point where you're going, for whatever reason, you're at the point that you're going to use a biologic? What's your order? Do you change after a while if there's not the effect that you think there should be, or what's your approach?
Yeah, I mean, I'd love to tell you that this has been studied rigorously with head-to-head trials and all that, but of course it hasn't been. I think the clinical trials data for Dupixent shows more polyp reduction for patients than the other clinical trials, and so I tend to go for Dupixent. I also, in my clinical experience, I find that patients do very well with it, and I get these notes back from Chris and Eugene saying their sinuses are clear and everybody's happy. So I tend to reach for that unless there's some contraindication if the patient can't inject themselves, if they don't want to do the every 2-week injections. Omalizumab has been around for a long time. I think it's a tried and true treatment. I haven't seen it be as magical for reduction of nasal polyps as the dupilumab has been, but I will use that for people who have failed Dupixent for whatever reason. I have had some patients who failed Dupixent do very well with the anti-eosinophil drugs. Actually, not even mepolizumab. So, I think there's some variability in clinical responsiveness, of course, but we want to start with the drug that we think is going to help the most people, and some of that's informed by our own clinical experience and some of it by the clinical trials data. I think, that the EPOS guidelines and the European guidelines are pretty strict about how much of an improvement you want to see in patients with the biologics. I think that's a little bit too much to ask for a lot of these patients, to be honest with you. I think if our patients look open, they're not getting steroids, and they're very happy. If they have a little bit of residual disease, I almost don't care. So it's a real patient discussion about when we're going to switch a biologic and what our goals are going to be for making that change.
Thank you to the panelists. If there are no further questions, we'll release you. I'm sorry, one other question back there. Last question.
Hi, I'm in primary care, so I'm just trying to soak up all this knowledge so I don't have to refer to y'all. But you mentioned budesonide irrigations, and is that something that I could prescribe to a patient to do at home, or is that something that y'all do in your clinic?
So budesonide is a water-soluble steroid, and it comes in these little respules that were made to put in nebulizer machines to nebulize little kids who had asthma. So I think the reason we use it in the irrigations is because that's what we had available readily for people. And so what we do is we ask people to add that into their sinus flush with the saltwater packet and flush it into their sinuses. And when people have had sinus surgery and their holes are all open, their sinuses are open, the water with the budesonide gets into those sinus cavities and provides that that sort of mechanical cleansing, but also deposits some of the budesonide into the sinus cavities. And so we'll prescribe it for patients and have them use that in their flushes once or twice a day to try to reduce the inflammation in all of those sinus cavities. Gotcha. Yeah, it's a great question.
It is off-label use, though.
It's off-label use, yeah.
Thank you.
Well, thank you so much. Why don't we, I'm sorry, Tom, just because you're Tom.
Well, just quickly,
Well, I find that if I do those procedures that I discussed, that they work better in people who responded with ipratropium. If not, then I kind of tell them, unfortunately, you have a condition that I cannot fix.
So yes, and I think it's really tough. I'll do combinations of azolastine and ipratropium, and sometimes Flonase, and sometimes all of these things can be helpful. Sometimes a sedating antihistamine for some of the anticholinergic benefit can be really helpful. But I've been reviewing the literature because I'm actually talking about this at the Quad AI, and there's a little bit of data on things like sphenopalatine acupuncture, which is very fascinating. There's some data about the benefit of actually open-label placebo to treat some of the psychoneuroimmune mediated outcomes. And so I think people are thinking about this. It's just not entirely clear how to do it. Chemical cautery might be another thing that we could consider.
There's also capsaicin nasal sprays out there. I don't think it's spicy.
It is.
It is spicy.
I think I've been told it feels like you're getting kicked in the face by a horse, but you
Oh,
might
wow.
not need to dose it frequently.
And with the ipratropium bromide, one thing that I do is I tell my patients to just leave it in their pocket, because the dosing is so variable, right? I mean, and you can dose quite a bit. It's a quite safe drug. So I tell patients to leave it in their pocket, and whenever they start feeling that runny nose, to use it. 4 sprays 4 times a day is typically the maximal dose. Most people won't do that, but if they have that kind of safety mechanism, then it tends to work more often than it doesn't. One more question. Yes?
0.06.
Yep. And that is, to my knowledge, that is not over the counter. That is still prescription only. Yeah. Thank you so much. Have a wonderful break. Dr. Lay will be leading our afternoon surgical session.
That was fun. Oh, that was fun.
It's such a
Yeah.
Hello, everyone. We're going to start with the second session of rhinology, and Dr. Woodard's going to give us a talk on avoiding complications during sinus surgery.
Okay, good afternoon. Today I'll be discussing how to avoid complications during endoscopic sinus surgery. These are my disclosures. During this talk, we'll be discussing the principles of prevention, right? How do you prepare the patient? How do you prepare yourself? And how to optimize the surgical field. We'll then transition to discuss complications, the major ones. So hemorrhagic complications, orbital and neurologic complications. So I trained at Loyola University in Chicago, and Jim Stankiewicz, who was the chair at the time, he's known as like the father of complications. I don't really know if that's a good thing to really be known as, but we have to give him credit because really no one likes to write about their complications, right? And so he was pretty courageous and was one of the first people to actually discuss complications associated with sinus surgery. And he did the very first large series looking at these patients, 90 patients, and he found that complications occurred in almost 30% of these patients, which is pretty high, but you got to remember this was back in the 80s. And so he classified the complications as major and minor with a frequency of 8% and 21% respectively. And so what do we consider a major complication? A major complication is one in which it requires readmission or going back to the OR. So, endoscopic sinus surgery has become a commonplace procedure. Recent studies have described that there's a decrease in the incidence of complications, of major complications, and it's instead of 29% or 8% that Stankiewicz found, it's down to approximately 1%. And we attribute that to a better understanding of the anatomy, refinement in the surgical technique, technological advances which improve image quality, navigation systems, and instrumentation. Now, sometimes our patients have risk factors that will predispose them for complications. They include things as like pansinusitis, so really bad, really inflamed chronic sinusitis, obstructive nasal polyps, sinus mucoceles, fungal sinusitis, and tumors. Additionally, patients who come to us and have revision, for a revision sinus surgery, oftentimes have landmarks removed, or scar tissue formation, which could really make it, put them at an increased risk of having complications. So first, when you say, okay, I'm gonna go and we're gonna operate on you, you're talking to the patient, but we need to get you ready for surgery. Some of the things that you need to make sure you tell the patient is stop all blood thinners. Now, in my practice, I see a lot of sick people. I tend to sort of say, hey, I need you to talk to whoever's prescribing your Coumadin and your Eliquis, whatever, right? Your aspirin, and make sure it's okay that you can come off your blood thinner. Also, it's important to tell patients, because they really don't consider these medicines, but all these herbal supplements, the vitamins, the ginkgo, the vitamin E, the ginseng, etc., they can thin the blood. If the patient says, I have a history of bleeding a lot, make sure you get a hem-onc consult to make sure they don't have any kind of coagulopathy going on. Also, if they're really inflamed, oftentimes we prescribe a steroid taper to help reduce the inflammation, and that's been associated with decreased bleeding during surgery. It's important to then prepare yourself, right? So familiarize yourself with the patient's anatomy. Every patient is different. They have different anatomy, and it's important. We discuss, when do you get CAT scans? In my practice, I routinely get CAT scans and with fine cuts. Make sure that they are like within 1 to 2 millimeters thickness, and I utilize those in our navigation system. I understand that not everyone uses navigation all the time. Since I'm in a teaching hospital, I tend to use it every single time, and it aids me in teaching our residents. All right, it's important to keep the patient's eye in the field at all times, because you want to make sure you haven't inadvertently penetrated the lamina and entered the orbit. So this is a mnemonic that we go over with our residents and fellows. It's the closed mnemonic. And I make sure when we're preparing ourselves, viewing the scans, that we go through this every single time. Right? So C stands for cribriform plate. You want to look at the height of the skull base. Is it a high skull base? Is it a low skull base? I'll give you some pictures in a minute to illustrate what I'm talking about. Is it asymmetric? Are there any dehiscences? Those are important to really understand. So, hey, if there's a dehiscence here, I'm going to leave that area alone, even if it is a polyp right there. That area is going to kind of just stay untouched, and we'll deal with that later, hopefully by medical management. What about the lamina, right? Is it thin? Does it have any dehiscences? Or is orbital fat protruding from a previous accident or previous surgery? These are things that you need to know before you go in there with your sharp instruments. What about anode cells? Anode cells are cells that occur superior and posterior to the sphenoid os. And so these cells oftentimes can fool you. Sometimes you may think you're in the sphenoid sinus, but actually you're in that anode cell. Other times you know you're in a anode cell, but there's this nice juicy polyp right there. And you gotta be careful, because about 20% of the time, the optic nerve can run through that and be dehiscent. So you really need to be careful of what instrumentation you use in these anode cells. The same for sphenoid sinus. We know there's a lot of important structures, right? The blood vessels, the cranial nerves, and so we don't want to inadvertently damage those. The anterior ethmoid artery oftentimes is hanging low below the skull base in a mesentery, and one simple move, you can avulse that and cause an orbital hematoma. So we go through this stepwise, stepwise examination every single time. So after you do that, it's important to optimize your surgical field. So we have a good relationship with our anesthesia. And, sometimes they listen to me, sometimes they don't. But basically, when I first started, you probably have heard of TIVA, right? Total intravenous anesthesia. And I'm like, hey, let's do remifentanil and propofol, da-da-da-da-da. And like I said, sometimes they listen to me and sometimes they don't. And so, say if they're doing their own thing, I'm always asking, anesthesia, what's the blood pressure? And then they'll give it to me, and I'll say, okay, fine, but let's make sure we keep whatever method you're using. Let's make sure we keep the mean arterial pressures between 65 and 70. And so I find that works better than me trying to tell them how to do their job and what, medicines to use. All right, so I always use reverse Trendelenburg, keep the bed elevated about 15 degrees, use vasoconstriction. Topically, you may use Afrin. Some people use diluted epinephrine. I actually inject with 1% lidocaine with epinephrine. We also use warm saline irrigation. And initially, I didn't use that, but my practice is about 40% skull-base surgery. And what we notice when doing that type of surgery, the warm irrigation really helps promote clotting. And so now, when I do my regular sinus surgery, I just bring in the warmer and we heat that irrigation. Again, avoiding that ethmoid artery and sphenopalatine artery are key. All right, so let's talk about major complications. Bleeding. Bleeding is the most common intraoperative and postoperative complication. There are minor ones which result from venules and arterioles in the nose and sinuses. They can typically be managed by packing or silver nitrate cautery. In contrast, major bleeding occurs from damage to these blood vessels. So the anterior ethmoid artery, the sphenopalatine artery, the posteoseptal branch, which is a branch off the sphenopalatine artery, and even the internal carotid artery. Typically, these require actually hospital admissions, posterior packing, and or take back to the operating room. So let's focus a little bit more on the bleeding. Sometimes there's just kind of diffuse bleeding, mucosal oozing, and that's to be expected. But how do you prevent that? Well, gentle dissection, right? Make sure that you're gentle with the middle turbinate if you're moving. Or if you keep if you're moving your scope and your instruments, be careful not to scrape against the septum or the inferior turbinate. You know, at first it seems like, oh, that's just a minor nick, but over time it could be multiple nicks, and it will actually bleed down over the end of your endoscope, blocking your view, making it more difficult. So I think an ounce of prevention is, you know, is worth its weight in gold. Obviously, you have to avoid danger or damaging the sphenopalatine artery and the posterior septal artery. Let's take a look at this picture here. So this is the sphenoid os, and just below it, a few millimeters, you'll see this blood vessel here. So this is the posterior septal branch coming off of the sphenopalatine artery, going over into the nasal septum. Oftentimes when we use a mushroom punch or a kerosene and we bite down, you'll just be prepared. If you bite inferiorly, have your suction bovie ready, because oftentimes you will damage this vessel. Sometimes you don't damage it, or it doesn't bleed at the time. And I've had like the mistake of saying, oh, we're fine. Sure enough, you know, probably a couple of days later, that patient comes in with significant bleeding. So really, every time that I actually widen the sphenoid os inferiorly, I just go ahead and lightly cauterize that area with a suction bovie. There used to be this talk about, do you keep the middle turbinates or do you remove the middle turbinates? And honestly, I think it depends, right? Depends on what type of sinus disease you're treating. I have had patients who it appears like the disease or the polyp is actually emanating off the middle turbinate. And so you can trim it down, but again, if you don't remove it, it'll come back and block the middle meatus and drainage of your sinuses. So in those cases, I do remove the middle turbinate. And it's very important though, if you remove the middle turbinate because of something like that, or if you're removing an inverted papilloma or a tumor, cauterize the stump. If you don't, it'll come back and bite you. The injury to the internal carotid artery, you know, I hope you never see that. I've seen it once. We were in our ORs, you know, I'm fortunate to have two neurosurgeons that I work with who are really lighthearted and they're friendly. They're actually like a group of guys that you want to actually go out and have a drink with at the end of the day, and that's not common. Excuse me to any neurosurgeons in here, but they're nice guys. And so we oftentimes listen to music and laugh. And I'll never forget this one day, we were operating and then all of a sudden, like just, it was so fast. I couldn't believe it. It was just like less than a second. The whole nose was just overflowing with blood. And so immediately, you know, it's time to get serious. But be prepared. If you're working in a situation like this, just sort of go over what would you do. So in this situation, I stopped, ran and got on the phone, called interventional radiology. He then took over talking to anesthesia, saying, hey, this is what we got. I need you to control the blood, the 2 large bore IVs, make sure you maintain the blood pressure. And then we started talking to the room about getting certain supplies, pack the nose off. At that particular time, you know, you'll hear people talk about getting muscle patches and things. We didn't have time for all of that, and that wasn't readily available. So we just packed the mess out of the nose, kept the blood pressure elevated enough so that they wouldn't have any neurological damage, or that we hoped they wouldn't have any neurological damage, and then rushed the patient down to the interventional suite. All right, if you have bleeding, prompt packing of the sphenoid sinus, you can try to use temporalis muscle to stop the leak or temporarily stop the leak. Neurosurgery consultation if they're not already working with you, angiography, and possible embolization. Let's talk about orbital complications. This usually occurs when you get blood that accumulates in the retrobulbar space. It's this is a serious thing because it can cause an increase in intraocular pressure, which leads to decreased optic perfusion of the optic nerve vessels. This can happen if it's a venous cause. It can take approximately 60 to 90 minutes to result in blindness, but if it's arterial, for example, from the anterior ethmoid artery, it's much quicker, 15 to 30 minutes. So how do you prevent these complications? Well, you've looked at your scan, you've become familiar with if the lamina is intact or if it's dehiscence, and during your surgeries, it's important to dissect parallel, not perpendicular to the lamina, all right? Make sure you point your microdebrider away from the lamina when you're using it. Also, take note and identify early if there's any lamina violation. And that's why I said it's important to keep the eye out, right? So you can look at it, raise the lids to look and see, if there's any ecchymosis, if it's any proptosis. You can press. And what I usually do is if I have an assistant with me, I'm a resident or a fellow, I'll have the scope in the nose. And if I know I'm going to dissect on the lamina, I'll say press on the eye. And they'll go press, press, press. And I can look and see if there's, while they're pressing, any movement of orbital contents in my view. If there's no movement, then I know there's no dehiscence, everything is fine, I can continue. All right? It's also important to identify the anterior ethmoid arteries. As you can see here on the patient's left, hopefully you can see that, there's a little steeple sign. That's where the anterior ethmoid artery comes out, all right? And so in many cases, it can run in the skull base, but other cases, it hangs low in the mesentery. And what happens is, as you're trying to remove the ethmoid cells from the skull base, you can nick that and avulse the artery. So, if you get an orbital hematoma, you need to actually work urgently, right? Prompt intervention. Make sure that head of bed is elevated. Remove any nasal packing. Sometimes operating rooms has a tonometer, so you could use that to confirm if there's high intraocular pressures. If not, a lot of times you can tell, right? Because the eye is starting to become proctotic, there's ecchymosis. You can do gentle orbital massage to redistribute the blood. If you've already done a orbital decompression, you can massage and allow for evacuation of the hematoma. But most of the time, just go ahead and do the canthotomy and cantholysis. So how do you do that? Well, you inject in the area in the soft tissue on the lateral canthal tendons around that area. You get a hemostat, clamp into the corner of the eye, and actually go till you touch the orbital rim. Once you do that, get some sharp scissors and make a cut laterally, and then go along the rim and cut inferiorly until you can feel like you're cutting through a tendon. This says if you're not satisfied, go ahead and cut the upper tendon. We just tell our residents, cut both. That way you can ensure that you've lowered the intraocular pressure. All right, there are some conservative measures, but they're not really intended for you to utilize if you have arterial bleed. So you can consider IV mannitol and steroids. Some people are equipped or have already done a orbital decompression endoscopically. You can consider that too, but the easiest is just doing the standard canthotomy and cantholysis. What about extraocular muscle injury? Well, it does occur. Sometimes it's temporary and unintentional from injection of local anesthesia into the orbit. Other times, though, it's due to violation of that thin lamina. And oftentimes, we'll have some type of power instrument, a drill or a microdebrider. And as you move posterior in the nasal cavity, there's less orbital fat that separates the eye and the muscles from the nose. Let me show you what I mean. Okay. So axial view of the sinuses here, right? And if you're anterior in the nasal cavity, you have a lot of space. But as you move more posteriorly, you'll see that there's less orbital fat that separates the structures from the lamina. And so usually if someone gets into the lamina, it generally occurs more posteriorly. Here's an example of violation of the lamina and damage to the medial rectus. Optic nerve injury. And so this can occur when you're dissecting in the anode cells, which are the cells that are superior and posterior to the sphenoid os, or sometimes in just you're dissecting in just the sphenoid cavity. Generally, the optic nerve can be dehiscent in about 10% of anode cells, which is a pretty high percentage. So you got to be pretty careful. This is a patient who had nasal polyposis, and we're going through the scan. And we're like, oh yeah, she got a big polyp back there in the anode cell, right? But as we're dissecting and moving to the anode cell, if you look to the right, you got to be careful. This is a dehiscent optic nerve, right? And so I never ever stick debriders in that cavity. Let's talk about neurologic complications. CSF leak is the most common, and usually it's due to violation or damage to the lateral lamella of the cribriform plate. Oftentimes it can occur when you're doing extended frontal sinus surgery work. Risk factors: pre-existing skull base dehiscences or low-hanging skull base, or if you are going to remove that polypoid middle turbinate, aggressive resection can lead to inadvertent violation of the skull base. So you heard me talk about low skull bases. There's a Caros classification, which really measures the lateral lamella. What's the lateral lamella? So it's the distance between the cribriform plate and the ethmoid fovea, or the ethmoid roof. So this portion right here, the vertical portion. And so type 1 means it's a very small vertical portion, and that is associated with a high skull base, and you're less likely to validate it, versus type 3, you have a really long distance, and the cribriform is really low in the nasal cavity. You're more likely to violate the skull base. There's also an easier way that I sort of just kind of look. For instance, I look at the level of the medial rectus. Unfortunately, you can't really see it on this resolution. But if you see that the cribriform plate is down at the level of the medial rectus, that means they have a low skull base. And you can't see it on this resolution, so I apologize. But just note, if the cribriform plate is down at the same level of the medial rectus of the orbit, that person has a low skull base, so be careful when you dissect the ethmoids. Now, generally people who have skull base violation, they usually have a CSF leak, right? So it's important to know where you are at all times, reorient yourself using consistent landmarks, right? What do you do if the middle turbinate's gone? Well, so what I do is tell my residents, let's look at the roof of the maxillary sinus, right? Let's look at our choana. So you try to find structures that don't move and then work off of their position. It's important to slow down, do gentle dissection along the skull base, especially medially, because that's where the skull base is thin, along the cribriform. Use navigation, right? Don't use it to, don't follow it. You use it to confirm where you think you are, right? So it's important for you to have a good understanding of the anatomy and then use the navigation to confirm where you think you are. Why is that? Because navigations can be wrong, right? No matter how much accurate they tell you they are, we know that there are instances where it's off. Even off by a few millimeters can make the difference between CSF leak and not. So let's say if you do violate the skull base, what do you do? Well, it's important to really understand that you've done that and immediately repair. And I'll go over this later, I think maybe in my next lecture. But basically, you prepare the surrounding tissue, removing all mucosa. With small violations, I like to just use a free graft. Some people take it off the middle turbinate, some people take it off the nasal floor. I like the inferior turbinate because it's thick and robust. Place it over that, use some gel foam, Tisseal, Duraseal, there's a lot. Now we use something called Adherus. I like it because it's like a motorized mist, and so you can easily place it over your graft. But there's a lot of different things that you can use to help your patch stay adhered to the defect. There's other catastrophic complications that can happen intracranially, right? Penetration and removal of brain tissue. This typically occurs when you have poor visualization, which usually occurs if there's a lot of bleeding. So control the bleeding, you can see, know where you are, so that you don't penetrate the skull base. So in conclusion, principles to avoid complications in sinus surgery really include, again, mastering the sinonasal anatomy, review the CT scans preoperatively in a systematic fashion, maintain good surgical habits, be consistent in your techniques, avoid an excessively bloody field, effectively use navigation, and if you have a complication, recognize it early and intervene to prevent further complications. Thank you very much. Are there any questions? Yes, sir.
Last year at the conference, we had a rhinologist from Stanford who was advocating for not using prednisone or any oral steroids in the preoperative period, which was news to me and quite surprising. I was wondering if you could comment on that.
Well, I think a lot of people practice differently. If the patient can tolerate steroids, like if they're not diabetic, or if they're not too old, a lot of elderly can't tolerate high-dose steroids, then I usually will prescribe a prednisone taper, or a Medrol pack, depending on how comfortable I am with them taking it. Because some people can't tolerate the prednisone. But yeah, did they talk about why they don't? Or okay.
And when do you have, so I kind of decided I'd try and advocate on her behalf, but still use a steroid. So now I do a week of a high dose prednisone 3 weeks prior to the surgery. When do you have your steroid taper finish?
So I have them start around 10 days before.
Mm-hmm. Thank you.
I think it's personal preference. For me, it only takes 1 or 2 times getting into a bloody mess, and I'm like, okay, what can I do to make this better? And I find that steroids improve it. So that's why I use it.
Often in nasal polyp cases, you can get into some bleeding, and I've not really used it. But have you used TXA at all, or what's your experience?
You know what? I have tried it a few times, and I actually learned about it from my resident. Evidently, a lot of the facial plastic surgeons in our department use it, and so I've tried it a couple of times. I haven't used it. I don't use it all the time, because I don't necessarily need it all the time, but in severe cases when I've ran through the gamut of epipledgets, Afrin, then I will try it. Now, interestingly enough, I treat a lot of HHT patients. We're a HHT center, and when I say a lot, I generally have about 2 patients every clinic that have HHT. So that's a lot, right? And so we use a lot of medical therapies, and TXA nasal sprays is one. Anyway.
Thank you.
Yes, sir. So I have done it both. So the first couple of times I put TXA into the irrigation and used it. I had one patient who, remember I said, you have to prepare the patient, tell them to get off all their blood thinners. Well, his doctor says, yeah, you can come off of it, but instead of the normal 5 days, you can come off of it like 3 days. So I just did a regular maxillary antrostomies and a septoplasty. He bled like at least a half a liter. I mean, I was like, oh my, it was bleeding from every single place. And so I tried everything. And then finally I was like, what about injecting TXA? Actually, it was the resident who suggested it to me again. And I was like, is that safe? Because I didn't know much about it. And then we did it. He stopped. And then, yeah. But it was bad too because, it seems like when you get complications, it's always either in a family member or something. This guy he's like a TV anchor, of all people, right? And so the ones you try to be careful around. The TXA? Yeah. Yep. Yeah, and so I have noticed that, not all the time, but I have noticed that in several times that it did help. All right, thank you.
Okay, thank you, Dr. Woodward, for giving that great talk. Just a little plug on TXA. There's actually some new good data on it and papers that came out looking from an anesthesiologist standpoint, from an otolaryngologist standpoint. And I could share those papers with you, but Dr. Chang and I, since those papers came out, have been using TX more regularly for our really bad CRS with nasal polyp cases, 1 gram before incision, and sometimes 1 gram at closing. It's somewhat based on the orthopedic literature. So that's really new papers that came out recently. So next, we'll talk about frontal sinus surgery. A gram IV, yeah, straight up before incision. So no disclosures. Our objectives today are to describe frontal sinus and recess anatomy and understand its many variations, develop a systematic approach for treatment of frontal sinus disease, describe the different types of endoscopic frontal sinus surgeries, and describe the role of external approaches to the frontal sinus. When we think about the frontal sinus outflow tract, we think about it as an hourglass, starting superiorly as the frontal sinus infundibulum, narrowing to the frontal sinus ostium, and widening to the frontal recess that drains into the nasal cavity. The frontal recess anatomy is really important anytime you're doing frontal sinus surgery, and so we need to know its borders. Medially, we're bordered by the middle turbinate, laterally by the lamina or the medial orbital wall, anteriorly by the uncinate and the Auger-Nazi cell, posteriorly by the ethmoid bulla and bular cells. Superiorly, we'll have our frontal sinus ostium, our anterior ethmoid artery, and supraorbital ethmoid air cells, and inferiorly, we'll have the ethmoid infundibulum. The uncinate process is something we talk about all the time in training, but it's really important because it determines the frontal sinus drainage pathway. Most commonly, the uncinate will attach to the medial orbital wall. If that happens, then the frontal recess will drain into the middle meatus. If the uncinate inserts the middle turbinate, then the frontal recess will drain into the infundibulum. And if it attaches to the skull base, it also will drain into the infundibulum. This is important when doing formal frontal sinus surgery or when you're doing your balloon procedures in office. I think that if you do rhinology fellowship, you have to have this slide in all your talks. I think you've seen it probably 3 times a day. So this is the anterior ethmoid artery. It's a really important landmark radiographically and surgically. Dr. Woodard talked about it already, but you'll see it on a CT scan, on a coronal scan between the superior oblique and the medial rectus muscle, or as a nipple sign. Surgically or anatomically, this is the right side. You'll see it as a speed bump along the skull base, and you'll find it reliably behind the frontal recess or a supraorbital ethmoid air cell. And during surgery with our residents and fellows, we want them to identify it every single time before they start the frontal sinus dissection. Dr. Kuhn came up with these frontal sinus cells. A lot of us in the room probably saw this in training, the type 1 to type 4 cells. This is just here for reference. There's a new classification of frontal sinus cells that P.J. Wormel came out with in about 2016, giving a more anatomical description of them. And it's a little bit better, and it helps us describe really the frontal sinus drainage pathway. And we'll go over those in more detail next. So here we have a type 1 frontal cell, or in the new classification, a super auger cell. This is a frontal sinus cell that will pneumatize above the Auger-Nazi cell. And then, as you can see here, with that frontal type 1 cell, it will push the frontal drainage pathway posteriorly. Let's see if I get this to work here. Right here. So this will be the frontal sinus drainage pathway from a type 1 or superauger cell. The more pneumatized your frontal beak, the bigger this cell is, and the bigger you actually can make your frontal sinus opening. So a type 2 cell is a tier of cells that pneumatize above the auger nosi, which is still considered a superauger cell in the new classification. This again will push the frontal sinus drainage pathway posteriorly. A type 3 cell, a frontal cell, or a superauger frontal cell is a cell above the auger nosi that will pneumatize into the frontal sinus. Again, this will push the frontal sinus drainage pathway posteriorly and medially. Type 4 cells are cells that pneumatize in the frontal sinus itself. A supraorbital ethmoid air cell is a pneumatization of the ethmoid air cell above the orbit. This will push the frontal sinus drainage pathway anteriorly. And a lot of times, this is the first cell, big cell you'll see along the skull base in front of the anterior ethmoid artery. And a lot of times during surgery with our residents, we'll call this a false frontal because they'll pop into this and they'll be super happy. They're like, oh, I found the frontal sinus today, Dr. Chang. And then he'll be like, well, let's keep dissecting. That's actually not really it. So a frontal bular cell is a cell that pneumatizes above the ethmoid bulla into the frontal sinus. These type of cells will push the frontal sinus drainage pathway anteriorly. A suprabular cell is a cell above the ethmoid bulla that pneumatizes to the skull base. Again, these type of cells that are posterior to the frontal recess will push the drainage pathway anteriorly. All these cells are really important because these are the cells that you need to navigate and open in order to get the biggest frontal recess or frontal sinus opening possible. Inner sinus septal cell or frontal septal cell or central frontal cell, this is just a pneumatization of the inner sinus septum. These type of cells will push your frontal sinus drainage pathway laterally. So some basic principles of when we're doing frontal sinus surgery. The most important thing, and it's been iterated multiple times, but review the CT scan multiple times in multiple planes. You really want to know anatomy really well. Identify the medial orbital wall or the lamina early, and the skull base early. And then preserve the middle turbinate if present, if possible. That helps you orient yourself when you're doing the frontal sinus dissection and helps you getting into the cribriform. Meticulous mucosal sparing dissection is important because this is how you get really good hemostasis. You're working in a really tight spot, you're looking up with an angle scope, it's bleeding down at you, you want to really maintain hemostasis. Really important is having keyed angled instrumentation and power instrumentation and instruments. And really, I really highly recommend, if you guys haven't worked this before, but using reverse post rigid scopes, meaning that the light post is the same angle as the view. That way, when you're working your angle instruments, you'll be working underneath it. And you're not fighting yourself with the scope. 45-degree scopes and 70-degree scopes are really important, especially when you're working in the frontal sinus. It's very angulated. A lot of times, you may be in the frontal sinus, and you're using a 30-degree scope, but you don't know. And then you pop in a 45 or 70, and you can actually see it much better. Or there's more cells up there that you haven't gotten to. So if you're doing frontal sinus surgery, these are the key instruments that you really need. You need a set of frontal sinus probes and seekers, a frontal sinus curette in various angles, giraffe through-cutting forceps in different angles. You need a Hoseman punch or a curved mushroom punch. A curved Karasin or a cobra punch is really important. And then also a giraffe cup forceps in different angles. So, our head and neck colleagues and our facial plastic colleagues talk about this reconstructive ladder. I think of the same way when we're talking about frontal sinus surgery. So the first thing you could do is do nothing. You could do a balloon sinuplasty. You could do a draft 1 frontal sinusostomy, a draft 2 frontal sinusostomy, a draft 3 frontal sinusostomy or endoscopic modified Lothrop. You could do a frontal sinus trephine, an external frontal ethmoidectomy, an osteoplastic flap. So here's a slide for your reference of just a summary of different indications and contraindications of different approaches to the frontal sinus. I'll just leave it here for your reference if you want to take pictures, but we're going to go through these different approaches next. Great. So when we say just do nothing, what we mean is an anterior ethmoidectomy alone can lead to the resolution of frontal sinus disease in the vast majority of patients. Several years ago, we actually had Dr. Peter Wong from Stanford here, and this is one of his studies he did in 2016. And they were looking at patients with CRS with frontal sinus disease. They split them into two groups. They enrolled them in multiple institutions, and what they did is endoscopic sinus surgery with anterior ethmoidectomy alone versus endoscopic sinus surgery with frontal sinusostomy. The primary outcome was looking at the improvement in SNOT 22, and secondary outcome looking at the endoscopic scores and use of multiple antibiotics. What they found is that the SNOT 22, there was no difference in the two groups. They did find out better endoscopic scores in the frontal sinusotomy group, and they found no revision sinus surgery in the frontal sinusotomy group, but only about a 3% revision rate in the ethmoidectomy group. So in some patients selected with frontal sinus disease, an anterior ethmoidectomy alone can clear the frontal sinus disease afterwards. Balloon sinuplasty, I'm sure everyone in the audience is very familiar with this. This got really popular when I was in medical school, or no, first starting residency. And there's a lot of good indications for it. Some of them I listed here. In our practice, we usually use it for a narrow frontal sinus ostium, postoperatively in the clinic, and then sometimes in combination with traditional endoscopic sinus surgery for a hybrid technique. Jonathan Liang at Kaiser Oakland really looked at frontal sinuplasty procedures. And what they found in this graph is from 2011 to 2014, there was a huge increase in overall increase in sinus procedures. But there actually was a decrease in non-balloon sinus procedures during this time and a really big increase in balloon sinuplasty. What they found, this is probably correlated with the introduction of CPT code for balloon sinuplasty in 2011. So we found that this probably was the driving factor of nationwide of providers doing more sinus procedures. So here's an example of a 50-year-old patient with CVAD who presented to our clinic with right-sided CRS. As you can see on the axial, coronal, and sagittal scans that he has some frontal sinusitis. So here we are, we're taking him to the OR, right-sided frontal sinusitis. You see that really thick, prominent frontal beak on the axial scan. And you see that really steep, angulated frontal ostium. So here we are on the right side. We already completed a full FES. We're looking with a 70-degree scope. Here we identified the supraoral ethmoid air cell. This is our Medtronic frontal sinus dissector navigation tool. So in this case, because the frontal sinus was so narrow and it was so angulated, we elected to use a balloon in order to get in there for mucosal sparing. So here we're putting the probe in. We're advanced the balloon in the right frontal recess. And we're going to blow it up to the manufacturer recommendation. Sometimes you'll blow it up twice depending on the frontal sinus anatomy. But here we are afterwards. Then we'll take down that remnant cell between the frontal recess and the supraoral ethmoid air cell. And then here's our view with a 70-degree afterwards. So we have the maximal opening of the frontal sinus and preservation of the mucosa. And this is important because afterwards, if you preserve the mucosa, this is this post-op nasal endoscopy in clinic, and you can see that the frontal sinus is widely patent over a year later and resolution of the symptoms. So next, we'll talk about the different draft procedures. So a draft 1, this involves removing the anterior ethmoid air cells, the unscented process, the Auger-Nazi, and the frontal cells below the frontal sinus. Essentially, this is a glorified anterior ethmoidectomy, and this is what Dr. Peter Wong was talking about in his study. So the draft 2A, probably our workhorse of most frontal sinus surgery, builds on a draft 1 by removing the floor of the frontal sinus and any cells associated with that. And this will give you an opening from the lamina to the middle turbinate, if present. So next, here's an example of a right-sided draft 2A. Here again, you see we're along the skull base. That's the supraoral ethmoid air cell. Here we see the Auger-Nazi cell uncapped and the superior unscented process. And again, remember the superior unscented is really important to remove to get us to the frontal sinus outflow tract. Here we're removing it with a cobra or curved kerosene punch. This will expose our whatever frontal cells that we have. And in this case, we have a type 1 frontal cell or a super auger cell. And we'll use right here a Hoseman punch to remove this type 1 or super auger cell in order to expose the frontal recess. Now we have that supraorbital ethmoid air cell, and then we have that partition again. And we'll remove this last partition between the frontal recess and the supraorbital ethmoid air cell to create the biggest AP diameter opening of the frontal sinus. So here we are at the end, completion of the draft 2A frontal sinusotomy right here on the right side. A draft 2B builds on a draft 2A by removing the middle turbinate and drilling out the frontal beak of the frontal sinus. So you get an opening from the lamina to the septum. So here's an example where we use it. It's a 60-year-old man who had prior facial trauma and presented with right-sided headache. We got this CT scan, and you see this thick frontal beak on the axial scan. You see this purulence or ossification of the right frontal sinus. And when you look closer, you'll actually see like a type 4 cell there. So here we are in our case, right frontal sinus mucocele. You see that thick, prominent frontal beak. And you see that type 4 cell. So in this case, we're on the right side again. We're trimming the middle turbinate. So there's options to either trim the anterior superior portion to get a more coronal view or widen it from a coronal diameter, or you can take the middle turbinate altogether. So here we are along the skull base, supraorbital ethmoid air cell, this prominent frontal beak, and this is a really narrow frontal recess, and you can slightly see the pulsations of that mucocele there. So what we're doing now is drilling the frontal beak to widen the frontal recess in an AP diameter. Now we actually really see that floor now. We see that frontal sinus mucocele. You see the pulsations there. That's not the dura. That's what a pulsation of a mucous pyocele will look like in the frontal sinus. We'll use our frontal sinus curate to enter it. And then now we'll use our Hoseman punch to remove the floor of that type 4 cell. And you'll see the mucopyocele appearance just draining out here. So we're not done. Now we want to make the biggest opening possible, so we'll drill some more of that frontal sinus beak to really saucerize it to make it as big as possible. So here we're at the end of the case, draft 2B frontal sinusotomy. And here's our patient postoperatively. So you see that trimmed middle turbinate there, increases the coronal diameter, and you'll see a wide open frontal sinus. So endoscopic modified Lothrope, that builds on a draft 2B by doing it essentially bilaterally, and you remove the superior nasal septum and the interfrontal sinus septum. This will give an opening from the lamina to the lamina. So there's two different draft 3 approaches. The traditional one that we probably all learned in residency, if we're doing draft 3s during the time, is the inside-out approach, meaning that you identify at least one frontal sinus or frontal recess and drill from that frontal sinus from inside it towards the midline. A newer approach that was popularized includes what's called the outside-in, where you'll identify the frontal process of the maxilla at the midline and identify your dissection limits early, meaning that laterally your medial orbital wall, the periosteum, the anterior limit meaning your anterior table. Posteriorly, you'll actually identify the cribiform early in the first olfactory villi, and then you'll actually drill straight up the middle, inside the midline of the frontal sinus and out towards the frontal recesses. Either way, this is the goal you want to get again. Endoscopically, you want a big, wide, common frontal sinus cavity, and radiographically, you want an opening from the lamina to the lamina. So here's a patient that was sent to us, a 72-year-old man with recurrent inverted papilloma. You see this nasal endoscopy on the right side showing that inverted papilloma filling the right nasal cavity. We obtained a CT and MRI scan, and as you see on these coronal scans, he has significant disease on the right side, filling his right frontal sinus and extending to his left frontal sinus. That vertical red line there just is marking the mid-pupillary line, which is our theoretical lateral limit of dissection from an endoscopic approach. So in this case, on both sides, we did a bilateral sinus surgery. Here we're on the right side, tracing the inverted papilloma back to the right frontal sinus. So here you see, here we're in the right frontal recess. see the inverted papilloma, we can't really see where the point of origin is. Same thing on the left side, full fess. Now we're in the left frontal recess, seeing the inverted papilloma that's filling the left side frontal sinus. So we will start drilling from one frontal sinus to the other, remove that inner sinus septum and the floor, and now we actually see that inverted papilloma that was on the left side was actually coming from the right side and blowing through the inner sinus septum. So now that we have this low-throw-up exposure, we're going to start debulking the inverted papilloma and try to trace it back to the site of attachment, which is really important. Dr. Woodard talked about this earlier, finding the site attachment to really prevent recurrence. So we actually find it along the posterior table on an area of osteotic bone. So we'll remove that, drill it down, cauterize it, and this is at the end during surgery. And here he is, years out, with a widely open, modified low throat, no recurrence of the inverted papilloma. So here's an example of the outside-in draft 3 of modified low throat. 63-year-old man had prior head trauma, and he had actually a frontal sinus obliteration many years ago. He presented with headache, forehead soft tissue cellulitis. A CT MRI was obtained, showed a mucocele in there, and also osteomyelitis at the frontal bone, which essentially was Pott's puffy tumor. So here we are, again, trimming the middle turbinate anterior and superiorly. We're going to do a superior septectomy. We're going to remove the anterior superior nasal septum to connect the two sides to have our window for working. What we see here is the midline. That's the first olfactory villi that's marking the cribriform plate. We'll use navigation and identify that for a reliable landmark. And now we're drilling the midline frontal beak straight up the middle at the superior septectomy. And once we identify the midline of the frontal sinus, we'll start drilling from the midline towards the left side where you see now it's open up. And once we open the left side, we're going to drill from the midline towards the right side. And what you're seeing here is this really thick inner sinus septum, and you're starting to see that mucopyocele in that right frontal sinus. So as we remove the inner sinus septum down, we'll get more exposure of that right side of mucopyocele, which you can start to see here. We'll continue to widen that area, take a culture, and then saucerize that frontal sinus cavity to make the biggest opening possible. We'll routinely take it to the periosteum of the anterior table, to the skin, and sometimes out of the orbit, just so as landmarks and to make an opening as big as possible. So here we are at the end. And here we are postoperatively, a wide open frontal sinus and no recurrence of his disease. So external frontal sinus procedures, it's still the goal to restore sinus function, minimize tissue destruction, preserve mucosa when possible, and image guidance is very helpful. This is still functional external sinus surgery. So a frontal sinus trephine, it's very helpful for acute complicated frontal sinusitis where the patient's critically ill. You don't have time for a formal sinus surgery, and you really just need to quickly decompress the infection. For really lateral frontal sinus pathology, isolated type 4 cells, or in combination with a draft 2 or 3 endoscopic procedure. Here's an example of a patient getting a right-sided frontal sinus trephine. After drilling through the anterior table, you could either put an endoscope through the frontal sinus from above or below to confirm that you're in the frontal sinus. External frontal ethmoidectomies, there are about 4 different types. I'm just leaving this here for historic perspective, but usually we don't have to really perform these procedures anymore unless we're doing an open skull-based procedure for like a sinus malignancy where we're doing an orbital exoneration or removing any external tissue. That's when probably external frontal ethmoidectomy would come in, and that's when we use it. The workhorse of external frontal sinus surgery would be an osteoplastic flap. And we all know from medical school and as a residents the importance of the layers of the scalp, identifying the TPF fascia and the superficial layer, the deep temporal fascia, in order to protect the frontal branch of the facial nerve. Common indications where we use it are really frontal sinus fractures or extensive skull-based or frontal sinus disease, or sometimes in combination with endoscopic procedures. For the osteoplastic flap, there's three common incisions we talk about. We talk about the bicoronal, we talk about the mid brow, or the gull wing. Let's say the majority of the times when we do this, we'll use a bicoronal. Again, it's important to identify the TPF fascia, the superficial layer of the deep temporal fascia, to protect the frontal branch. So here we see the osteoplastic flap and the plating afterwards. We can form a frontal sinus obliteration if needed during the osteoplastic flap. Usually we would plug the frontal recesses and use abdominal fat. If for sinus tumors or skull-based tumors going intracranially into the brain, where you have to take the posterior table, we will raise a pericranial flap for cranialization of the frontal sinus. So here is an example of a patient who came in with headaches, referred from one of our community ENTs, and with the CT scan, you see that she has this very large frontal sinus osteoma, and it's adherent to both the anterior and posterior table and the superior orbit. And she did have some post-obstructive frontal sinus disease. So in this case, we offered her a draft 3 with the osteoplastic flap. You see her on the picture on the left. This is her with the registration. For those of you who want to use registration for external frontal sinus surgery, this is not really off-label use, but there's been a good paper that has been published that you can put it on the cheek and still use it throughout the case for the endoscopic approach and the external approach. So that's what we did here. Picture on the right is the bicoronal incision marked out. Here you see the bicoronal incision, our osteoplastic flap that we drew out using our navigation system. This is the osteoplastic flap off in the middle, showing the frontal sinus osteoma. The fourth picture is showing the osteoma removed, and then the plating. So at the end of the case, here is the draft 3. That's actually the bicoronal incision. Once we lift it up, you can see that this is the osteoplastic flap before the plating. And here's the patient over a year or 2 out, showing a widely patent frontal sinus, no more disease, and doing well. So in summary, the frontal sinus cell configuration impacts the drainage. A stepwise approach to frontal sinus surgery should be utilized. The draft 3 or endoscopic modified lithotrope is the maximal endoscopic frontal approach that we have. Open external frontal sinus surgery should be considered and is still utilized today for pathology not amenable to endoscopic approaches, either by itself or in combination. I want to acknowledge my colleague Jonathan Liang for collaborating on this talk. So I want to thank my wife, Dr. Helen Wakova. She may be here in the room today. She's one of our neurotologists, and you won't be here speaking tomorrow because she's currently almost 39 weeks pregnant. So, but she's here to support us, so I think she's back in the room right now. And that's it. Any questions? Yeah, yes, sir. That really good question. I do routinely use the. So the question was, am I often routinely using stents, and specifically the Propel stents? I think the Propel stents are an excellent device. I started using them when the Propel stent came out. That's the smaller one. That's a perfect fit for the frontal sinus. The Propel Mini is a bigger stent. I use that for the modified lithotrope. I think it's really good. It gives mometasone. It's really good for the post-op sneaky eye. And the good thing is that you don't really have to remove if you don't. One of the things we found with the Propel stent in the past, when we used to put in the middle meatus when it first came out, it crusted a lot. But in the frontal sinus, for whatever reason, it doesn't crust as much. And so I think it's wonderful. Before that, I used to cut silastic stents and then put dissolvable gauze in there and put some Kenalog. I found that cutting the stents were harder, and these Propel stents are just much more user-friendly. And I've definitely switched my practice to that in the last several years. So I do suction them out at the 1-month visit if there's anything left, but a lot of times there are patients that are irrigating, they kind of fall apart into that kind of fishbone stuff, but like very rarely do I see it there after a month where it's one piece, but I will suction it out if there's any left at that 1-month visit. Any other questions? Great. Okay, Dr. Woodward will be back up, and he's going to talk about management of CSF leaks.
Is this the? I think so. There we go. I got it. All right. I know you guys are, and ladies are tired of hearing from me, so I'm almost done, okay? How do I press yes to this? Let's try this. Disconnect you for 1 second. Okay. Yes. Okay, there we go. There we go. All right, so today we're going to talk about spontaneous cerebral spinal fluid repair. These are my disclosures. Throughout today's discussion, we're going to learn about the physiology and pathophysiology associated with CSF leaks. We're going to learn how to diagnose them and some management strategies. So let's talk about the normal physiology. CSF is produced 70% by choroid plexus. The remaining amount is actually produced from interstitial and intracellular fluids. We make about 500 cc's a day, but it's a constant turnover. And at any one time, we have about 140 cc's within our central nervous system. Normal pressures range anywhere from like 5 to 15. At our institution, we think anything 20 and below is considered normal. And that varies constantly, depending on if you're sleeping, sneezing, laughing, any type of like strenuous activity or Valsalva maneuver. The pressure is maintained constantly by a balance between secreting it and absorbing it. And so it's a steady state. Usually when people have high pressures, there's some kind of issue in the absorption. It's largely absorbed into the venous system at the arachnoid granulations, a pressure-dependent flow. Now, for someone to present to our office with a CSF leak, it actually has to go through several layers. So it has to have several layers of failure, right? If you think about it, we have the arachnoid and dura mater that surround our brain and, hold the fluid inside. Then we have the bone of the skull base, and then we have the mucosa of the sinonasal cavities. So in order for it to actually get out of our bodies into, the environment, it has to go through all 3 layers. Now, usually when someone presents with rhinorrhea, there's a defect in the anterior skull base. However, I've seen on a few occasions where there was actually a defect in the lateral temporal bone. It went down the patient's eustachian tube and then came out the nose. There are a lot of different etiologies. There's traumatic, there's etiologies from tumors, congenital etiologies, but today we'll really be focusing on spontaneous CSF leaks. Spontaneous really means that there's no other discernible etiology. You need to rule out some of the other etiologies first. And it's actually increasing in prevalence. Most commonly, it's found in middle-aged obese women. Historically, we thought that most people have normal ICPs, but we've really come to realize that a lot of times when a patient presents with spontaneous CSF leaks, they actually have elevated intracranial pressures. There's also studies that demonstrate a high rate of either having an empty sella or partially empty sella, usually diagnosed on the MRI. Now, what's the pathophysiology? So there's pulsatile forces that actually push and push and push on the brain, and we know from our previous discussions how thin the skull base could be. And over a period of time, it just erodes away that bony material and then erupts and you have a leak. Erosions are common at the cribriform plate and the lateral recess of the sphenoid. There's usually focal atrophy in the olfactory villi, and that kind of creates potential spaces of where the CSF can go. So it's been postulated, and I sort of mentioned this earlier, that CSF leaks really represents a variant of benign intracranial hypertension. Studies demonstrate up to 72% of CSF leaks are found in patients fit to be considered having benign intracranial hypertension. What are the symptoms associated with that? Well, many patients have headaches, pulsatile tinnitus, hypertension, balance problems, visual complaints. Spontaneous CSF leaks are strongly associated, as I mentioned, empty sella syndrome. So if you see that, or if you see a report of a patient that has that, consider that they likely have benign intracranial hypertension. So the patient comes to your office, is leaking all over the place. You've ruled out non-allergic rhinitis, right? We've learned all about that today. And so what you have to do is figure out, is this a CSF leak? First thing is, confirm that it's a CSF. So what tests do we have at our disposal? Traditionally, some people used to use glucose quantification. If you have over 30 milligrams of glucose in the solution, then you could ascertain or assume that it's CSF. However, it's only correct in about 88% of the cases. What about glucose oxidase test strips? You should not use those. Why? Because the mucus in our nose or lacrimal gland secretions actually have reducing substances that can inadvertently cause a positive reaction. So it gives you a high false positive rate. Beta-2 transferrin protein test is really what we consider the gold standard, is used at most places. The advantages are that it's high sensitivity, specific for CSF. Now, there are other fluids that are in our body that have this, ocular fluids and perilymph, but those are the only ones, all right? The disadvantages, most locations still have to send that out for outside lab analysis. So it takes a little while for you to get the results. Also, it's really important to handle it properly. So we usually tell our patients, okay, we give them a test tube, we give them an ice pack, tell them stick the ice pack in the freezer. When you leak, we usually say around 1 cc is enough. And then we say, okay, you need to chill it until you can get it back to the hospital lab. Do not freeze it, and you can only keep it in the refrigerator for 3 days. We have them use that ice pack. They stick it in a little bag when they're transporting the liquid, so that way it won't evaporate. There's also beta trace protein. A lot of times that's used over in Europe. It's the second most abundant protein in the CSF after albumin, produced by the meninges and choroid plexus, found in nasal secretions and in low concentrations in the serum. So once you confirm that you have a CSF leak, the next step is to localize where it is. So there's a lot of different imaging that you can use: high resolution CT, CT cysternograms, MRIs, radionuclide cysternography, and intrathecal fluorescein. So let's start with CTs. We know CTs are good choices. They really delineate the bony anatomy of a person. Usually 1 millimeter cuts are very good in helping you really scroll through the skull base to look for dehiscences. They help you localize the defect. Now the disadvantages, CT scans can't really differentiate between liquid and tissues. Well, I guess liquid you can because of the T2, but soft tissues from like the brain or the meninges versus polyps or turbinate, it won't really be able to differentiate between those two things. You can tell if a person has a bony defect, but just because they have a dehiscence doesn't mean they're leaking. CT cystoscopy comes into play, and it helps you really locate the exact point or spot on a scan where the leak is. So you inject intrathecal contrast, and at our institution, they kind of make the patient move around, jump up and down, do whatever they do to cause them to leak. Then they will do the CT scan. Again, it's a CT scan, so it provides excellent bony detail. Because they have the intrathecal contrast, it's going to exit the intracranial cavity at the point of the dehiscence, and you will see it in the nose. In this case, the patient has a large ethmoid fovea defect, and you see all of the dye here in the ethmoid cavity. Disadvantages, though, is that the patient has to undergo a lumbar puncture and injection of the contrast. They can have headache, nausea, arachnoiditis. Another disadvantage is this only works if they're actively leaking. MR cystoscopy are also increasingly being done. Advantages. Now, MRs, we know, give more soft tissue detail compared to a CT scan. So you'll be able to distinguish between CSF, brain, tumors, mucus, polyps, etc. The disadvantages is it does not provide bony detail. It's more time consuming and more costly. Radionuclide tracers. Now, haven't done this in a long time. I did it in residency, been at the Cleveland Clinic 15 years, probably the first 5 years we used to do this, but this has kind of fallen out of favor. Again, lumbar puncture, inject the intrathecal tracer, wait a while, you have the patient, you sort of pack their nose with different types of pledgets, you wait, you take them out and you use a Geiger counter to see if any of them kind of light up. The advantages is that you can identify the side of the leak. The disadvantages, you don't really know the exact location, right? They have to have an invasive procedure, and there's a high false positive of 33%. Intrathecal fluorescein. Now, we use this quite often. Normally, by the time we use this, we know the location of the leak. I like to use fluorescein to help me know if I've plugged the leak, okay? So fluorescein, and it's kind of interesting because on the bottle, it says for not for use intrathecally. And so, you know, because in high doses, it can cause neurotoxicity. So we have a special consent where we go over all the risks and benefits of intrathecal fluorescein with the patient, tell them that we're going to use a very dilute amount, 0.1 cc of a 10% solution. So basically, 0.1 cc of the fluorescein dye, and then we take 10 cc's of the patient's CSF, mix it together, and then slowly inject it. We inject about 1 cc a minute through the lumbar puncture. All right, and once we do that, we place the patient in Trendelenburg, wait a while, operate, trying to expose the skull base, the area of the leak, and look for the fluorescent green dye. Advantages, you know exactly where the leak is by looking at the dye. You also know when you've plugged the leak because you don't see any more dye. Disadvantages, as I mentioned, you must expose the skull base and have precise identification. It's an invasive procedure, and high doses have been associated with seizures and neurotoxicity. All right, so we went over how to confirm that you have a leak, localize the leak. Next, you got to plug the hole. You got to stop it. All right, so let's talk about different surgical managements. Depending on where the leak is, you know, depends on the route or determines the route you take. So there's a lot of different ways to skin a cat. So there is the direct periseptal approach where you're dissecting along the septum up directly at the cribriform plate. The good thing about this is that you have direct access to the cribriform, but you do not have to dissect the ethmoids out. When I tried to repair these, you know, initially I tried to keep the middle turbinate in place, but oftentimes it's so narrow, I go ahead and remove the middle turbinate, That gives me more room to move my instruments, to lay the graft flat, to put something on top. It's just not as cramped. This lesion can also be extended and to allow you to go along the septum into the sphenoid. All right. If you have lesions in the sphenoid, you can just take down the septum in between and then just directly approach the skull base dehiscence. No need for ethmoidectomy in this case. This is a patient who presented, she was a young female who came with just copious amounts of CSF. We got the scan and we saw, basically it looks like the whole, skull base is just gone, right? So much brain tissue and, fluid filling the ethmoid cavity. We got, because of the large defect, we got a MRI to confirm. This is what her endoscopic exam looked like. So you can see a lot of just, some of that is spray, but it's just a lot of fluid in her nose. There you go. You can see the pulsations of the large meningoencephalocele in the ethmoid cavity. Now, unlike the first approach that I showed you, this will require you to really dissect the ethmoid cavity. So the transethmoid approach. The benefits of this is that you can have good access to the ethmoid fovea or the ethmoid roof. You have to do an ethmoidectomy though to clear out all the bony partitions. Some people do it with or without a maxillary antrostomy. I always do a maxillary antrostomy because it helps me keep my landmarks consistent, right? The maxillary roof is also in line with the sphenoid sinus, so that's where I know my orientation, how far up I am. Also, one benefit of having the maxillary antrostomy done is it sort of acts as a reservoir. So if you have bleeding or a lot of irrigation, etc., it kind of can get out your way by going into the maxillary sinus. So in this particular patient, what I did was remove the encephalocele, either with a coblator or bipolar cautery. It's important to skeletonize the skull base. You have to expose about 3 to 4 millimeters of bare bone. So if you see here, we cauterized and removed the lining, the meninges and brain tissue, exposed this bone, and it's a pretty large defect. So you have to decide if you're going to use just an overlay, an underlay, a multi-layer. And because of its size, we actually decided to use a multi-layer, all right? So when what makes us decide which type of closure to do? So just for overlays, we usually do those for smaller defects, about 6 millimeters and less. You can use anything from mucosa, either vascularized pedicle flap or a free mucosal graft. Usually for small defects, I'll use a free mucosal graft. You can also use fascia. Underlays we usually place in the epidural space and use them in larger defects like this one. You can use really a combination of different things. When we had this case, we use Alloderm. Now we use other dural substitutes that I think really don't crust as much and really sort of grow into the person's dura, like dura repair or dura matrix, fat or fascia. Even though I have fat here, I rarely ever use fat because oftentimes over a period of time it sort of degenerates and leaves a space. Sometimes it gets infected, and that's the last thing you want in this type of scenario. You have to remember though, no matter which type of mucosal graft you use, make sure that the mucosa is facing the inside of the nose because it's going to continually secrete mucus and you don't want a mucocele to form intracranially. So how do you make sure that the mucosa is facing inside the nose? We usually get a marker, and here you can see I mark the mucosal side because after a while it's hard to determine which side is which. So as soon as you harvest your graft, if you mark it with a pen, you'll never forget which side is the mucosal graft. In this case, I actually used inferior turbinate. I removed the inferior turbinate, skeletonized it, and it provided a large, robust, and thick free graft. She did fine. You could have also used a localized pedicle graft, like a nasal septal flap. The nasal septal flap is considered the workhorse of skull base surgery. Basically, let's see here. You have your branch off of the sphenopalatine artery. It's the posterior septal artery. It runs underneath your sphenoid sinus and onto the septum, and it feeds the tissue of the septum. You can harvest this graft. Really, you outline the area that you need, and you elevate it like you're elevating a septoplasty, and then you just kind of rotate it. It can be rotated superiorly along the skull base, posteriorly along the clivus and up around the sella, even inferiorly along the clivus. It's really considered the workhorse. This is just a video that illustrates how we harvest. Sphenoid sinus here, remember the vessel runs under the sphenoid sinus. So we get a needle cautery and start making our superior cuts. It's important to not go straight up, but come anteriorly at an angle. That way you don't just go straight up and enter the skull base and cause a CSF leak. So we come anterior to our inferior turbinate, then we start making our inferior cuts. You start at the choana and come down at an angle. And we go down on the floor. Depending on your defect, you can extend this all the way under the inferior turbinate if you want. We're bringing our cuts anteriorly, and we're going to join this to the superior cut. Once you have it outlined, then we use a freer or a caudal to elevate the graft. Apologize if you can't see it. It's kind of dark. It looks better on the computer screen, though. Again, so you start to elevate it off of the cartilaginous portion of the septum like you do a septoplasty. We're just elevating it, freeing it up. Takes a little while, and you have to be careful because you don't want to cause your flap to rip. So we're separating along the superior incision. Sometimes you have to go, but you realize, oh, I didn't really make a good incision there, so you have to go back again. So once it's free, you can tuck it in we usually tuck it in the nasopharynx until we need it to, we'll tuck it in the nasopharynx, remove whatever tumor we're doing, and then once we're ready for it, we'll lay it over the defect. All right. There's also the transpterygoid approach. Now, this approach is needed when you are attacking encephalocele or defects that are in the lateral recess of the sphenoid sinus. So, sphenoid sinus is here. The defect is in the far lateral portion of the sphenoid sinus. We got an MRI, and you can actually see that there is some herniation of temporal lobe into the sphenoid sinus. Usually, again, all the tissue that's herniated is non-functional brain. And so you can just coblate that or bipolar that without any consequence to the person. Now, in order to get to that far lateral reach, we usually do a total ethmoidectomy, a really wide maxillary antrostomy, a wide sphenoidotomy, and then we remove the posterior wall of the maxillary sinus, enter the pterygopalatine fossa, try to avoid the internal max artery, and the other vessels, the other nerves, and you drill down the pterygoid plates. This is an illustration of how we approached this patient with a lateral recess meningocele. We do a maxillary antrostomy, make a real wide opening. We then go to our sphenoid, begin to widen it laterally. You can kind of see with a 30-degree angle scope, you can see the beginnings of the lateral recess and the meningocele. It's sort of like you're joining the two together. Wide, huge maxillary antrostomy, huge sphenoid, and now you have to remove the the bone in the middle. So we start to remove the posterior maxillary wall with a Kerrison punch. We ablate all the periosteum with either a coblator or a suction bovie. And I don't like to even see the vessels. So what I do is cauterize and push everything laterally. I get it out my way because I think it's safer. If you can dissect and just push all the contents of the pterygopalatine fossa more laterally, then you won't injure the IMAX. So this shows us reducing the encephalocele with a coblator. And there we go. There's our bony defect. And again, place free mucosal grafts. I think they work better, especially far laterally, as opposed to rotating your nasal septal flap over in here. We lay it, and then we put, top it off. This is that Adherus spray glue that's motorized, and it's a malleable shaft, so you can kind of point it in all different places. Okay. So, now let's talk about like the post-operative management, right? So people who have high intracranial pressures are more likely to develop recurrent leaks, all right? Now, how do you manage someone post-operatively? Well, people do different things, but at our institution, we go based off of their intracranial pressure management. Now, you heard me say a lot of times that we'll either inject with intrathecal fluorescein or get a CT cisternogram. Well, while we're doing that, we also measure the intracranial pressures. If the pressures are less than 20, then we consider that normal, and they're at a low risk of a recurrence. And so we still will do a repeat LP in about 4 to 6 weeks, all right? If the pressures are 20 to 30, we consider that intermediate. And so after the surgery, we'll place them on Diamox for about 4 weeks, and then have them go off for 2 weeks, and then get a repeat LP and check pressures. If it's greater than 30, then they're high risk of a recurrence. And after our repair, we refer them for a shunt. So let's say 6 weeks have passed, 4 to 6 weeks have passed, and now they need to get their repeat LP. If it's less than 20, they're a low risk, nothing else to do. If it is 20 to 30, they're intermediate. So we have that patient actually follow up routinely with ophthalmology to do fundoscopic exams to see if, that's a less invasive way to see if they have high intracranial pressures. And if it's greater than 30, then we consider them a high risk and send them off to get a VP shunt. We also tell them it's important to avoid, at least immediately postoperatively, things that are going to increase their intracranial pressure. So we give them stool softeners, tell them no push and pull and strenuous activity for a month. We have them follow up every 2 weeks or so to do gentle debridements down low. We start them off with saline mist, and after about 2 weeks, they go to irrigations. So that's really about it. In conclusion, spontaneous CSF leaks represent a variant of benign intracranial hypertension. Careful preoperative evaluation and localization will help aid you in selecting the appropriate technique for repair. In addition to sound endoscopic closure, treatment of the underlying intracranial hypertension is imperative to having excellent outcomes. And so remember, how we manage the underlying hypertension is based off of the pressures of that LP, right? So if it's low, then it's nothing to do. If it's intermediate, then we follow them up and then either get an endoscopic fundoscopy or fundoscopic exam, or if it's high, they go get a shunt. Or if it's immediately, we see it as the pressure's off the chain, off the roof, we just refer them straight to get a shunt immediately post fixing their CSF leak. And that's it. Thank you. Any questions? Okay. Yes.
I don't know if we missed in the slide, but when you're using the fluorescein dye afterwards, do you keep that lumbar drain to clear that fluorescein dye afterwards, and with CSF diversion for a few days?
Yeah, I think you're right. I think I accidentally went past it. But so when we put in the lumbar drain, fix the leak, we usually drain them 10 cc's an hour for about 24 hours. And then after that, we will clamp the drain and watch them for another 24. If they don't leak, then we pull the drain and then go home.
All right, last talk of the session as well as of the day. Thank you all for your patience and your energy, which I'm sure is decreasing as we speak. But I do feel like this talk is kind of the culmination of a lot of speakers' talks throughout the day, including Chris Holsinger's talk on AI, Troy's excellent talk on complications, as well as our talks in technology. Oops. There we go. So this talk will be pretty short. It'll be about 30 minutes. I don't want to keep you from the evening entertainment tonight, but I do want to talk to you about how we are using technology to train better surgeons, including our residents, and some of the tools that I wish I had when I was a resident. These are my disclosures. So we'll outline current methods of teaching, particularly in sinus and skull-base surgery. I'll use transsphenoid approaches as an example. So many of you out there in the community might be interested in learning about transsphenoid approaches when you're working with some of the neurosurgeons for pituitary adenomas. We'll talk about areas where we're getting squeezed and pushed in terms of our training, how to convert our two-dimensional images to three-dimensional images so that we can learn about spatial anatomy and orientation, foundations for safer surgery, how we can get better feedback, and then how we can avoid complications rather than just fix them, although now we know how to fix them, but hopefully we never get them to begin with. So as Troy had mentioned, sinus and skull-base surgery can be very difficult, and although complications can be exceedingly rare, thank goodness, when they do happen, they can be pretty devastating. These are some pictures of of patients who unfortunately had surgeons that just got lost in the sinus cavity, and they thought they were in the sinus, but they were in the orbital cavity, or they were in the cranial cavity. And although rare, these patients did have very challenging complications. The first patient up on the corner actually had gone blind, and then the second patient actually expired a couple of days later. So fortunately, this is rare, but how do we prevent this? Well, surgical experience as well as technical expertise is going to be really critical for patient surgery. And although a lot of our residents might joke that Chris and I just do the same surgery over and over and over again, I don't think that's true. I think every patient is unique. So we really need to study up on why we're doing the surgery as well as their anatomy. So how do we traditionally train people? Well, we read textbooks, right? So we read Cummings, we read atlases, we read or we listen to lectures such as the ones given today. We go into the operating room and there's a gradation of experience. So you might observe as a medical student. As a resident, you might learn how to close. You might learn how to do the steps of the procedure. And then you go back home and you process this, you learn, and you repeat this. And this is where areas of feedback are really important, because you want to get better each and every time you do the surgery. Unfortunately, the days of getting to do a surgery 10 times in a row or 10,000 times to become experts is dwindling. And why is this? We talked about the 80-hour work week or the 37-hour work week in Europe. Also, I think that we get really more difficult cases at our tertiary institution. And so it's challenging to have trainees learn on these really hard cases when they might even be very difficult and challenging for us. And then there's also a lack of continuity. And so you might not see this patient and work them up, take them to the operating room, see them afterwards, and then potentially have to look for complications. And that continuity of care is really important. And as my first year as an attending, it's something that I recognize, wow, this is something that's deficient in our training. Technology can be our friend, but sometimes it can be our enemy as well too. And what do I mean by that? Well, the more resolution or the higher resolution of scans that we get, we know that that's important, but we also know that that's a whole lot of images that we then have to process. So typically, for our surgeries, we're looking at over 400 images in 3 different planes. And so now our head is a computer, and we have to learn how to visualize this in real time. Troy had talked about that close algorithm, and it's one that we commonly use. But it is still a huge monumental task to be able to visualize this in 3 dimensions. So how can we do better? Well, this is Eric Bailey. He was one of our fellows, and this is something that I started to do as a resident many years ago, and I see a lot of our residents doing as well, is we watch videos. It's a different format, but for our types of surgeries, which is endoscopic surgery, videos are so critical because you can see people doing what they are performing in real time, and you can kind of almost grade them and try and be in their shoes, especially with endoscopic sinus surgery because we're all looking at the same monitor. The problem is that not all the videos out there are very good, and so how do we do this? How do we narrate these videos? How do we get them on a educational basis? And so Eric actually developed a video along with a couple of students from our school where our goal was to take these 2-dimensional CT images, help them to train medical students as well as very junior residents so that they knew where they were on CT scan, but then we also overlaid these with surgical images. So one of our co-residents actually overlaid this with Adobe Photoshop so that way you could see not only things in 2D, but also in 3D. We can also bring this patient anatomy to life. So using relatively inexpensive or free commercial software, we can actually segment these. And what I mean by that is we can take the CT scans, we can highlight them using imaging software, and then we can create this in a Unity 3D game engine where you can bring nasal endoscopy to life. So that way those areas where you segmented and you structured can actually be visualized. 3D printing is incredibly inexpensive nowadays. We do have a Formlabs printer in our residence lab. I think now that Sam's not here, it's probably not getting used as much. But it is a resin-based printer that has 0.5 millimeter accuracy, and then we've also got a silicone mold. So we're very fortunate at the University of Arizona. We've got an excellent simulation training center run by Drs. Hamilton and David Biffar, and so this is somewhere where residents can learn and train on how to do these procedures. Finally, we've got an excellent engineering team. So these are some of my partners in developing the first iteration of our VR simulator. Sam Barber was one of our residents, now is a neurotology fellow and coming back as an attending at Barrows next year, who had a really strong engineering background in VR imaging. And he helped us partner with our engineers just across the street, Dr. San and Dr. Jain, who helped us develop this technology for simulation. Why simulation? Well, this is where people can practice to do these surgeries without risk to patients. And so in order to do this, we divided our procedures into tasks and subtasks based on motions. So little do you know, but all of our motions are being captured, and it doesn't really require an OR black box in the OR. With our navigation machines, all of these are captured in 3D real time. And what we did was we looked at the time taken for all of these surgical procedures for both residents, trainees, and novice medical students, as well as experts. So we were able to use artificial intelligence based on a very narrow subset of 24 novices and 24 experts to look at proficiency. And what we did was, and what we were very surprised with is that computer algorithms were able to detect who was an expert versus who was a novice with over 80% accuracy. But what I had mentioned in Chris's talk is that no AI algorithm is very good without sufficient data. And so in order to provide a foundation for education, it can't just be, this is how I do it, follow me. It really has to be, this is why I do it, and this is what can happen if we don't do it this way. And a really comprehensive understanding of that is going to be incredibly important. So Shireen, who was our fellow last year, put on the task of doing what's called a Sherpa analysis or an HTA analysis. This has been used in really high-risk scenarios, such as like flying an airplane, right? Very low chance of a complication, but you never want that to happen. So how do you train people to do this? Well, you outline all the specific steps, you have sub-steps, and then you want to train people on what to look for and have checklists. The closed checklist is a phenomenal first step, but we want to have a more detailed step on how to do this. So what Shireen did was she divided the transsphenoid surgeries, and these are all available online as well, and I'm happy to share this if you are new to this procedure and you want to learn how to do it. She divided this procedure into 3 different phases, including nasal access and exposure, tumor resection, and she validated this with Chris Lay, who's one of our prominent endoscopic skull-based surgeons, as well as Dr. Mike Avery, who's our neurosurgeon. So not only did they give you the steps, but they also told you why they were important. So what happens if you take too much septum? What happens if you take too much tissue? Why don't we want to strip mucosa? And I think this is what's lacking in some of our education, because if residents are watching me do things and they're hopefully seeing me do it correctly, they might not understand why I'm doing it. I think feedback's really important as well too. How do we provide feedback? One of these could be more detailed checklists, and this is something that we've been implementing in our transsphenoid approaches. Something really simple. Did you do it well? Did you not do it well? What can you improve on? And then we also developed a ordinal grading scale on how well trainees did. And I think this is probably going to be more beneficial than our standard residency grading scales of 0 to 5 on are they good or are they not good. If we can really define what they're good at and what they're not good at, it helps them with their training. So at this time, I'd like to introduce David Amadian, who's our medical student, who's now taking a research year between his 3rd and 4th years. It's been a pleasure working with him, as well as Jason Zhang, who's one of our engineering students who graduated actually this year, graduated early in fact, and has been working with me in the lab. And what they'll do is they'll talk to you about some of our VR simulation, and we'll give you a little bit of a demo. So let me introduce our VR simulator at this point. David has been doing that clinical segmentation and processing. So we've actually got de-identified patient images so that we can then use these for skull base and sinus training. Jason takes these de-identified images, implements them in a Unity 3D game engine, which is a common game engine for, like, let's say, first-person shooters or any VR games that you might be used to. And then Jerzy Rosenblatt is one of our engineers. He's one of our new members of the team. And he's actually looking at what's called cast hardware implementation. So within our simulator, there's actually a hardware component. You won't see that today, but a hardware component where you can use these instruments and it will guide you to where you should go for surgery. So we talked a little bit about surgical automation. So if you are completely new to this, imagine, let's say you're playing violin for the first time. You know, you can say, well, you hold your bow this way, you hold your violin this way and play. But imagine if you could take that and then you have, like, Itzhak Perlman's motion superimposed, so you're playing like Itzhak at that same time. So what that does is it provides muscle memory, it provides training, and as Chris had mentioned in terms of those 10,000 images or those 10,000 steps that Erickson has mentioned, it provides you those 10,000 motions the right way rather than the wrong way. And I think that's a faster way to be able to learn. So what were our goals with this? It was to improve 2D to 3D localization. It was to help in identifying and practicing the steps of surgery and to understand the purpose as well as the potential complications. And in the future, again, this is one iteration that we're using right now, but in the future we'll use that cast trainer to utilize haptic feedback. So I'm going to introduce Jason here. Jason will actually plug our HDMI into this. Just so I can plug it into the HDMI. Oh yeah. Doesn't matter if I don't. But there it is. Here's the HDMI cable. Do you need sound as well?
I think it's good. It doesn't really matter. Alrighty. So hey guys, thank you for Dr. Chang for introducing us. Again, my name is Jason. I am a recent graduate from University of Arizona. David Ahmadian is a medical student at the University of Arizona. So we're going to be showcasing the first couple of steps of our VR case-based simulator. And as Dr. Chan has been stating, the purpose of this, this VR simulator is to create an active learning environment that guides trainees through the steps of a surgery, while also teaching them the anatomical structures and providing the clinical correlations as well. So for this case, you can see that we are going to be talking, this case is going to be an endoscopic endonasal approach for the resection of a pituitary adenoma. Since David already knows, the nitty-gritty of the program, we won't be performing the tutorial, so he'll hit no. And then if, David, you could look up just a tiny bit. Okay, great. So this is going to be like an overview of the case. So it provides the history, and once David is finished reading it, I'm not going to read it out loud, but once he's finished reading, we can continue along with the task. All right, so now we are actually transported to the outside of the nasal cavity. So nothing really interesting here, but so we can enter into the nasal cavity as David is going through. And you can see the point of view of what David is looking at is the endoscopic point of view. And so for like the first task, it is to lateralize the left inferior turbinate using the Freer elevator tool. But let's take a step back before we actually perform this task. Let's give like a what if scenario. What if David was looking around and seeing like, hey, what is the structure? What is the left inferior turbinate? Well, we built like a feature where David could use his left
left controller and press the Y button and kind of point at any structure, and this will actually print out the structure's name right in front of us. And then it's not only just the left inferior turbinate, just the nasal septum, it's just any structure that's available. In addition, it's also very important to connect the 2D information visualized from CT scans to the 3D spatial orientation visualized from the actual surgical procedure. So what we've built is that if you use the right controller and if you were to click the B button, 3 CT images will actually pop up. Here it is highlighted the inferior turbinate, and along with on the bottom left we can see that it is also pointing at the 3D inferior turbinate in the model. And so now that David has like a general encompassing like understanding of what kind of structures are kind of around him and where he is spatially oriented within the nasal cavity, he can close the CT imaging, and now we can actually begin with the task. As I mentioned before, we can see that it requires a Fourier elevator tool to actually perform this task. So what David could do right now is bring up the surgical tools menu. So he could use the X button on his left controller and actually select the Fourier tool. And as you can see, once the tool is actively inside of his hand, there's like a simple slider that actually appears. And this slider actually kind of allows David to mimic the motion of lateralizing the turbinate. If David tries it out, he can actually start moving the turbinates. And it's also important to note that the next task won't appear until he completely lateralizes this turbinate. And this kind of goes back to what Dr. Chang was been saying about the active learning process. You see David's actually performing the task himself. It kind of adds like an extra layer of learning, and instead of just reading like a textbook. We see now is that there's like a question that appears. We actually have several of these type of questions implemented throughout the module, and it kind of ties into like the clinical correlations, going in detail about the purpose of that particular step or the potential complications. And so, David, no pressure, we can actually see if he actually gets this correctly, and yes, he gets it correctly with the nasal adhesions. So now we can begin and continue on to the next step, which is advancing to the middle turbinates. And advancing to the middle turbinates, the next step involves lateralizing the left middle turbinate. Now, this is really similar to what we were just doing with the inferior turbinates. And so, if again, David isn't sure what structures he's looking at, or if he wants to look at the CT images, he can if you want to. It gives him the freedom as well. And so now David can actually lateralize the left middle turbinates. And now the next step is to advance to the superior turbinate. However, due to time's sakes, we actually are going to end it here. But the first 2 steps really encompasses like what we've been actually talking about like previously. So I'm going to like kind of close and give like a conclusion per se. So in conclusion, based on the features that we've actually implemented, a trainee is able to identify and learn the anatomical structures while also being able to connect back to the CT images. Second, they are able to learn about the clinical correlations by looking in details about the purpose and the potential complications of that particular step. And lastly, David and trainees are able to perform tasks, actively learning through these tasks by mimicking the motions of any sort of surgical procedures as well. And yeah, that concludes our demo, and thank you for listening. Yeah.
Hey guys, that was fantastic. What a way to end the day. We'd love to take some questions. Again, I wish I had this when I was a resident. But if any of you guys want to come up and try it, you're more than welcome to. Otherwise, if we don't have any questions, we're also happy to meet you at the evening reception.
I hate to keep us from the reception, but
I'm Chris Holsinger. I haven't done sinus surgery in 10 years since I left Houston, but can you use the instrument tracking for navigation as a means to describe surgical efficiency?
Absolutely. So that's what we did with the AI VR simulator. We created objects that were collision objects, and then we looked at path analysis. So what we found were that novices would like kind of float around in the nasal sill and the nasal opening quite a bit, whereas experts were much more directed. And that's obvious, right? But to be able to quantify that, I think, is incredibly important. We were talking that everything is recorded for us as rhinologists in the operating room, and we don't know it, but all of our XYZ coordinates are being coordinated: pitch, yaw, speed. And that's a huge advantage that we just haven't been able to unlock yet. But hopefully we'll be able to partner with some navigation companies in the future to be able to take some of this data. I also think, I'm a huge proponent in really specific feedback. Our residents know this as well too, but in the future it'll probably end up being that you do a portion of the procedure, you hit a QR code on your phone, and then right then the attending says, hey, you did this, this, and this correctly, but not this. Or maybe it's automated with your AI algorithms. And so that's how we get to be better, quicker, with fewer number of cases, and more objectively rather than less emotionally, I would say.
Well, that's transformative. I thought that was a really carefully designed, bespoke Chang Lab innovation. But to use the standard of care, that's spectacular. Yeah, congratulations. Look forward to seeing that in the future.
Thank you. Yes, sir. In boards, yeah, that's a great question. So when we first did this as a demo, the former president of the AAO actually was really interested in this and thought, hey, this would be a good skills assessment lab training. Instead of asking questions where it's more verbal language, where do people screw up in practice, right? It's not necessarily the knowledge, but it's maybe translating that knowledge to physical ability. One example, in Arizona, you actually don't need to get your license renewed for, I think like 25 years. And so we have like 75-year-old people, 80-year-old, 90-year-old people who have not had their license renewed, who are physically smart, cognitively smart, but maybe the physical motions of driving are challenging. So I don't know where I'm going with this, but
Well,
in terms of the skills assessment, being able to translate that into motion, I think is going to be important.
And if I could, so the board, American Board of Otolaryngology, I'm sometimes a guest examiner. Starting next month, new diplomate candidates will track their cases monthly, and at the end of this test period, external examiners will review them on data accumulated from their cases in their own practice out there in their first year, and they'll be examined on that rather than artificial simulated questions that no one can ever figure out what the heck the examiner is asking. And it paves the way for exactly what you're asking. Yeah.
Thank you, everybody.
Thank you so much. Thank you.